think we can squeeze anybody else in here. I think we're at that point right now. So the Rules Committee will come to order. Good morning, everybody, and I want to welcome our witnesses to the Rules Committee. Thank you so much for being here. Before I give my opening statement, I'd like to outline kind of the time agreements that we reached before the majority, between the majority and the minority on this committee for the purposes of this hearing. So you'll kind of get in the Rules Committee, we have no rules. So, but today we're going to have rules today a little bit. So, you know, while the Rules Committee, while the rules of our committee provide members with 5 minutes to ask questions of the witnesses, that rule has not been followed for as long as I can ever remember. So I believe we reached a fair agreement with our minority that respects the time of our expert witnesses and provides members of this committee with ample time to ask questions. So under the agreement, the chair and ranking member will provide an opening statement around 5 minutes. If other members of the committee have opening remarks, we ask that you submit them, those statements for the record. Each witness will then have 5 minutes to provide an opening statement. If you go over a little bit, fine, but if you see that red light on, I mean, try to wind it up. After the committee receives testimony from our witnesses, each member of the committee will have about 15 minutes to ask questions of the witnesses. And if a member has a question for Mr. Barkin, please ask him your question at the beginning of your time, and then proceed with your questions for the other witnesses to give Mr. Barkin some time to type his responses. Please be sure to leave some time at the end of your questioning for his responses. The chair and ranking member will have an additional 15 minutes to provide comments throughout the hearing or to provide additional time to members during questioning. The minority's additional time must be used before the majority's last member begins his or her questioning. The chair and ranking member will have about 5 minutes to close, and the chair will close after the ranking member offers his very, I'm sure, eloquent closing remarks. I want to thank Ranking Member Cole for his assistance in reaching this agreement, and I thank all of our members, both Democratic and Republican, for participation in this hearing. And before I begin, I just want to acknowledge some people here in the audience. You saw Speaker Pelosi was here a little bit earlier. We appreciate her coming by. And we have Congresswoman Katie Porter is here from California. We are grateful that she is here in the audience. In addition, we have Amira Sequeira from the National Nurses United, Jean Ross from the National Nurses United, Nicole Jorwick from the Consortium of Citizens with Disabilities, Christy Fogel with the Maryland Progressive Healthcare Coalition, Robert Craig with People's Action, Savannah Lyons with People's Action, Rebecca Wood and her daughter Charlie. They're here. There they are, over there. Charlie was born prematurely, and before the age of 3, she had suffered through more therapies and injections than most experience in a lifetime. And as the expenses piled up, Rebecca and her family faced tough choices regarding Charlie's treatment, which highlight the need for adequate long-term care in this country. Jennifer Epps Addison, sitting behind Adi, from the Center for Popular Democracy. Nate Smith, Adi's lifelong friend and caretaker. Liz Jaff, the president of Be a Hero, which is Adi's organization. Elazar Barkin, Adi's father, he's here, and I'm sure you're very proud of your son today, and as we all are. Yochai Benkler, Adi's uncle, is here, and Ari Benkler, Adi's cousin. So, and the incredible Pramila Jayapal is here, and when I get to my opening statement, I'm going to thank her again because it is her legislation that is why we are all here today. So, having said that, let me begin with my opening statement. So, I believe this is a historic day. Today, the Rules Committee is holding a hearing on the Medicare for All Act, and this marks the first time Congress has ever held a hearing on Medicare for All. And I want to thank, again, Congresswoman Pramila Jayapal and Congresswoman Debbie Dingell and their staffs, Senator Sanders and his staff as well, for leading this effort and for all their help with this hearing. But I particularly want to thank Congresswoman Jayapal for her commitment and her dedication to this issue, and we are all grateful to her. We have a talented witness panel with us today, and I have a sneaking suspicion that we will have a lively debate, and that's a good thing. After nearly a decade of Republicans talking only about how to rip health care away from people when they were in charge, this majority is here to discuss how to expand it and how to lower costs and improve outcomes in the process. You know, I have long believed that health care is a right for all not a privilege for the lucky few. And this Congress is putting that belief into action. That's why I voted for the Affordable Care Act, a law that gave 20 million more people access to health coverage. It banned insurance companies from discriminating against cancer patients and women and made sure that health plans actually covered essential benefits. The ACA changed lives. It saved lives. But we knew then that it was never going to be the last stop in health care reform, that we were always going to have to come back and build upon those core values. And that is what today is all about. Because the work of reform isn't done. 29 million Americans are still without coverage. 44 million people have coverage that isn't there for them when they need it. And all of us deserve health care that we can afford, without health insurance middlemen unnecessarily jacking up costs or deciding who gets care. Because it's still true today that for too many in America, you can go broke if you get cancer. You can lose your home if your kids get sick. That's not health care being delivered as a basic human right. That's health care that remains out of reach for too many. The Medicare for All Act would change that. The 29 million uninsured Americans in our country today would get health care. The 44 million underinsured people would have the peace of mind of finally knowing that their health care will be there for them when they need it. And all of us, workers, seniors, students, all of us, will be free from crushing out-of-pocket costs. Importantly, this bill would also guarantee, for the first time, that people living with disabilities have access to services they need to live with dignity. The Medicare for All Act is a serious proposal. That's why more than 100 members of Congress are co-sponsors. That includes me, and it includes some others on this panel. Not only does it deserve to be part of the discussion as we consider ways to expand and strengthen coverage, it deserves to move forward. And so I hope today is just the start. So Congress should be a place where we tackle big things, where we're not afraid to have hearings and real debates. I know we won't pass this bill overnight, but we won't pass it unless we start the dialogue. This Democratic majority was built by Americans tired of political leaders who tried to sabotage their health care and who looked after the wealthy and well-connected at the expense of everyone else. The American people in the last election spoke loudly and clearly. They wanted a Congress that works to expand coverage. They are sick and tired of the problems that are fundamental in our system today. So if my Republican friends want to use a lot of scary words like government takeover and socialism today, have at it. They tried that during the passage of Medicare. They tried that during the passage of Social Security. They tried that during the passage of the Affordable Care Act. And every time the American people saw through it and supported those programs. So this would be no different. And by now, we all know that the Republican plan for health care can be summed up in one word: repeal, no replacement. To the extent that they had a health care plan, I think it could probably be summarized as take 2 tax breaks and call me in the morning. They didn't hold a single hearing on their repeal plan last Congress, not one. Well, this majority is taking a different route. We have fantastic witnesses who will talk about this bill today. Some are for, some are somewhere in the middle, and some are against. But I want to focus on one witness. With us today is Adi Barkan. And Adi is a father and a husband, out of circumstance, a healthcare advocate. And I think we all have we have a picture of Adi's beautiful family here today, and I'm sure your son is incredibly proud of you being here at the first ever Medicare for All hearing. So we are so honored that you are here. If you recognize Adi's name, it's because he's been fighting like hell for his life and for all of ours. And Adi was diagnosed with ALS in the fall of 2016. Since then, he has battled insurance companies, drug companies, medical device companies. You name it, Adi has battled it just to get the care that he needs. And I say battle because that's exactly what he has had to do. Battle to get care, battle to get services, battle to get life-sustaining medical equipment. But no one should have to fight a healthcare company while they're fighting for their lives. Now, I can't do Adi's story justice. I will let him tell it. But I will leave my colleagues with this. If you think healthcare in America is just fine today, if you think we only need to nibble at the edges of reform, look at Adi after what he has gone through and try to tell him that. Of course, Adi, you are welcome to stay here as long as you want and take any breaks that you want. We are just honored that you are here. You literally put your life on the line to travel here from California, and we are fortunate to be able to hear your story. Let me just close with this. You know, in Washington here, we talk a lot about national security. That's everybody's favorite topic. And I believe we need to expand the definition of national security to include more than just the number of bombs we have. National security should also mean things like quality health care for every person in this country. You know, we expect the federal government to defend us against enemies abroad. I don't think it's too much to expect the federal government to protect us against illnesses here at home. So we're going to have a spirited debate here. I'm looking forward to it. But before I get started, I want to first recognize our distinguished ranking member from Oklahoma, my good friend, Mr. Cole.
Thank you very much, Mr. Chairman, and I, too, want to thank you for holding the hearing, and I want to thank all of our witnesses for coming and participating. I had the opportunity to read all of your testimony, and frankly, I found it very informative in all cases and quite moving, obviously, in a number. And it's interesting to me to note, Mr. Chairman, that while, as you pointed out, there's a variety of perspectives, as there should be, amongst our witnesses today, each and every one of them is interested in the best possible health care for the American people. And they may disagree over how they get there, but it's a noble and worthy goal that you all share, and frankly, you've all dedicated a lifetime in pursuit of. So I am very grateful for that, as I know every member of this panel is. Today's hearing, Mr. Chairman, is quite extraordinary. We're here today to consider H.R. 1384, the Medicare for All Act of 2019. Unlike our usual weekly hearings, today's hearing is an original jurisdiction legislative hearing covering a bill over which the Rules Committee has some original jurisdiction. I say some because out of the 120 pages of bill text, the Rules Committee has jurisdiction over precisely one of those pages. That's it, just one page. Yet we're about to hold our first original jurisdiction legislative hearing in nearly 3 years on this bill. That's what makes this hearing extraordinary. I also think it's worth noting that Speaker Pelosi's personal committee is the one to take the first swing at this ball, when 3 other committees in the House can claim wider jurisdiction than rules. Energy and Commerce, Ways and Means, and Education and Labor could and should all conduct multiple hearings on this legislation as well. And frankly, I'm sure ranking Republican members of those committees will be requesting their chairs to take up this legislation in the relevant committees, and I hope that happens. Of course, there's a reason it's coming to rules first, and that's because this bill, too, is an extraordinary bill. What Democrats are proposing today would completely change America's health care system, and not, in my view, for the better. Medicare for All would require all Americans to pay more in taxes, wait longer for care, and receive potentially worse care. Even worse, it would put our current Medicare recipients at risk. As Medicare is structured now, current Medicare recipients and Medicare Advantage plan holders are by and large satisfied with the health care they receive. In particular, Medicare Advantage plans are extremely popular. However, this radical bill puts Medicare itself at risk by enrolling millions of new recipients who have not paid into the program in the same way current recipients have. It would reduce the quality of services, enforce longer wait times, and ban Medicare Advantage entirely. For current Medicare recipients, Medicare for All really means Medicare for none. Indeed, this bill is a socialist proposal that threatens freedom of choice and would allow Washington to impose one-size-fits-all plans on the American people. Private health insurance would be completely banned. Everyone, every man, woman, and child in America with private, employer-based, or union-based health insurance would lose their plan. Even if you like your plan, you really can't keep it. More than 150 million people will lose health plans they like, plans that they bargained for, and in many cases, plans that they've earned through years of hard work. Medicare for All throws it all out the window in favor of a one-size-fits-all government-run health plan. We will hear from one of our witnesses, Ms. Grace Marie Turner, on the impact this will have on employer-sponsored insurance and the method by which roughly half of Americans receive their health care. In the midst of all this, I think the majority needs to be honest about the phenomenal cost of this new program. We're going to hear from Dr. Charles Blehaus, a former public trustee for Social Security and Medicare. He reviewed Medicare for All for the Mercatus Center and authored a very telling study on the topic. Dr. Blayhouse's work showed the previous, more basic version of Medicare for All would cost at least $32 trillion over the next 2 years. And frankly, the version in front of us would cost more than that. The majority has not told us how much this massive new program will cost, how they will raise the money to pay for it, or whose taxes will have to go up to pay for it. On the last concern, I can assure you that the answer is everyone. Everyone's taxes will have to more than double to pay for this program. The majority needs to be honest with us and with the American people about the cost. Beyond this, I'd like to point out one of the most egregious provisions of the Democratic health care bill is that it relates to the federal funding of abortion. As many know, the federal funding of abortion has been limited for well over 3 decades by several legislative provisions. The Hyde Amendment limits taxpayer funding of abortions. The Weldon Amendment prohibits states from discriminating against providers that do not support abortions. The Church Amendment protects the conscience rights of health practitioners, and even Obamacare maintained limited conscience protections. However, this bill contains none of them. It requires coverage of comprehensive reproductive care, quote unquote, which includes elective abortions paid for with taxpayer dollars. Section 701 of the bill explicitly states that this bill must ignore these federal laws dating back 33 years. Mr. Chairman, I would hope that you're encouraging your leaders to pursue hearings and markups within the committees that have primary jurisdiction over the majority of health care issues, energy and commerce, and ways and means, so that we can ensure that long-standing life protections are included as you move Medicare for All to the floor for a vote. Mr. Chairman, I'm looking forward to today's hearing. I hope our witnesses can shed some light on these and other questions as we review this proposal that, if passed into law, would dramatically change the American health care system for absolutely everyone, and in my opinion, not for the better. Thank you, Mr. Chairman.
Well, thank you very much, Mr. Cole, for your statement. And let me just assure you that I hope all the committees of jurisdiction will do hearings on this bill, and because I think that would be a big, as I mentioned in my opening statement, a big contrast to the way my friends on the other side of the aisle conducted themselves when they tried to repeal the Affordable Care Act. There were no hearings. Hearings are a good thing. And as far as why rules is beginning, I'd like to think it's because there's an enlightened chairman. So we are ready to begin. Anyway, our first witness is Adi Barkan. Adi is a lawyer and an organizer with the Center for Popular Democracy and the founder of the Be a Hero PAC. He helped design and draft policy proposals to enhance the quality of low-wage jobs in New York City, including the right to paid sick days, regulation of major retailers, and unionization of the car wash industry. He graduated from Yale Law School and Columbia College cum laude. And we are, as I said in my opening statement, we are deeply honored to have you here, Mr. Barkan, and the floor is yours.
Chairman McGovern and members of the committee, thank you for inviting me to testify today. My name is Adi Barkan. I am 35 years old and I live in Santa Barbara, California with my brilliant wife Rachel and our beautiful toddler Carl. She is an English professor at the University of California, Santa Barbara, and I am an organizer at the Center for Popular Democracy and the Be a Hero Project. I earned my bachelor's degree from Columbia University with a major in economics and my law degree from Yale Law School. For 20 years, since I was a freshman on my high school debate team, I have been giving speeches and presentations on topics like healthcare reform and the federal budget. But never before have I given a speech without my natural voice. Never before have I had to rely on a synthetic voice to lay out my arguments, convey my most passionately held beliefs, tell the details of my personal story. 3 years ago, Rachel and I felt like we had reached the mountaintop. We had fulfilling careers, a wonderful community of friends and family, and a smiling, chubby infant boy. We could see decades of happiness stretching out before us. The sun was shining and there was not a cloud in sight. And then, out of the clear blue sky, we were struck by lightning. ALS. A mysterious neurological disease with no cure and no good treatment. a life expectancy of 3 to 4 years. Most of its victims are in their 50s and 60s. I was 32. Every month since my diagnosis, my motor neurons have died out, my muscles have disintegrated, and I have become increasingly paralyzed. I am speaking to you through this computer because my diaphragm and tongue are simply not up to the task. Although my story is tragic, it is not unique. Indeed, in many ways, it is not so rare. Jennifer Epps Addison, the president of my organization, is sitting next to me. Like me, her husband was struck at a young age by a neurological disease. Multiple sclerosis. 10% of Americans have a serious disability. Every family is eventually confronted with serious illness or accidents. On the day we are born and on the day we die, and on so many days in between, all of us need medical care. And yet in this country, the wealthiest in the history of human civilization, we do not have an effective or fair or rational system for delivering that care. I will not belabor the point, because you and your constituents are well aware of the problems: high costs, bad outcomes, mind-boggling bureaucracy, racial disparities, bankruptcies, geographic inequities, and obscene profiteering. The ugly truth is this: health care is not treated as a human right in the United States of America. This fact is outrageous. And it is far past time that we change it. Say it loud for the people in the back: health care is a human right. For my family, although we have comparatively good private health insurance, ALS now means paying out of pocket for almost 24-hour home care. This costs us $9,000 every month. The alternative is for me to go on Medicare and move into a nursing home, away from my wife and my son. So we are cobbling together the money from friends and family and supporters all over the country. But this is an absurd way to run a healthcare system. GoFundMe is a terrible substitute for smart congressional action. Like so many others, Rachel and I have had to fight with our insurer, which has issued outrageous denials instead of covering the benefits we paid for. We have so little time left together, and yet our system forces us to waste it dealing with bills and bureaucracy. That is why I am here today, urging you to build a more rational, fair, efficient, and effective system. I am here today to urge you to enact Medicare for all. There are 3 simple reasons why Medicare for all is the right solution, the only solution, to what ails the American healthcare system. I will summarize them here, but I urge you to read the fantastic testimony submitted by the National Nurses United for more details. First, Medicare for all will deliver to everyone living in America the high-quality care that we deserve. The law will provide comprehensive care, including primary and hospital care, dental, vision, reproductive, and mental health care. We will all be allowed to see the doctors and specialists we want. And, crucially, the program will provide for long-term services and supports that will allow people like me to stay in our homes and communities, with the people we love. This will dramatically improve life for the tens of millions of people whose families include older or disabled people. Second, Medicare for all will save the American people enormous sums of money. Under the program, there will be no premiums, no deductibles, and no copays. That means that we will no longer need to choose between paying the rent and filling a prescription. It means we will no longer delay necessary care until it is tragically late and tragically expensive. It means that we won't have to worry every year when our employer announces the new rates. It means that we can finally start to eliminate the atrocious racial and economic disparities that destroy so many lives, that rob our communities of so much dignity, that strip us all of our common humanity. Any proposal that maintains financial barriers to care, any proposal that continues to charge patients exorbitant copays, deductibles, and premiums will necessarily leave people out. Any proposal that maintains the for-profit health insurance system will require that some people don't get the health care they need. Without the generous support of my family and friends, this would include me. Crucially, Medicare for all is the only way to make our health care system more efficient. Over the past 3 years, I have seen firsthand how the current system creates absurdly wasteful cost shifting, delays, billing disputes, rationing, and worry. Administrative waste is costing us hundreds of billions of dollars every year. Medicare for All will streamline the entire system, letting doctors and nurses focus on delivering care instead of on paperwork. As a single-payer program, Medicare for All will be able to eliminate immoral price gouging by pharmaceutical and device companies. The fundamental truth is that too many corporations make too much money off of our illnesses, and they are spending gazillions of dollars lobbying and campaigning and fighting to stop us from building something better. It is very important to emphasize the following point: these cost savings are only possible through a genuine Medicare for All system. Other proposals to increase health insurance coverage, such as those that would make Medicare compete with private insurance, would not facilitate administrative and billing savings. There are many other major benefits to Medicare for All, and detailed in the written testimony submitted by the nurses and others. But my time to deliver this testimony is running out. And, in a much more profound sense, my time to deliver this message to the American people is running out as well. So I want to end on this third and final note. Our time on this earth is the most precious resource we have. A Medicare for All system will save all of us tremendous time. For doctors and nurses and providers, it will mean more time giving high-quality care. And for patients and our families, it will mean less time dealing with a broken healthcare system and more time doing the things we love, together. Some people argue that although Medicare for All is a great idea, we need to move slowly to get there. But I needed Medicare for All yesterday. Millions of people need it today. The time to pass this law is now. Winning this reform will not be easy. The moneyed interests will do everything in their power to stop us. And yet, despite these obstacles and despite the personal challenges that I face, I sit before you today a hopeful man, a hopeful husband, and a hopeful father. I am hopeful because right now, there is a mass movement of people from all over this country, rising up. Nurses, doctors, patients, caregivers, family members, we are all insisting that there is a better way to structure our society, a better way to care for one another, a better way to use our precious time together. And so my closing message is not for the members of this committee. It is for the American people. Join us in this struggle. Be a hero for your family, your communities, your country. Come give your passion and your energy and your precious time to this movement. It is a battle worth waging, and a battle worth winning. For my son Carl, for your children, and for our children's children. We have a once-in-a-generation opportunity to win what we really deserve. No more half measures. No more health care for some. We can win Medicare for all. This is our Congress. This is our democracy. And this is our future for the making.
Thank you very much, Mr. Barkin. Thank you so much.
Chairman McGovern and members of the committee, thank you for inviting me to testify today. My name is Audie Barkin.
Thank you very much. I appreciate it. I think this entire committee is grateful for your testimony, and we're honored to have you here. Let me yield to my colleague, Mr. Cole.
Simply want to echo your remarks. It's a great privilege to have you here, and at considerable sacrifice and risk to yourself, which is a testament to your courage. So we're very happy and honored to have you in this debate, in this hearing today. Thank you. My witness? Okay. We'll go next to Dr. Charles Blayhouse, is the J. Fish and Lillian F. Smith Chair and Senior Research Strategist at the Mercatus Center at George Mason University, as well as a visiting fellow at Stanford University's Hoover Institution. Previously, he served as a public trustee for the Social Security and Medicare programs and as Deputy Director of the National Economic Council under President George W. Bush.
Thank you very much. Chairman McGovern, it should be. Is it on? Okay. Chairman McGovern, Ranking Member Cole, all the members of the committee, I greatly appreciate this opportunity to appear before you to discuss the estimated federal budget costs of Medicare for All. Before I proceed to the estimates, just a few caveats. This is not an analysis of whether Medicare for All is good policy or bad policy. It's purely a cost projection. And as I discuss the factors that play into the estimates, it's purely by way of explaining how they affect the numbers. Second caveat is that my testimony is based on an analysis of the Medicare for All Act of 2017, introduced by Senator Sanders in the last Congress. Obviously, there are more recent bills introduced by Representative Jayapal and by Senator Sanders himself. These would be expected to cost somewhat more because they've added long-term care benefits, but I have not had an opportunity to analyze these bills. Medicare for All would add somewhere between $32.6 trillion and $38.8 trillion in new federal budget costs over the first 10 years. The $32.6 trillion estimate is a lower bound estimate. It essentially assumes every cost containment provision in the bill saves as much as possible. If instead things play out more consistently with historical trends, the new federal costs would be closer to $38.8 trillion. And I'll say more about the specific assumptions later. Now, obviously, such enormous numbers are very difficult to grasp. We're talking about 11 to 13% of our GDP in 2022, rising to 13 to 15% of GDP in 2031, being added to the federal ledger. And we simply do not have historical experience with permanent government expansions of this size. So to provide a sense of the magnitude, the study notes that doubling all currently projected federal individual and corporate income taxes would be insufficient to finance even the lower bound estimate of $32.6 trillion. Now, to be clear, these would not be the total costs of Medicare for All. These would be the federal government's net new costs above and beyond currently projected federal health obligations. Total federal spending on Medicare for All over the first 10 years would be somewhere between $54.6 trillion and $60.7 trillion. Now, the vast majority of these costs would arise simply from the federal government's assuming responsibility for health spending that's now done by others, by state and local governments, by private insurance, and by individuals in their payments out of pocket. Other aspects of Medicare for All would add to that existing health spending. Still others are intended to bring costs down. The biggest factor increasing health spending under Medicare for All would be its expansion and increased generosity of health insurance coverage. Spending on behalf of the currently uninsured would rise, as one would expect and presumably intend. Additional benefits would be provided that Medicare currently doesn't, such as dental, vision, and hearing services. Perhaps most importantly, as has been noted here, Medicare for All would provide first dollar coverage of all Americans' health expenses, meaning no deductibles, no co-pays, no other cost sharing. And this would considerably increase the demand for health services for the well-documented fact that the more people's health care that is financed by their insurance, the more they tend to consume. So under Medicare for All, the federal government would not only take on responsibility for funding currently projected health services, but a significantly increased demand. Now, other provisions of Medicare for All are expected or hoped to reduce costs. The study assumes substantial administrative cost savings from eliminating private health insurance, and it brackets a range of possible outcomes of efforts to negotiate lower drug prices. Now, the big variable here is payment rates for health providers. The bill indicates that providers will be paid at Medicare payment rates, and these are much lower than those that are paid by private insurance. For hospitals, the payment reductions would be more than 40% for treatments now covered by private insurance, and for doctors, the reductions from private insurance rates would start out around 30% on average. They'd grow even steeper over time, reaching 42% within 10 years. Now, importantly, these reduced payment rates would be substantially below providers' reported costs of providing services. We do not know what would happen to the supply, timeliness, or quality of healthcare services if we were to impose sudden provider payment cuts of this magnitude while simultaneously increasing the demand for services. And because of this, several other studies performed prior to the bill's introduction assumed higher payment rates than Medicare's would be needed. Now, my study does not take sides on whether these provider payment cuts would be desirable, but purely from an analytical standpoint, you have to recognize that they're much larger and more sudden than lawmakers have historically been willing to implement. If historical patterns continued and such payment reductions did not occur, Medicare for All would further increase national health spending even above current projections. My written testimony provides comparisons showing that these estimates are generally similar to those of other experts when you adjust for the years being estimated, as well as for alternative assumptions regarding administrative costs, prescription drug costs, and provider payment rates. I hope this information is useful, and I thank the committee again for the opportunity to discuss these important aspects of Medicare for All.
Thank you very, very much. Appreciate it. Dean Baker is a macroeconomist and co-founder of the Center for Economic and Policy Research, CEPR, in Washington, D.C. His areas of research include housing and macroeconomics, intellectual property, Social Security, Medicare, and European labor markets. He is the author of several books, and his piece, Medicare for All is Not a Fantasy, was recently published on CNN's website. He received his BA from Swarthmore College and his PhD in economics from the University of Michigan. Mr. Baker, we're very honored to have you here.
Thank you, Chair McGovern and Ranking Member Cole. I appreciate the opportunity to speak here. Also, I have to say it's a great honor to be next to Adi again. I knew Adi from prior days when we were in the Fed Up coalition to pressure the Fed to allow more full employment, and that was an amazing effort that Adi deserves enormous credit for, in addition to his great work, subsequent work, and I appreciate being here. I want to make three main points and then say a little bit about the transition. First off, I want to say that Medicare for All is affordable, that the bulk of the payments should be coming from shifting employer premiums to government, basically to taxes. So it's not additional money out of workers' pockets. Secondly, that the amount of additional revenue that will be needed depends hugely on the extent to which we can reduce input costs. And here what we have to keep in mind front and center is that we pay twice as much for everything as everyone else in the world, and that doesn't make sense. And the third point is that lower costs can be associated with better care, not just for the obvious reason that will increase access, but for other reasons that we should expect better outcomes. On the first point, in terms of the overall affordability, taking a look at Dr. Blahhaus's numbers, the basic story, very comparable, that you're looking at incorporating somewhere in the order, I was looking at 2021 to 30, I think those might be slightly different years, but incorporating the private payments under the government budget, it's about $33.4 trillion by my calculations using CMS numbers. First off, though, we know that there will be a lot of administrative savings. There was an analysis done back in 2003 by Steffi Wolfhandler and David Himmelfarb that compared our administrative costs with Canadian administrative costs, and most obviously you have the huge difference in what we actually pay up front for insurance. But in addition to that, we have huge administrative costs on providers, hospitals, doctors' offices, nursing homes. They all have to have large numbers of staff to deal with different billing from different insurers. So using their figures, I calculate that we would get that tab down to $25 trillion, still considerable. That's shown in Table 1 of my written testimony. A second point, second adjustment, we will see more utilization. I think that the amount of utilization, we are somewhat shooting in the dark here because we don't know what happens when we, in essence, make more health care free or cheap for people. But important point to keep in mind that 70% of our health care costs come from roughly 10% of the population. The point about that is those 10%, they're either on Medicaid or they've hit their out-of-pocket limits. In other words, they're not already constrained. So we're looking at 30% of costs. So how much more will that go up? We don't know. I assume 10% in the calculations. There's some research for that. There will be some out-of-pocket. Again, that will be debated, how much you have. I assume 1% of GDP. That leaves us, after we count for the $11.6 trillion in employer payments, we're left with $13.6 trillion, still a substantial bill over a decade. But then I go, okay, well, what about input cost? And I won't go into these in great detail, that's in my testimony. But if we look at our input costs, as I say, if we look through medical equipment, prescription drugs, physicians' payments, dentists, we pay twice as much as everyone else in the world. Now, will we get down to other levels? That's an open question. But there's no obvious reason we should be paying twice as much for our drugs, for our medical equipment as people in France and Germany. We don't pay our auto workers twice as much. We don't pay twice as much for cars. It's not clear why we should pay twice as much for health care. And let me just focus quickly on prescription drugs. CMS projects we'll spend roughly $6.6 trillion on prescription drugs. Now, the assumption in the bill, and most people have analyzed it, we can get that down a lot. One of the points I like to make is we're not talking about making prescription drugs cheap. The problem is we make prescription drugs expensive. Drugs would be cheap if we didn't give government-granted patent monopolies. I understand there's a rationale for that, but the point is we could fund the research alternative ways, and they would be cheap. So just to come quickly to the last points, we could expect better care. People shouldn't have to deal with the stress. Adi and his family shouldn't have to deal with the stress of paying for their bills. That has to be a negative in terms of care for someone, a cancer victim, someone else suffering from a serious disease that they have to deal with bills. Also, in the case of prescription drugs, our opioid problem, at least it's alleged, is in large part the result of our patent monopolies. Purdue Pharma would not have done as they're alleged to have, pushed their drugs, insisting that it wasn't addictive when they had evidence it was. We helped create that problem by granting patent monopolies. Last points on the transition. I would be cautious on how you do it. First off, fix Medicare. It's absurd that we don't have an out-of-pocket limit on traditional Medicare. We need that. Secondly, not incorporating the drug benefit. We don't have standalone drug plans in the private sector. Why do we have that with Medicare? It just raises costs. That's utterly pointless. And we overpay the Medicare Advantage plans. A recent analysis found we overpay them by roughly 13%, $20 billion a year. No reason for that. Secondly, in the transition, I'd say allow a buy-in, have a competitive Medicare plan. The third point, reduce input prices. I can give you lots of ways in which we can get input prices down, in addition, as I said, to public funding of research for prescription drugs. And lastly, as just a very, very simple first step, how about lowering the Medicare age of eligibility to 64? That's very affordable in the scheme of things. A lot of 64-year-olds are already on Medicare through disability or they're on Medicaid. A great down payment, in my view. So long and short, I think it's affordable, but we have to be careful in how we get there. Thank you.
Thank you very much.
Thank you very much, Mr. Chairman. Ms. Grace Marie Turner is president of the Galen Institute, a public policy research organization that she founded in 1995 to promote an informed debate over free market ideas for health reform. She's been instrumental in developing and promoting ideas for reform to transfer power over healthcare decisions to doctors and patients. She speaks and writes extensively about incentives to promote a more competitive, patient-centered marketplace in the health sector.
Thank you, Ranking Member Cole. Thank you, Chairman McGovern, members of the committee, for the opportunity to testify today. Let me begin by saying that I believe there are important shared goals for health reform. Everyone should be able to get health coverage to access the care they need. It should be affordable. People should be able to see the doctors they choose. We must guard quality of care, and we must protect the most vulnerable with a strong safety net. Millions of Americans are frustrated with the current system. Care costs too much, and many are simply priced out of the market. Others with insurance say premiums and deductibles are so high they might as well be uninsured. Those on public programs like Medicaid struggle to find physicians, especially specialists, who can afford to take the program's low payment rates. People are hurting and they feel powerless as cogs in the $3.6 trillion health sector with little power to impact choices or costs. But it is hard to see how consumers would be more empowered when dealing with a single government payer. In a country that values diversity, will one massive program with one list of benefits and one set of rules work for everyone? I was in the gallery the night that the House passed the Affordable Care Act in March of 2010. And heard member after member talk about the importance of passing the bill in order to finally achieve universal coverage and to lower cost. 9 years later, with millions still uninsured and costs doubling in the individual market, our nation is still struggling to achieve those goals. In calling this hearing today, you acknowledge the growing interest in this bold proposal. But when people learn that Medicare for all would mean much higher taxes, and losing the coverage they have now, support plummets. What happened recently in Colorado and Vermont when they tried and failed to create their own single-payer systems, I think is important to study. I believe the growing presence of government in the health sector is a significant contributor to its dysfunction. Government officials, not consumers, increasingly determine what services can or must be covered, how much will be paid, who is eligible to both deliver and receive these services. Third-party payment systems lead to significant disruptions. Insurers and others must respond to government rules and regulation, shoving consumers to the bottom of the healthcare totem pole. Rather than dramatically expand the role of government, I believe we need to look more carefully at these problems and target appropriate solutions that empower consumers and build on what works. Medicare for All's promise of unrestricted access to benefits is virtually unprecedented, and it is difficult to anticipate the impact of this new system. Representative Jayapal's bill implies a recognition of cost by imposing global budgets to contain spending. Paying doctors and hospitals at Medicare rates would force many to close or significantly cut back on services and would worsen the existing physician shortage. We do know from the experience of other countries that global budgets and centrally determined benefit structures lead to rationing, waiting lines, and lower quality of care, as I describe in my testimony. Tragically, it is often the most vulnerable who are left behind when demand for services outpaces resources. Many Americans would see it as severely disruptive to lose their current coverage when public programs as well as job-based health insurance would be shut down under Medicare for All. 173 million Americans get health coverage through the workplace, a highly valued benefit. My colleague Doug Badger explains that this employment-based health system is really a central pillar in our health sector. It produces a nearly 3-to-1 ratio in value to tax expenditures. Employer plans also pay doctors and hospitals more than Medicare and Medicaid do, and providing the margins that most may need to maintain quality and even keep their doors open. Employers also have more flexibility to tailor insurance to the needs of their workforce, to advocate for them, and provide education and incentives about good health. I describe in my testimony targeted solutions already underway to give individuals and workers more, not fewer choices, and to provide states with more resources and flexibility to help their health insurance markets recover. I also describe work by the Health Policy Consensus Group, which I facilitate, in developing a plan to reduce the cost of health insurance while protecting the poor and sick, including those with pre-existing conditions. Finally, Americans want more, not fewer choices in health coverage, yet Medicare for All would put them on a single government program. When government officials are making decisions about what services will be covered, as the legislation explicitly says, how much providers will be paid, how much citizens must pay in mandatory federal taxes, consumers will have even fewer choices than they do today. It will reduce access to new technologies, stifle innovation, and result in a near doubling of the tax burden. I would welcome the opportunity to work with you to achieve the goals of better access to more affordable coverage and better protection for the vulnerable. Thank you for the opportunity to testify.
Thank you very much. Dr. Sarah Collins is Vice President for Healthcare Coverage and Access at the Commonwealth Fund. As an economist, she directs the fund's program on insurance coverage and access. Dr. Collins has led several multi-year national surveys on health insurance and authored numerous reports, issue briefs, and journal articles on health insurance coverage, health reform, and the Affordable Care Act. Early in her career, she was an associate editor at U.S. News & World Report, a senior economist at Health Economics Research, and a senior health policy analyst in the New York City office of the Public Advocate. Dr. Collins holds an A.B. in economics from Washington University and a Ph.D. in economics from George Washington University. Thank you for being here.
Thank you. Thank you, Mr. Chairman and members of the committee, for this invitation to testify on proposals to reform the U.S. health system. My comments are going to focus on gains in health insurance since the passage of the Affordable Care Act, the problems people continue to report affording insurance and health care, and the potential of recent congressional bills to address these problems. The ACA brought sweeping change to the health system and expanding comprehensive health insurance to millions of Americans and making it possible for anyone with health problems to get coverage by banning insurers from denying coverage or charging more because of pre-existing conditions. The number of uninsured people has fallen by nearly half since the ACA became law. There's also been a decline in the share of people reporting problems paying medical bills or not getting needed care because of cost. The large body of research on the ACA shows that the law's overall impact on people's ability to afford insurance and get health care has been positive. However, three distinct yet interrelated problems remain. 29.7 million people remain uninsured. 44 million people with insurance have plans that are leaving them underinsured, and healthcare costs are growing faster than median income in most states. The stalled gains in coverage stem from 5 primary factors. 17 states have not yet expanded Medicaid. People with incomes just over the eligibility threshold for marketplace subsidies, and many in employer plans have high premium costs. Congressional and executive actions on the individual market and Medicaid have reduced potential enrollment in both. Undocumented immigrants are ineligible for subsidized coverage. and cost sharing is climbing in individual market and employer plans. A major factor underlying trends in both uninsured and underinsured rates is growth in healthcare costs. Healthcare costs are the primary driver of premium and deductible growth in private insurance. There is growing evidence that a major cause of healthcare cost growth are prices paid to providers, especially hospitals. There is also evidence that these prices explain the wide healthcare spending gap between the U.S. and other wealthy countries. And there is also evidence that the greatest provider price growth is occurring in private insurance. Congressional Democrats have introduced several bills to address these problems. The bills all propose to expand the public dimensions of our private and public health system and may be grouped into three categories. Bills that add more public plan features to private insurance, such as enhancing marketplace subsidies and reinsurance. Bills that give people a choice of public plans alongside private plans, such as plans based on Medicare or Medicaid offered through the marketplaces. Bills that make public plans the primary source of coverage, such as Medicare for All bills. These bills are an amalgam of provisions that individually or collectively have the potential to make the following changes in the health system: improve the affordability, benefits, and cost protection of insurance, slow cost growth in hospital and physician services, prescription drugs, and administration, reduce the number of uninsured and underinsured people. Some notable estimates of the effects of these bills' provisions include lifting the top income eligibility threshold for marketplace tax credits could insure nearly 2 million more people and lower silver plan premiums by nearly 3% at a net federal cost of $10 billion. Allowing HHS to negotiate prescription drug prices under a Medicare for All approach could lower drug prices by 4% to 40%. A Medicare for All approach could lower administrative costs from a current 14% of spending in commercial plans to anywhere from 6% to 3.5% of all spending. The estimated effects of a Medicare for All approach on U.S. health expenditures range from a decline of 10% to an increase of 17%. What has captured the most attention in the debate about Medicare for All is a significant shift in how health care would be paid for. Most Medicare for All bills shift most financial responsibility to the federal budget. This shift raises important questions about financing sources, in particular the incidence of taxation. But what is notable about the range of national health expenditure estimates under a Medicare for All approach is that the increase in expenditures is often less than the increase in demand for health care induced by providing comprehensive coverage to everyone. These spending estimates vary widely because of assumptions about the degree of change in provider prices, prescription drug costs, and administrative costs. But the mechanisms for slowing cost growth in these proposals could be considered, refined, and applied not only in single-payer approaches, but in other health reform approaches as well. In the absence of congressional action on improving coverage, many states have stepped up and implemented policies such as reinsurance programs. But improving coverage for everyone will ultimately require federal legislation. Expanding coverage, limiting families' costs, and slowing cost growth are achievable goals, and these bills provide mechanisms to move forward on each. I look forward to your questions. Thank you.
Thank you very much. Dr. Doris Brown is a retired colonel in the U.S. Army Medical Corps and the 118th President of the National Medical Association. Dr. Brown retired from the National Cancer Institute, where she managed the breast cancer chemo prevention portfolio. She was a Woodrow Wilson Public Policy Scholar in 2007, where her research focused on breast cancer health disparities. Her focus is on achieving health equity. Dr. Brown now serves as the President and CEO of Brown & Associates, a small business specializing in improving health outcomes. Dr. Brown graduated from Tougaloo College. Am I saying that right?
Yes.
Good. And the BS in a historically black college in Mississippi, the University of California at Los Angeles, MPH, and Georgetown University, MD. She's a medical oncologist by training, and we're thrilled to have you here.
Thank you. Thank you, Chairman McGovern, Ranking Member Cole, and members of the committee. I thank you for the opportunity to appear before the committee to discuss universal health coverage for all Americans, particularly the vulnerably underserved population. I am here as the retired military medical officer and the immediate past president of the National Medical Association, which is the largest and oldest national organization representing the interests of more than 30,000 African American physicians and the patients we serve. As the nation's only healthcare organization still devoted to the needs of African American physicians and their patients, we are disturbed by the vast health inequities for vulnerable populations, with numerous and often insurmountable obstacles to receiving quality health care. People of color experience differences in access to care, the affordability of these services, implicit bias by some providers, and limited participation in clinical research, which has consequences around viable medical treatment. And the NMA has been responding to inequities in the healthcare system throughout our history. Most notably, we were the only organization to support the Medicare Act of 1965. Research reveals that African Americans, of course, are more likely than other racial and ethnic groups to experience health inequities. And in my written testimony, I address some of those concerns. But given the disproportionate impact on chronic diseases in communities of color, Congress must find ways to make health care coverage affordable, accessible, and of high quality for all. For the National Medical Association, healthcare is more than a provision of medical services. Healthcare is a multifocal, complex product which takes into account the critical determinants of health, including the socioeconomic conditions, housing, education, food and nutrition, environmental exposures, genetics, and biological factors. And while the ACA was a step in the right direction and made substantial improvements in our healthcare system, it did not go far enough. And in order to stem the high prevalence, morbidity, and mortality of chronic diseases, we must first develop a comprehensive agenda around health equity. And health equity is a state in which everyone has the opportunity to attain their full health potential and no one is disadvantaged. It is imperative that health care be provisioned to surpass one's social position or socially defined circumstances. Health equity and opportunity are inextricably linked. When health equity is achieved, there is no health disparities. And universal health coverage is a pathway to achieving that health equity. It has the potential to address poverty, inequality, and discrimination. It can also provide a more efficient and effective cost-saving healthcare system for everyone. Because health equity and opportunities are linked, the health equity, as I've indicated, there will be no health disparities. The government has maintained a track record for providing comprehensive health care throughout the military's TRICARE program, the Department of Veteran Affairs, and other sponsored programs, as you know, in Medicare and Medicaid and others. And these programs have diligently worked to confirm affordable access to high-quality healthcare benefits for millions of citizens covered by these programs. Under DOD's TRICARE, which is the second largest single-payer health system in the country and second only to the VA program, both of these high-caliber systems adhere to high-quality, evidence-based, accessible care for their beneficiaries. A patient should not have to decide between getting their full prescriptions filled and whether they should buy food. And of course, that certainly is something that we've seen in the private sector taking care of cancer patients, where they would decide, maybe I should fill only a part of this prescription. Part care does not get you to remission in cancer. Every patient should have the opportunity to receive first-class medical care rather than being considered second best because of a lack of insurance, provider bias, and limitation of the Medicaid system. And we've seen this over and over, where an individual may not get the approved drug for care in cancer, but get the second best because their system did not have the drugs on the formulary. The best framework for universal health coverage is through collaboration and engagement of diverse multi-sector partners, including the communities in which they serve. Some of the existing healthcare programs already have the infrastructure and provide a network to serve our communities. But improvement is needed to target the excessive costs, service accessibility, while minimizing the duplicate services that we see in many cases. I want to leave you with 2 points. First, we must adopt a system of universal coverage that minimizes the administrative medical costs. It does not matter what label you use, whether it is Medicare for all, universal health coverage, single payer, whatever. The coverage must be one that would allow the patient the ability to choose the provider for their care, and care should be the same no matter whether you receive it in Mississippi or California, whether you're in rural America or urban America, and it should not be restrictive based upon language, age, gender, racial, and ethnic areas. And secondly, we must continue to address the physician shortage and funding of our safety net hospitals. Universal health coverage would allow for increased investment in educating more providers and allowing for additional residency slots. With consistent and predictable provider costs, we can end the two-tiered system of healthcare that has placed hospitals that serve low-income and minority communities at risk for closure. Universal coverage would ensure that our safety net hospitals are sufficiently funded and resourced. The NMA will continue its long history of advocacy and education. We believe that all individuals in every community in the United States have a right to equal quality, high-quality health care that is accessible, affordable, comprehensive, and coordinated. We begin by providing the comprehensive coverage benefits that we have under Medicare for All. Thank you.
Thank you very, very much. And before I go to Dr. Navi, I just want to acknowledge Congresswoman Debbie Dingell from Michigan, who's arrived here. She's a co-author of the Medicare for All bill, along with Congresswoman Jayapal, and we appreciate her leadership and her being here. Last but certainly not least, Dr. Farzan Navi is an emergency medicine physician and an assistant professor of emergency medicine in New York City. Dr. Navi completed his MD in residency at NYU School of Medicine and has been featured on the Now This discussing his patient struggles with the current healthcare system. And he's on the board of directors of the New York Metro chapter of Physicians for a Natural Health Program. And I would urge my colleagues you could Google Dr. Navi, and he's got some really interesting and compelling videos that kind of highlight some of the inadequacies of the current system. And anyway, we're happy to have you here. So make sure your mic is on. That's okay.
Thank you so much. A little closer?
Yeah.
Too close?
No, that's perfect, yeah.
All right. Thank you, Chairman McGovern. Thank you, Ranking Member Cole, for inviting me to be here today. My name is Farzan Navi. I'm an emergency medicine doctor in New York City, and I support Medicare for All. As an ER doctor, I have the opportunity to help all sorts of people in all sorts of ways. I get to save investment bankers from heart attacks and strokes, and I get to help with homeless veterans from hypothermia in the winter. And that's what I love about my job. That idea that I could help any person with any problem at any time is what attracted me to emergency medicine in the first place. But over the years, I've learned that it becomes impossible to care for someone when our medical system forces them to fear things like bankruptcy and foreclosure when they come to decide to seek medical care. Now, if you ask any ER doctor, any ER nurse, or even any ER janitor in this country, you're going to hear countless stories of people who came into the hospital to seek medical care, only to walk out in the middle of the treatment, AMA. AMA stands for Against Medical Advice, and people often walk out against medical advice, often because they're concerned about the cost of their treatment. The reality for many people in this country is that seeking medical care means weighing one's health against one's wallet. Now, everyone in this room is very smart. Everyone in this room already knows all the statistics. You already know that 41% of Americans have skipped a visit to the ER in the past 12 months because of cost concerns. That's easy to gloss over, but we should let that sink in. That's 41% of Americans. Over 2 in 5 Americans have skipped a visit. They felt that they needed to go to the ER, but then they decided not to go seek medical care because they were concerned about the cost of that visit. You also already know that 45% of Americans live in fear that a health event could lead to bankruptcy. But I see these numbers every day on the ground level. I have to look these patients in the eye, and I want to put some face on those numbers that you all already know so well. A few weeks ago, I took care of a patient who I was sure had appendicitis. I recommended a CAT scan, we discussed IV antibiotics, and possibly a surgery. But a short while later, this patient flagged me down, she pulled me aside, she asked me to pull out her IV because she wanted to go home. Now, she wasn't stupid, she wasn't crazy, she didn't distrust doctors or anything. The patient just was concerned about the cost of her treatment. She did some research on her phone. She learned that in some rare cases, appendicitis can be treated with antibiotics alone. She asked me if I could give her a prescription so that she could go home. Now, you don't need to be a doctor to know that this is far, far, far from the standard of care for appendicitis. All cases of appendicitis need a hospital admission, IV antibiotics, and probably a surgery. I told her that there were way too many things that could go wrong with her plan, and I strongly advised against it. Now, she asked me about the risks, and I told her the truth. I told her about the possibility of an abscess formation, perforation of her bowels, sepsis from her infection, and even death. This is not an exaggeration. This is just the truth of what happens when you don't treat appendicitis. She sat back, she asked me for some time, she thought about it for a long while, but eventually she flagged me back down, she decided to leave. In her own words, she said, "Thanks, Doc, I appreciate all you've done, I really do, but I just don't know if I'm gonna be able to afford this. I'm gonna go take my chances." Now, in my line of work, I often have to give people really bad news. I often tell loved ones that their family members have died. I've had to tell parents that their child has died, children that their parent has died. I've had to tell spouses that their husband or wife has died. But I can tell you with complete sincerity that watching someone sick walk out of the door with something that is completely treatable right here in the richest country in the world is just as awful a feeling as any of those conversations. About 1 year ago, I took care of a young lady who came in for an overdose on fish antibiotics. She had a fever, she couldn't afford an ER visit, so she decided to go to a local pet store to buy some fish antibiotics for her symptoms. She had had a job interview coming up, and she wanted to make sure she was better for that interview. Now, of course, fish antibiotics come as a packet of powder. You put them in a fish tank so the fish can eat it. There's obviously no instructions for human consumption. She ended up overdosing by an order of magnitude. She had side effects that affected her brain and her central nervous system. She fell down a staircase while she was on that job interview, actually, and then she had to be admitted to the ICU. All of that because she felt like she couldn't afford a simple visit to the ER for a simple fever. 21 years ago, when she was 10 years old, my fiance, who is here right now, she lost her mother because her mother decided to delay medical care for her abdominal pain until only after her stomach cancer had already spread beyond any hope for treatment. A housekeeper raising 2 daughters, my fiance's mother was worried about the cost of her care, and she paid for it with her life. I'm here today because my patients and my fiance deserve better than this. These stories and countless, countless, countless others are absolutely ridiculous to be taking place right here in the richest country in the world. I'm not asking for much. All I want to do is practice medicine in a world where I no longer have to watch a patient walk out of the ER without medical care that can save their life because they're worried about going bankrupt. And I never want to see another patient who thinks their best option for medical care is to go to the local pet store. To simply treat for someone for a problem as simple as appendicitis in 2019, or to have my human patients take human antibiotics from a human pharmacy are absolutely not radical ideas. From my perspective on the ground, the solution has to involve approaching medical care in just the same way we approach educating our children, maintaining our roads, or supporting our armed forces. All this means is treating healthcare like any other public good, creating a universal healthcare system like Medicare for all, so that when they're at their most vulnerable, my patients never have to make any consideration except simply to do what they need to do in order to get better. Once again, thank you, Chairman McGovern, Ranking Member Cole, and the Rules Committee for inviting me to be here. I'm looking forward to any questions.
Thank you. Well, thank you all very much for testifying. Before I ask some questions, I have a few unanimous consent requests I want to add to record. You know, our healthcare system is built with checkpoints that more often than not prohibit a person from being able to access health care, including pre-authorization requirements, lifetime limits, network restrictions, cost, and the inherent discrimination built into the system. So without objection, I would like to submit a letter from the National Nurses United, an organization with 150,000 members. Their letter explains how gatekeeper obstacles would be eliminated with this bill. And I would like to thank Jean Ross, President of the National Nurses United, who is with us here today for her leadership and her work in ensuring that every American has access to affordable health care in this country. Jean is here in Washington, D.C. with nurses from 28 different states advocating for Medicare for all. We want to thank you. I'll insert that in the record without objection. Without objection, I'd like to submit in the record a letter from Diane Archer, the founder and past president of the Medicare Rights Center, which is a national nonprofit consumer service organization. In her letter, she brings to light the serious concerns with Medicare Advantage and how Medicare for All, an improved and expanded Medicare system can fix these problems. You know, a child's access to health care is crucial. They're going through a time of rapid brain and body development, and it is important that their health coverage reflects their needs. Yet a recent survey by Georgetown Center for Children and Families found an increase in uninsured children for the first time in a decade. So without objection, I would like to submit a letter from the Children's Partnership, a California-based nonprofit child advocacy organization working to ensure that every child has access to health care. This letter outlines the critical components of health coverage and care for children that should be addressed in any policy Congress considers, including Medicare for All. And I would like to thank Mayra Alvarez, President of the Children's Partnership. And so those will be in the record. So let me begin my question. So, Mr. Barkin, let me ask you a question, then I'll come back to you in a minute for the answer. But you know a little bit about how health insurance companies deny claims. And you testified that your medical bills cost thousands and thousands and thousands of dollars a month. You also talked about the time commitment it takes to fight back against these denials. And I guess my question is, what are some of the services or medical devices that were denied by your insurance company? And how is your life impacted by not having those services? And I'll go to the next question, then come back to you, Adi, in a minute. Let me, let me say to Drs. Baker, Blauhaus, and Collins, you're all economists. And tell me, are economists always right?
No.
I mean, I know, right? Yeah, I mean, you should try being a member of Congress. We're always right? But seriously, though, I mean, let's look at studies. You know, even looking at Dr. Blahaus's study from the conservative Mercatus Center, it seems like the studies suggest that Medicare for All could cost a little more or a little less than we're currently paying now, right? Getting that right?
I think that's fair.
All right. So, worst case scenario. I mean, we could spend about what we are spending now nationally on health care and guarantee that another 29 million people get health care coverage. We could end crushing out-of-pocket costs for everyone, and we could include new services for seniors and the disabled. I mean, that sounds like a pretty good deal to me. So, I mean, when we have all these, warnings about the high cost, I mean, we're spending an awful lot on health care right now, and we're not getting the services and the effectiveness that we're all demanding. And so, I just want to put that out there because I think that I think it's important for people to put all this in perspective. We're not talking about all new costs. We're talking about costs that they're already built into the system. Dr. Baker?
Yeah, if I just throw a quick point in on your point about economists not being right. I think the Affordable Care Act hasn't gotten as much credit as it should for reducing costs. And again, one could argue how much it deserves credit for the slowdown in cost growth. But if you go to 2008, the projections from the Center for Medicare and Medicaid Services for 2017 compare with what we actually spent. We spent 1.5 percentage points of GDP less on health care than what they had projected. So that comes to $300 billion that year. Same thing if you look at the CBO projections. We're spending 0.5 percentage point of GDP less on Medicare than what they had projected in 2010 before the bill passed. Now, whether you want to say the Affordable Care Act was responsible for all that slowdown, that's a totally arguable point. But the point was, we're actually doing pretty good in terms of slowing the course of healthcare cost growth with, if you like, increased government involvement.
Dr. Collins?
My testimony covers the range of estimates that are currently out here, including Dr. Blahaus's. And what you do see is exactly what you said. You see some estimates show a decline in national health expenditures. Some show an increase in national health expenditures. It depends crucially on savings that we can potentially get from provider prices, from prescription drug costs, from from administrative costs. But I think one of the major contributions of the Medicare for All bills is putting the issue out there on how much we're paying providers right now. I think that is a really critical issue. It's why we do see some savings in some of the estimates that we've seen of the Medicare for All bills. It's a conversation that the country needs to have right now, and I think it's the differences and the changes in expenditures under these approaches put a fine point on that issue.
Look, at all of us here as members of Congress, we do casework too, right? And we get an inordinate amount of casework that is healthcare related. And it's always about fighting with insurance companies, right? It's always about the crippling costs. And I guess the point I'm just trying to make is that, I mean, I'd like to think we all believe we can do better. And I'm just simply saying when people, push the panic buttons on cost, I mean, we're spending an awful lot right now and we're not getting the result we want. And I think, to me, Medicare for All offers a better way to go forward and gives us more care. And by the way, for senior citizens, it gives them Medicare Plus. I mean, they get a lot more than they're getting right now. I don't know, Adi, are you ready to? All right.
And provided by my neurologist was not necessary and that I would have to pay full price. The company also denied me a brand new FDA-approved medicine to treat ALS. First of all, my plan doesn't cover long-term care. And so we have to pay for 24-hour care, which is incredibly expensive. In addition, my insurance company, HealthNet, denied me a breathing assist machine. HealthNet ruled that the ventilator and medicine provided by my neurologist was not necessary and that I would have to pay full price. The company also denied me a brand new FDA-approved medicine to treat ALS. The first time, I had to complain publicly and generate an outcry for them to reverse their decision. The second time, I had to organize a protest at their headquarters. But most people don't have the ability to do that. And nobody should have the obligation to do that. But this is a big part of how insurance companies make their money. They deny, delay, and wait for patients to give up. I believe that approximately 1/4 of claims are denied. As a result, people get sicker, and die. Fundamentally, the priority for health insurance companies is to make a profit. But that is not in the public interest. By getting the profit motive out of the healthcare industry, we can refocus on the real priority, delivering high-quality health care.
Thank you. Dr. Navi.
I just wanted to piggyback on that. I do think when health insurance companies deny claims, it's not only unethical. I just wanted to share a couple of examples when it's kind of just financially stupid as well. I have a couple cases I'll share real quick. In my hospital recently, there's a 28-year-old female. She came in with a regular run-of-the-mill urinary tract infection. Super easy to treat, course of outpatient antibiotics, no problem. She was denied that claim for that antibiotics. No good reason was given why. That she was charged $300 over the counter in cash. She couldn't afford that. She ended up going to the other side of the pharmacy, ended up buying some cranberry juice because she thought that might be her best option to treat her UTI. She ended up coming into the hospital 2 days later, septic, with a fever, high heart rate, had to be admitted to the hospital and get IV antibiotics. We denied her $300, but now we're paying thousands of dollars for that. There's another example I had. I had a patient that came in. He was having a heart attack. His cardiologist came down, recognized him, and started yelling at him and said, "Why'd you stop taking the antiplatelet medication that I told you you cannot stop taking?" He said, 6 months ago, I was admitted to the hospital with complications for my diabetes medications. My endocrinologist told me I can't stop taking those. I had to make a decision. I couldn't afford both of them, so I stopped taking my antiplatelet medications. He ended up coming back in with a heart attack. Because we insufficiently covered these patients' prescription medications, we ended up paying more in the long run. Another example, there's a patient I had. She was 38 years old. She had a long history of depression. Her depression was controlled with some psych medications. Out of nowhere, she'd been on these medications for many years. Her medical insurance company started denying that medication. She stopped taking them. She couldn't get in to see her psychiatrist for another month or two. She ended up coming in because she was feeling suicidal, had to be admitted to the hospital. All three of these cases, these patients had bad medical outcomes, and that's horrible in and of itself. But it just financially doesn't make any sense. We ended up paying more for these bad outcomes, and that needs to be a part of this discussion as well. And when we talk about all these estimates of cost, I imagine that the kind of cost savings we would see by making sure patients are covered and fully covered, we don't really see that in these numbers because there's no way to really account for what we're seeing on the ground level. This would save a lot of money.
Dr. Brown?
Yes, well, certainly in the oncology area, we see this most particularly with people of color, because one, they have a fear of going to the doctor to begin with, and so they will deny that that lump is there and think it's going to go away. In many cases, will say, I'll pray it away. But when they finally come in after being denied several times, it is advanced disease, and they require much more care that is much more costly, but the outcome is negative because they tend not to survive.
Mr. Barkin, let me ask you a question, and then I'll come back to you. You indicated, again, you're paying all these thousands of dollars worth of medical bills, and then you've turned to a GoFundMe page online to do the online fundraising website to help you cover the cost. If you didn't have GoFundMe, what other household costs or family bills might not get covered to cover your care? You're a pretty popular guy, and even I have seen your Twitter feed and know all about your work. Relying on GoFundMe might be something that someone of your stature can do, but not everybody can do that. So, what if you don't have the Twitter following you have, and what if, how would you afford the care? And do you think there's anything sane about our GoFundMe healthcare system? So while you think of that answer, let me go to Dr. Brown and Navi. I mean, based on your testimonies, I'm guessing that these stories of insurance companies denying care isn't surprising, right? Dr. Brown, you're a cancer specialist. Can you tell the committee how a prepaid system like the military compares to a postpaid system like the one for the civilian population, and how it differs when it comes to patients getting the care that they need and actually following the doctor's best medical advice? And Dr. Navi, you testified about your patients who put cost before their health care out of necessity or fear, and you've told some really horrible stories here. I mean, do you believe that you are free to practice the best medicine you can, that your patients are free to take your advice without fear, or do you think that there's something standing between you and your patients getting the care that they deserve? So,
Yes, well, in the prepaid system in the military, as a military provider, whether it is cancer or general internal medicine, it's a equal access system, and we do not have to be concerned with, can that patient afford an MRI, or should I just order an X-ray? Again, I know that the best possible care is what I can provide for those patients, and so I order the MRI and get the best care for those individuals. They don't look at, do I have a copay? Is it some out-of-pocket? They go to that facility in the integrated system and they get the best care. If you're outside, you weigh that. Maybe I should see if a CAT scan will suffice and I can still see the dimensions of this mass and its distinguishing features to whether I should order surgery. If the patient cannot afford for even a CT scan, then I look at what are the other kinds of things that I can order to get that patient to the care that they need. And that is not the way I was trained to practice medicine. You go in to provide the best possible care for those patients, and it's not based upon cost. It's based upon need so that you can improve the health outcomes.
Dr. Navi?
I couldn't agree more. The answer to your question is no, I don't think I'm practicing the best medicine I can practice. I feel like I'm practicing with one hand tied behind my back. I feel like every time not every time, but oftentimes when I recommend something to my patients, they sit down and they think, can I afford this? Should I do it before they decide to do it or not? And these are lose-lose conversations. I feel like if I try to tell someone to do something and they say, no, I don't know if I could afford that CAT scan, and they walk out, their health suffers. But even if I convince them, I don't feel terribly good about myself. If I convince someone to get a CAT scan that they're not sure they could afford, we might be taking care of the health, but I walk away thinking, did I just kind of sentence this person to years of debt that they're not going to be able to pay off? So there's no winning a lot of these conversations, and I'm not given the best care.
Mr. Barkin.
If I couldn't use GoFundMe, I would probably start by asking my parents to start spending down their retirement savings. Then we would go hand in hand to friends. Nobody dealing with a serious illness should have to do either of these things. We should instead have a rational, fair, comprehensive social safety net that actually catches us when we fall.
Mr. Cole.
Thank you very much, Mr. Chairman. And if I may, I'm going to follow your lead here. I want to submit a letter without objection from the American Hospital Association in opposition to the legislation.
Without objection.
Thank you very much, Mr. Chairman. If I could, Ms. Turner, I'll start with you. H.R. 1384 explicitly makes it illegal for private health insurers to provide for service that the government would provide under this legislation. How many people would lose the current health insurance that they have if we did something like that?
Well, everybody would lose the current health coverage they have, 173 million Americans with job-based health insurance, but those on ACA coverage, people on Medicare, people on Medicaid, the Children's Health Insurance Program, all would be folded in to the new Medicare for All program.
So under this legislation, really, if you liked your plan, you liked what you had, you would have any option at all to keep it?
Only if you are in the VA or the Indian Health Service, as I understand it.
Well, believe me, a lot of people in the Indian Health Service might want to make this change. That's another issue.
From Oklahoma,
Yeah,
to close up,
that gets to
yes.
what Congress does and doesn't do in that service. But anyway, let me ask you this and follow up to that. How would this impact both employers who provide the coverage and employees who are satisfied with what they're actually receiving?
I think this is really a significant issue, and it's one that when Colorado tried to did a ballot initiative in 2016 to try to create a single-payer system for the state of Colorado, they did wind up with serious pushback from people who didn't understand that it meant that they would lose their private coverage, that they particularly lose their employer coverage. The employer-based system is really a central pillar in our health sector for a number of reasons. Because employers have easier access to help their employees with different health plan options. They listen to their employees, what benefits do they need, what matters to them. They're always trying to balance the cost against benefits and trying to get the best deal for the employees. They also have a lot of wellness programs. They know that a healthy workforce is beneficial to them, so they invest a lot in their employees. But I think there are two other points that are really crucially important. One is that because employers pay more for private coverage, they in turn pay more to hospitals, doctors, other providers in order to be able to make sure their employees have access to the care and the treatment they need. By paying them more, it allows Medicare and Medicaid to pay less so that people on those public programs will also be able to access care. So there's a real balancing, and I think the value of the employment-based health insurance for 173 million people, half of the people in the country, retirees, workers, dependents, et cetera, is really helping to support the current Medicare and Medicare system that we're talking about emulating. And also, because employers get a tax break as providing health insurance as part of the compensation package for their employees, there's a tax break there, and also employees, the value of their health insurance is excluded from their income. My colleague, Doug Badger, assumes that the value of employer-sponsored health insurance is about $991 billion, almost $1 trillion in 2016. And there is a tax break worth about $350 billion to support employer-based health insurance. So that tax break supports 3-to-1, and some estimates are even higher, health insurance for half of the country in order to get private payers to contribute to that health insurance. So I think that that equation, and that's something that's developed over 70 years in this country. It's unique to America, but perhaps that's because we, through some permutations of history, started on that path. It's something that people enormously value, and it really has become a central pillar in our health sector.
Well, your answer actually anticipated a lot of my next question, but let me put it to you this way and get your response on this as well. If we, as this bill calls for, held the reimbursement rates for providers at Medicare and Medicaid levels, how would that impact the providers? What do you think the response would be?
I'm not an economist, I'm a policy person, but the former actuary for CMS anticipated when Congress was considering and actually enacted cuts to Medicare providers, when we were still having the doc fix battles. If hospitals and physicians were to see 40% payment cuts, many of them simply could not keep their doors open. They do not have that kind of a margin. They would either dramatically curtail services, or they would wind up closing their doors. And I think you'd see fewer
you're sitting
physicians.
right next to an economist. So I'm going to ask Dr. Blahaus for his response to the same question.
Well, I think the honest answer is that the effects are unpredictable. We do know the data. We know the data indicates that Medicare payment rates for hospitals over the time window, first 10 years of Medicare for All, Medicare payment rates are a little bit more than 40% below private insurance rates. For physicians, they're about 30% below at the beginning of that 10-year period, but those relative reductions under the macro law become even steeper, so they'd be about 42% by the end of 10 years. And the honest answer is we have no idea how providers would respond to this. We do know roughly that under the legislation, the demand for health services would increase by probably about 11%. Other studies have made similar estimates. And if we make simultaneous, very dramatic reductions in payment rates to providers at the same time as this increase in demand, none of us can say for certain how they would respond. We do know from the Medicare Actuary's Office that Medicare payment rates, that the margins on treating Medicare patients are negative for about 80% of hospitals. And Medicare for All would extend that situation to the population as a whole. How providers would react to that, what sort of disruptions there might be in the timeliness or quality or supply of health services, we simply don't know.
Let me ask you this, because we all know that not all hospitals, are equally profitable or serve populations that are equally affluent. Certainly in my district, we've lost a number of rural hospitals in recent years where they're treating a population that's older, quite often sicker, and enjoys less private coverage. So they rely very heavily on Medicare and Medicaid, and they're having a tough go. Again, if we remove that, I suggest to me the impact wouldn't be equal all across the country. In other words, I think rural areas in particular would really take a pretty hard hit unless something was done to change the rates. Is that fair?
I think that's fair, and I just to add an additional perspective on this from the vantage point of my study, my main reason for flagging this issue is primarily just to help with understanding of the numbers. We have a set of cost estimates that would arise if you assume that these very dramatic payment reductions were implemented right from the get-go, right in the very first year. But if you look at the historical patterns of congressional behavior, you do not see a willingness to impose sudden cuts for providers of anything close to that magnitude. And if you think those historical patterns of congressional behavior were to continue, the cost estimate for the legislation would be much, much higher. It would be more in the area of $38 trillion rather than 32.6.
Let me ask you this. I'm going to address this to all of you, if I may. We'll just start actually down here and go across. This is an enormously complex undertaking that we're talking about to change the entire healthcare system. I lived through one of these things with as many of my colleagues did, the discussion, debate, and then the implementation of Obamacare, the ACA. Is 2 years a sufficient period of time? Because that's what the legislation calls for, as I understand. Within 2 years, we would make this entire transition. Is that a realistic, even for those of you that want to go in this direction, I worry about the time frame. So
Well, I would just say that you'd have to be cautious. 2 years is certainly very ambitious. I just want to add quickly, if you're referring to your hospitals as largely rural and they already have a large number of Medicare patients, if that's the case, they're less likely to be at danger because they're already getting reimbursed at Medicare rates.
well, they also get private payments as well. That's at
Understood, but it's a smaller
proportion, yeah.
share.
But if every patient they treated was at Medicaid and Medicare levels, I promise you, most of them would close.
No, I can't comment.
Yeah.
That may well be true.
I think the transition issue, you can certainly decide to extend it, make it a longer period of time. The ACA was a 4-year transition period, so that's certainly something that you could consider. I did want to say, address the cost shift argument in the Medicare payment area. The evidence really does not show that the reason that private provider prices are higher is because Medicare prices are so low. If that were the case, we would see consistently higher margins all the way across the country. Instead, we see a lot of variability across the country. So the way this works is that private providers are negotiating with their commercial carriers prices that work the best for them. In concentrated markets, they get higher prices, and insurers want them in their network, so they concede to those higher prices. They then take that negotiated rate to employers. Employers have to pay higher premiums. They reduce their workers' wages, they increase deductibles, so those costs get shifted ultimately to people. So there's really not a lot of evidence that the cost shift argument is the reason for higher prices. It's really these non-transparent price negotiations that occur in the private market.
Brown?
Sorry.
Representative, may I
Oh, yes, absolutely.
employer issue you asked earlier? We don't expect employers to provide their workers with education for their children, or with fire insurance. There is no reason to tie health care to employment. It just exacerbates the negative impact of job loss. And, frankly, it's a huge burden on employers.
Thank you. Dr. Brown?
Yes, I just wanting to add, in terms of people of color, the Medicare and Medicaid reimbursement cost is not the same across the board, so our providers are already getting a lower rate. It's not likely that they're going to go out of business. And in terms of employers and the amount that's being paid, many of the smaller businesses go to part-time individuals so that they do not have to carry that cost. And so again, I think for providers that we are concerned about, they're not going to walk out on taking care of their patients, even though they're getting a lower rate.
Dr. Davitt?
Sure. I assume you're asking the question from an implementation perspective, but from a physician perspective, we were ready for this not in 2 years, but 2 years ago. I'm ready to stop seeing my patients not get good care because they can't afford things.
And I'll answer the question as I'm answering every question from the federal cost perspective. When I did my study, I was dealing with a bill that had a 4-year transition, and did not feel myself able to score the effects during that 4-year transition period, because very unpredictable factors like transition costs, voluntary buy-in rates, things like that. And so, for simplicity's sake, I assumed that in that 4th year, everything just instantly sprang forth fully formed, that we instantly had administrative cost savings, we instantly had a level shift downward in prescription drug costs, that we instantly had the full implementation of these provider cuts. So you could look at that and you could say, well, those might be reasons why the lower bound estimate, even assuming a 4-year transition, would be an understatement. If you had a 2-year transition, obviously that increases the likelihood that the lower bound estimate is a gross understatement, because there's probably very, very little chance that we'd be able to attain those instant administrative cost savings, those instant drug cost savings that I'm assuming in the lower bound estimate.
weigh in on the transition issue.
Let me let Ms. Turner, I have very limited time left, and then I'll come right back to you if I may.
Mr. Cole, there's a really good piece in today's Washington Post about Vermont's experience that I think is really instructive. Amy Goldstein took an in-depth look at the experience and their experience in trying to achieve a single-payer healthcare system. Green Mountain Care, they worked for 4 years and were unable to figure out how to structure it for the small state of Vermont, to figure out how providers would be paid, how the taxes would be collected. And what they found was that the initial projections took what she calls a 36,000-foot view of what the costs were going to be. When they really got down into the hardwiring of implementation, they found that it was going to be so disruptive to the state's economy and so disruptive to the current structure of healthcare system that they had to pull the plug on it. She said that it's very difficult to dismantle one healthcare system and replace it with another.
May I? Okay, Mr. Backer, please.
Here's what I know for sure, I needed Medicare for all to be in effect yesterday. If the richest nation in the history of the world really decided to, we could guarantee health care as a right, and we could probably do it more quickly than people think. But the problem is that right now, we're not even trying. Too many people in the halls of this building are fine to accept the status quo, that leaves people like me behind.
Thank you very much. Thank you, Mr. Chairman.
Thank you very much. I just want to yield myself a minute here just to make a couple of points. To amplify Adi's point, employer-sponsored health care means the effects of job loss are amplified. It also puts a huge burden on employers. Imagine if we expected employers to provide for fire insurance, as was mentioned, police insurance, school funding for K through 12, and the paperwork. That's all part of that. It's insane. And just one other point here. I mean, because I think some of us are looking at this whole initiative from a different perspective. People aren't going to lose their health care with Medicare for all. I mean, you would actually get to keep your doctors and go to your hospitals that you currently have. The only difference is you wouldn't have to deal with insurance companies. And I don't know about you, but that's not my favorite thing to do when I get sick. But anyway, I now yield to my good friend, Mr. Perlmutter.
I just want to thank this panel, everybody. The professionalism in your testimony is very much appreciated by this congressman, and I know the Rules Committee generally. Mr. Barkin, couple questions for you. You know, you talk a lot about time. Another guy in a chair like you, Stephen Hawking, he wrote a number of essays on time. But time is really a key piece to all of this. And you talked about number of things, you know, the effect of taking time and the waste of time on you personally. So I'd like you to maybe expand on that a little bit. And then you also said we could save enormous sums of money. I'd like you to expand on that. And then you said we could avoid immoral price gouging. I think those were your words. So I'm just putting those three things that you talked about, I'd ask you to expand. Now, to the economists, I'd like to just talk a little bit more about the money that's in the system, in the healthcare system, is the biggest part of our economy in its own right. Healthcare system, 19, 20, 21%, 18%, whatever it is, it's far bigger than anything else. So my first question, I guess, to you, Dr. Baker and Dr. Collins, is how does that percentage of our overall economy compared to the rest of the world, other countries, industrialized countries? And I guess to all of you, and Dr. Blayhouse, you as well, the overall savings that we might expect from something like this. And you know, there was an economist, Bob Pollin, and sort of his approach to these things, because it is a massive change. And why do we want to undergo a massive change if we're not going to save some money and have better outcomes, and I'll get to you doctors, you medical doctors in a second, to talk about the outcomes. And then, Ms. Turner, just so you know, I'm going to talk about Colorado, so I'll tee that up for you.
Okay, well, we spend about 18% of our GDP on healthcare, and that's roughly twice the average from the OECD. You have a range. If you take a lower-cost system like the UK, we could finance that whole system from what we spend now in the public sector. That's how much we are out of line with everyone else. And, you know, the point that I think is striking, on the one hand, we have huge administrative costs, but the other point that I was trying to emphasize in my both comments and my written testimony, we pay twice as much for all the inputs. So twice as much for the drugs, for the medical equipment, for our doctors, on down the list. And again, that's not true of our cars. It's not true of our auto workers. So you're sort of hard-pressed to say, why do we have to pay twice as much for drugs as everyone else? We don't pay twice as much for, you know, our cups here and our cars, but we do. And that I think, speaks to the enormous potential savings. Again, I understand none of that is easy. You're the ones that have to fight with these people because that's income for people. But if we just make the comparison, what does it look like U.S. compared to everyone else? We're paying twice as much on average.
Dr. Collins.
I would just echo Dr. Baker's comments, and there's a chart in my testimony that shows all the detail on the countries that pay so much less than we do, but I would also make the point too, is that we also don't get commensurate outcomes for the spending that we're making. So we actually have worse outcomes in a number of areas than other countries that are spending far less. So the quality issue is a huge issue internationally as well.
And Dr. Blehaus, and I appreciated your testimony when Mr. McGovern was asking you some questions about, you know, ultimately it's kind of a push, maybe it's a little bit of a loss, maybe a little bit of a gain. This Dr. Pollan, I guess, economist from University of Massachusetts, thinks that there's a big savings. Do you have any comments on that?
Well, sure, if I could try to unpack it a little bit.
Sure.
And I want to build off of some of the things that Dr. Baker and Dr. Collins have said. I think it was well stated by Dr. Baker that most of the costs from the federal perspective are a shift. They're a shift from costs now being borne by the private sector to the federal government. I would add to that, the federal government would also be assuming costs that are currently borne by state and local governments. So it's not just the private sector,
right,
but it's all of that. It's primarily a shift. That's the biggest piece of the federal costs. Now, there are other things that would increase the costs beyond that. And I thought Dr. Collins said something earlier that I thought was very useful, where she said basically the total national cost increase would be less than the utilization increase. So in other words, the biggest part of this cost increase is an increase in service demand and utilization. Now, maybe we can cut into some of that increase by savings on administrative costs, savings on drug prices, things like that. Now, we wouldn't be able to offset that cost completely with those measures, and that's where the cuts to provider payments come in. The question is, would we be able to cut provider payments enough to offset that additional cost?
Well, and I think Dr. Navi mentioned this, and it's in somebody else's papers, you know, that 2 out of 5 people don't take advantage of healthcare, their need for healthcare, because of fear of expense, that they walk back out. And he gave some dramatic examples. So in effect, you know, there is a lot of demand that's not being met because people are afraid of the cost. So I was a bankruptcy lawyer for many, many years before I was elected to Congress. And obviously, one of the biggest areas of bankruptcy is because of healthcare costs. So I do appreciate your comments, Dr. Navi, when you said, oh, yeah, I may convince somebody to stay there, but now have I saddled them with some debt that could cause a bankruptcy or something else? So there are all sorts of issues here, but I think to Dr. Brown and Dr. Navi, then I'd like to get back to Mr. Pollan's kind of estimates. If we were to go to this Medicare for all or universal healthcare system, do you agree that there would be more demand on the system? And could we, from a provider standpoint, manage that?
Thank you. Yes, I think that there would not necessarily be a demand on the system. I think you would practice medicine in a more appropriate, better way. And the idea is that you're going to increase your educational components for your patients and practice prevention. And if you put prevention into practice, you're not going to have many of those hospitalization visits that will end up in the intensive care units. And so there's cost savings there. We have not practiced prevention, and we've been talking about it for years and years, and it's just going to the wayside. If we get people to come in and to do their immunizations and get those standard tests of screening, so screening and early detection find the diseases at an earlier stage, and again, you can then provide that care at a more cost-effective, and so the demand is not going to increase. We're practicing care in a more efficient, effective way.
Dr. Navi?
Yeah, I'd like to echo that. So I gave you a couple examples of people that came in, didn't get the care they needed, then ended up having more expensive care. There will be some people that will be using more care, but we're going to be more efficient as well with primary care and other ways to utilize our healthcare system. As an ER doctor, I see a lot of people come in with late-stage disease because they didn't get to go to their primary care doctor when they needed to, and then we end up paying more for that. The reason for that is we have a law, it was a Reagan-era law called EMTALA, 1986. It's the Emergency Medicine Treatment and Active Labor Act. It makes it such that anyone insured, uninsured, documented, undocumented, whoever they are, they could come to the ER when they need to come to the ER. And we treat them, and if they can't foot the bill, the taxpayers foot the bill, or the hospital does. I think if we expand coverage, we get these people utilizing care at the right places. They end up going to their primary care doctor to get their diabetes, high blood pressure, high cholesterol controlled, so they don't end up having strokes and heart attacks and coming into the ER for those things.
Do you think a system like this would help you avoid some paperwork? Okay? So that
Most
you could
certainly.
be treating your patients?
Yes.
Okay. Ms. Turner, and then I'd like to go back to Mr. Barkin. So, and I appreciated your testimony because you really kind of laid it out as to, 70 years ago, it was you paid out of your pocket or you got charity care. And a lot of that charity care was underwritten by the churches, by charitable organizations. And then Kaiser came along and said, people are getting hurt, we've got to do a war effort. And so Kaiser Steel and Kaiser Aluminum and all those guys, they created this they started the employer system. So we are in this massive system, and to change it is obviously a big undertaking. So I agree with all of that. With respect to Colorado, so I'm from Colorado, and I support Ms. Jayapal's legislation, and I support beefing up the Affordable Care Act, and I support, there's an effort out there that says for anybody 50 and older, you can buy into the Medicare system. So I think all are improvements over where we are today. But my question to you on Vermont and on Colorado, just as a voter on that thing, I voted against the legislation because I didn't think Colorado on its own could undertake a Medicare for all system, that it was national in scope. And that's why I went this way, but I'm happy to have you comment on it a little bit more.
Well, just briefly, you know much more about the debate in Colorado than I do. In Vermont, they were assuming that much of the money that currently is flowing to the state through healthcare, whether it was employer contributions, whether it was ACA funds, existing taxes, et cetera, all would be part of that. So they were assuming a much larger pot of money because there would additionally be federal funds coming in, and they still couldn't make it work. I know in Colorado that from my reading of it, and I did a couple of debates in the state about the ballot initiative, the feedback that we continually got was people so nervous about the taxes that would be required to support it. And yes, there were arguments that the current money going to employer-based health insurance would go into the kitty, but that just wasn't enough. And it would disrupt the economy.
And I think you're right, from a policy and a kind of a political standpoint, it wasn't enough to overcome a number of the concerns and fears. But I think, listening to the testimony of the economists and the doctors and just our own experience, my wife had a difficult surgery, initially denied. I mean, I can't tell you the panic that hits a family when something like that happens. You know, so there are all sorts of issues, and I'm just pleased that Mr. Cole and Mr. McGovern were able to work out the details so that we could actually have this hearing and get this ball rolling, because I think it is a very important conversation for this nation to have. Mr. Barkin, can you answer my questions, or you ready for that?
Thanks very much for your questions. This healthcare system only works if you're a pharmaceutical or insurance industry executive who wants to maximize their own profit at the expense of people like me. It is simply unconscionable that I should have to pay $9,000 per month for life-saving medical care, at a time when the insurance industry is raking in record profit. That's wrong, and it needs to stop. Here's the thing, it's a huge stress to have to fight with insurance companies over what they'll cover. It's a huge financial strain. But most of all, I've come to realize that our time on Earth is the most precious resource any of us have. I wish I didn't have to be here today. I think you are wonderful, Congressman, but frankly, I'd rather be back at home, being with my wife and playing with my son instead of trying to wake the conscience of this nation's lawmakers. Every day is precious for me. I don't have time on my side. Americans who are dealing with the everyday realities of their health care don't have time on their side. No one should have to fight to be treated with dignity again, and that's why I'm here today.
Thank you. I yield back.
Thank you very much. Mr. Woodall.
Thank you, Mr. Chairman, and thank you for the holding of the hearing and the way you've conducted it so far. We have a tough time. It may not be obvious to you, though, Mr. Barkin, with your reference to awakening the conscience of Congress, it may be obvious to you that we don't always get a good, healthy conversation on issues of this. I credit the young woman to your right there, Ms. Jayapal, I cannot support her legislation, but I absolutely support her. And there's a way to have a conversation. I know you are, Pramila. I don't really. There's a way to have that hearing. In fact, the Washington Post, I don't know if you all saw the article on you all this morning. Washington Post did an article on this hearing, and you all as the witnesses, and made a point of saying, in fact, they quoted Ms. Shalala as saying, "We're not going to make ourselves look crazy this morning." Was the quote they grabbed. That the Washington Post observed that there are lots of ways to start this conversation, and that the chairman and the leadership of the House went out of their way to pick a group of folks who were going to start it on a healthy, productive measure. And I hope you take your role in that with a great deal of pride, as I take the chairman's role in that with a great deal of pride. I want to start with the numbers, Mr. Ballhaus. I appreciate what you do, what you did as a trustee. I used to read your work regularly. I read it less now that you're in the think tank world. I read it more when you were in the government world. My understanding is that our payroll taxes, our Medicare and Social Security taxes, are the largest tax that about 85% of American families pay. And yet every time I read a report from you, or read those reports, and they hadn't gotten any better, is that there's not enough money coming in to do the things that we've promised to do. I can't believe that I read your testimony correctly, but I want to check it out with you. $32 trillion over 10 years as the best case scenario, not for the total cost of Medicare for all, but just the add-on to the current Medicare program that is already there. Am I reading that correctly?
Yes, that's a lower bound estimate of the additional federal obligations above and beyond current federal health obligations.
I sit on the Budget Committee, and we're not able to pass a budget out of the Budget Committee because we couldn't even agree as a committee on how to sort out our current challenges, much less future challenges. But it was going to be about a $4.5 trillion budget, a little under that. Best case scenario, $3.2 trillion annualized over 10 years. Worst, but more appropriate scenario is your nearly $40 trillion number the worst case scenario or an expected scenario?
I wouldn't say it's a worst case scenario. I think basically the cost estimate over 10 years would be in the region of $40 trillion if you didn't assume any particular targeted savings from Medicare for All. Of the different categories of potential savings from Medicare for All, I think the relatively most likely is probably administrative cost savings, which would bring the total down to about 38.8 trillion over 10 years. But depending on your assumptions for provider payment rates, drug costs, things like that, the additional federal costs would be somewhere between 32.6 and 38.8 trillion.
Help me with that math. Looking at your best case scenario, your lower bound, everything goes right. What are we talking about in a per American cost, per person cost?
Well, this is very crude, but it's about $10,000 per capita, per person. An
32
additional federal
trillion,
cost. So
320
basically,
million Americans, okay.
exactly. I mean, 35 trillion, 350 million Americans.
Okay.
It's about 10,000
Okay.
per person.
That's real money. And I was listening to your testimony, Dr. Collins, and as you were going through some of those numbers and talking about after the Affordable Care Act, things that had gotten better. And I want to stipulate that I agree with everything that you said about increased outcomes. What wasn't reflected there, though, is whether we got the best bang for our dollar. Of course, if I spend $1 trillion new dollars on health care, subsidizing American families with their health care costs, when I run a poll that says, are your health care costs easier to manage today than they were yesterday, folks are going to say yes. I don't think that's the right question, though. I think the question is, we agreed to spend $1 trillion. Are we spending that $1 trillion in the way that helps the most families do the most work, do the most for themselves, reduce those stresses that we've talked about? Have you seen any data along those lines? Not did we do better, but did we do the best we could do given the enormous resources we invested?
We can actually do better. 17 states haven't expanded Medicaid, so that's one area where we haven't fully implemented the law. There have been some changes to the cost sharing reduction subsidies in the marketplaces that have bumped up premiums on silver plans, which has hurt some people, but people's tax credits adjust, and actually the federal government's paying a lot more because
Exactly
we're not paying these cost sharing reduction subsidies. So in terms of implementation, there are definitely areas where we could do better. We could extend the subsidies so that people just over that threshold for marketplace tax credits could afford their plans. But I also want to say too, on the Affordable Care Act didn't really.
Let me reclaim my time just for a second, because I understand that if we wanted to improve the Affordable Care Act in its current structure, there are lots of things that folks would do. In fact, I suspect there are lots of men and women around this table who would rather do that than the Medicare for All plan. That wasn't the question I was asking, though. My question is, and it goes a little bit to what Dr. Navi said. He said 41% of folks reported they didn't go to the ER even though they thought they needed to go to the ER. Every ER physician I talk to says, Rob, we're in a conscious effort to keep people out of the ER. People keep wanting to come to the ER. We don't want them to come to the ER. We want them to go to our urgent care center right next door, because when they come to see us, if they don't really need to see us, we're wasting valuable resources on them in our environment because it's hyper expensive. We could have served more people in more ways if we could have redirected them. And that's what I'm thinking about, maximizing the dollar that we're spending. Let's agree we're going to spend more money, but let's demand the very best of that money. And I think about that in your case, Dr. Navi. How does the Medicare for All plan, as Ms. Jayapal has crafted, what incentive is there then to do what all ER physicians are telling me needs to be done? We got to keep folks out of the ER, get them into urgent care instead. What is the skin in the game that keeps me out of your office? And
It doesn't need to be skin in the game. People want to go to their primary care doctor. They don't want to see me, and frankly, I don't want to see them. I agree with the doctors you talk to. When a patient comes to me and they want me to adjust their diabetes medication because I'm the only doctor they could see, because they're the only doctor they could access because I'm in the ER, I feel totally comfortable intubating someone, doing chest compressions, treating a heart attack or a stroke or stabbing or gunshot. I don't feel comfortable adjusting someone's diabetes or high blood pressure medication. That's a primary care doctor's job.
Your experience is that overutilization in the ER doesn't come from my misunderstanding as a consumer of what my needs are. It comes from EMTALA requires you to see me, and that's why I show up on your doorstep?
Yeah, patients often come in and they'll come to the ER. They say, I took my blood pressure at a pharmacy. I went to the Rite Aid, and they had the machine there for free. It was through the roof, so I didn't know what to do, so I come to the ER. I don't want them there. I want them to go to their primary care doctor. It'll be cheaper for them. It'll be better for them. It'll be cheaper for all of us. It'll be better for me. That's a win-win. I don't need to incentivize them. They already want to go there. They just can't get in.
That is a win-win. I think about that, Ms. Turner, and some of your testimony about your desire to do better. You've invested a lifetime in trying to move us in a better policy direction. I was visiting with a small-town doc in Georgia, we did not expand Medicaid in Georgia. And he said, Rob, you hand out all the new Medicaid cards you want to if it'll make you feel better. But I'm the only doc in 5 counties who still sees Medicaid patients, and I can't fit anybody else in my waiting room. So we're not going to achieve Dr. Navi's goal of providing more care. We'll just achieve a policy goal of feeling better about what we're doing in rural Georgia as it sits today. What policy reason is there? If I want to achieve Dr. Navi's goal of not seeing folks walk out the door because they can't pay for their care, I don't understand the policy reason to take away all of the DOD healthcare system that my men and women in uniform tell me that they love. I don't understand why we have to abolish every union healthcare system that my union members back home say, Rob, I've got the best healthcare on the planet. Why, to achieve the goal of serving the underserved, is the policy solution to take everything away from people who already feel well served?
And I think that's really a crucial issue. What do we need to do to fix the current system rather than blowing it up? Because there are a lot of systems in the employer community, in TRICARE, in Medicare, to try to provide this kind of coordinated care, to provide better access for people, more humane, better coordinated care. If Medicare fee-for-service is used as the model, all that's blown up. And can we create a new system for better coordinated care in 2 years? Extraordinarily difficult. I think we have to value what we have, build on that, and solve the problems that we have, but not destroy what's worked and what we've built over decades.
Well, even in the Medicare system, in my jurisdiction, I live in a suburban area, and so we have lots of providers. But more than 40% of my seniors have opted for Medicare Advantage. They've said, I don't want the traditional Medicare system. I have a better option. Now that you've provided that option, I'm going to choose that. And of course, that goes away too. We poison the well of productivity around here on a regular basis. And I want to thank each one of you in your testimony. No one went out of their way to poison the well. And again, you were chosen for a reason to get this conversation started. I think we can achieve Dr. Navi's goal of not having the underserved walk out on what ought to be an affordable procedure. Though I think we can do it without what Dr. Blauhaus is virtually doubling the federal budget, a federal budget that I'm not paying for today, that I'm borrowing from others. What I love about Ms. Jayapal is she doesn't hide from those numbers that you've laid out. She recognizes it's going to be a tremendous increase in tax burden for the country. You can't get to $40 trillion without that, and believes it's worth it. And that's the conversation that we have to have. I want to ask for, and I'll ask the good doctor who has more experience in the military system than most of us do. I don't hear frustrations from my servicemen and women about their quality of care. In fact, what I hear them say is, Rob, because I'm deployed all over the planet, I have to have something different than what would work in just Metro Atlanta in general. Is it necessary to achieve the goals that you want for America and our healthcare system to abolish that system that we've promised our men and women in uniform, or could we keep that system while trying to achieve some other goals?
I think you can keep that system and build on it. Medicare for all, or whatever label you put on it, can be that system. And that is what I'm saying. The government is paying for your health services, my health services, Medicare, Medicaid, VA, DOD already. You can duplicate that and label it whatever you want, because you see the efficiencies there. And particularly when we talk about the goal that Dr. Navi is mentioning for the underserved, you have to have the educational component and address the social determinants of health. If you're in an area where there's a food desert and you can't get nutritious food, you can't exercise, you have to have a whole list of prescriptions when they come in to see you and they lay it out. If you can provide them with preventive care and education, they will become healthier and not need the bag of pills, not need to go to the emergency room. And also, they have an assigned primary care provider that is going to keep them out of the emergency room?
I'm glad you raised that. It is troubling to me, again, particularly given the trillions upon trillions that we're talking about investing here, that we're only talking about treating people after something bad has happened. There's nothing in here that says what we ought to do is make sure that you're eating better before this happens. Diabetes, as it contributes over a quarter of our health care costs, nothing in here that says we need to get to exercise ahead of time. It's all a response to crisis instead of intervening before the crisis. So that's what healthcare professionals see. I don't go to my healthcare
Representative,
professional on a good day.
may
I go on a bad day. Let me ask this, and it goes to what Mr. Barkin said. I think you said 10% of American families are grappling with someone who's disabled in their household. The health care costs there are related to that. I do think it's outrageous that GoFundMe is what folks would call a successful health care system. I don't call that a successful health care system. But what I don't want to do is refocus America's resources away from your family and towards my family if I'm not in the 10% that's facing crisis. I want to focus the resources on the families that need them most. Is it clear from your advocacy and your work that we have to change it for everybody instead of doubling down on those families that we know? There's not a man or woman who is not touched by your testimony and who doesn't want to do better for you, not just on this committee, but in this entire Congress. And I worry that we're losing an opportunity to agree on that by trying to take the conversation even broader.
Representative, may I please weigh in on the cost issue?
Please.
One thing I can't help but think about today, Congressman, is how we always seem to find the money for things like tax cuts for the wealthy, and for corporate tax cuts. We never ask where the money will come from when we declare war. We always seem to just find the money. We only ask how we'll pay for it when it comes to our health. This is such a clear problem with such a straightforward solution. We can save taxpayers money, we can save money for families, and we can provide high-quality medical care for every American by doing what every industrialized nation on earth already has.
If you'd indulge me just one moment, Mr. Chairman, I thank you. I have to disagree with you, Mr. Barkin. And I do worry that kind of pithy one-liner makes it harder to get to where we need to go. It's not just health care that we have this conversation. I live in a district that's a majority-minority district. 27% of my constituents are first-generation Americans. We have the best education system in the country in our district, so says the Broad Prize that awards us year after year. We pay for that, and it's hard to pay for it. Our taxes are very high, but we make a decision every day. Are we going to have the best education system or the second best or the bottom best? Public housing in this country, Dr. Navi referenced that earlier, talking about some of our rights. We have people who live in desperately dangerous communities today, desperately unhealthy communities today, and we're not coming up with the money for those things either, because money is in every conversation. And I want to agree with you 100%. I support a war tax. I think it's absolutely immoral that we have taken the war off of the front page of the paper, and that unless you have a family member who's at risk there, I know the chairman supports that as well, and having that conversation and putting skin in the game. I would share with you most respectfully. I need you to believe that folks on every side of the aisle care as much about serving men and women in need as folks on any other side of the aisle. It's not a budget dollars and cents issue. It's a paying for those things that we value. We value you, and we want to pay that tab. And Mr. Chairman, you've been overly indulgent, and I'm grateful.
But I want to make sure that Dr. Navi, he had his hand up. I want to make sure you get.
Yeah, I just wanted to pick up on one thing you did say. You said that you talk to the men and women in uniform, and they're usually satisfied with their care. I work at a private hospital, a public hospital, and I also work at the VA as well. And that's been my experience, too. And I think you inadvertently just made a great case for Medicare for All. Our VA system is wonderful. We provide excellent care, and I've never had a patient at the VA leave against medical advice because they're worried about the cost of their treatment. So I think that our men and women in uniform have great care, and it's a federally funded program where the doctors there are employees of the government, and we have a single formulary, and we take care of patients in a great medical way and also a financially responsible way. So I do think if it's good enough for our men and women in uniform, it's good enough for all Americans.
Well, just so we don't confuse the issue, of course, the VA system stays under the Medicare for All plan. I'm talking about the DOD system. Very different conversations I have with veterans about the VA system and DOD families who are serving abroad. But I take your point. Thank you, Mr. Chairman.
No, thank you. And I'm going to, I have a, before I leave to Mr. Raskin, I get to, because I'm the chairman and you're the ranking member, we have a little extra time, so we're going to, I'm going to.
When did I get that?
You do have that extra time. You just haven't used it, that's all. You can yield it back at the end if you want. But just a couple of points. I just want to, just to Mr. Barkin's point about, you know, when it comes to certain things, we don't question money, and the cost, when it comes to health care, we do. That's just a fact. And I know it's an uncomfortable fact, but it is. I mean, we passed a tax cut bill, which I know you guys supported. I didn't support it, but we didn't even have a hearing on it in the committee jurisdiction. And it came right to the Rules Committee, and it went to the floor. I mean, we could argue whether that was a good idea or a bad idea. I think it was a bad idea, but it's just the issue of how we're going to pay for it never really came up. And you and I have agreed on the issue of the need that when we're engaged in wars halfway around the world, we ought to pay for it, not just put it on the credit card. And we just don't do that, right? I mean, we make believe that we don't have to. But when it comes to healthcare, we do. But I just want to Mr. Woodall raised two important points. I mean, one was that Medicaid rates are lower than private insurers, but that's when they pay. Right? But we know that private insurers don't always pay. And Dr. Collins, I just would appreciate if you could explain this for us. And also, would Medicare for All say pay? Would it pay the lowest rates? If we had,
Actually, Medicaid rates would go up under Medicare for All proposal.
And just the issue of I mean, insurance doesn't pay oftentimes. I mean, that's what we all have. We do casework all the time in our districts where we have people who have issues, and when it comes to paying for the bill, the insurance companies say no. I mean, that is a reality in this country, right?
That's exactly right, and surprise medical bills are a huge issue right now. Congress has taken up this issue. People are getting bills for services that they thought were covered, and that continues outside of the surprise billing issue. People have very high deductibles. People talked about how great employer-based coverage is. About 12%, people across the country, about 12% of their premiums and deductibles comprise about 12% of median income. So employer-based coverage is one of the largest sources of increase in the underinsured rates that we're seeing. So
and just one final, I mean, I've talked to a lot of hospitals. I have a lot of hospitals in my district, and in Massachusetts, we have some really fine hospitals. But one of the things they complain to me about all the time is the fact that they invest so many man and woman hours into getting into filing claims with insurance companies to get them to get paid for what they've provided, and sometimes they get to the point where it's not worth the time, and they just eat the cost. And so that's another issue as well. So I throw that out there to kind of make sure that people appreciate that fact. I'm now happy to yield to Mr. Raskin from Maryland.
Mr. Chairman, thank you so much. Before I begin, I wanted to submit for the record a statement from Egan Kemp, who's the healthcare policy advocate for Public Citizen, which makes the important point that even Americans who have insurance today are facing spiraling costs, and that a Medicare for All system will enable us to lower drug prices and restrain the extraordinary growth in drug prices we've been seeing. I also want to recognize the presence today of the president of National Nurses United, Gene Ross, who is the leader of an organization that has been heroically fighting for health care for all Americans for many decades, and I just wanted to recognize her. Mr. Chairman, thank you for calling this historic hearing, which is a breakthrough in the national dialogue about health care and what we're going to do to deliver health care to all of our people. I think not since Senator Kennedy had a hearing several decades ago about healthcare have we had one that is this comprehensive, this detailed, and this serious, and I want to thank colleagues on both sides of the aisle for participating. I especially want to thank you, Mr. Barkin, for your very lucid and poignant and compelling testimony today. And I wanted to start by saying that 9 years ago, I sat where you sit, metaphorically speaking. I was suffering from reflux symptoms and went to the doctor who recommended that I go in for an endoscopy, and they said, while we're at it, why don't we have a colonoscopy? We wouldn't normally do it this early. I think I was 47 at the time. But let's just go ahead and do it. And when I woke up, they said, well, we've got good news and bad news. The endoscopy went fine, but we found something in the colonoscopy, and I had stage 3 colon cancer and was off to the races. And I did it all. I did radiation, I did chemotherapy, I had surgery twice, and I can't imagine any of my fellow citizens going through such a trauma, something of such an enormous emotional, psychological, and family strain as that, and not know where they're going to get insurance. Now, I was a state senator, and I was covered by Maryland's health insurance plan. Most state legislators don't make very much money. I think we were getting paid $40,000, $45,000, but we had a great health insurance plan, and I was covered, and I was able to deal with it. But it opened my eyes to the fact that this is a crisis in our country, that there are tens of millions of people who don't know what they would do in the event that they came down with a diagnosis like that. Like Mr. Barkin, I decided that I was going to try to go through this personal crisis by staying at work and by engaging with the things that I loved. And one of the things I was working on was I was leading the floor fight in Maryland for marriage equality. And we adopted marriage equality. We became the first state in the union to do so without a judicial order compelling us to do so. Mr. Chairman, all glory to Massachusetts in all cases, but Massachusetts did have that judicial order from the Supreme Judicial Court telling them they had to do it. In Maryland, we didn't have that, but we passed it anyway. And, as the floor leader, you've got the opportunity when it's all over to make a little speech. And I got up to thank my colleagues because I had been wearing a chemo belt to the debates and to session for several weeks. The guy who sat next to me, Jim Brochin, who's a great conservative Democratic state senator from Baltimore County, said that I just wore the chemo belt to try to get sympathy and votes for marriage equality, which is probably right. But we ended up pulling him over and changing his mind about it, so it worked, I guess. But I got up and I said, that I had learned something in this process about the difference between misfortune and injustice. Because if your life is going great, you've got not one but 2 jobs that you love and a wife that you love, and my wife is here today, and kids that you love and constituents you love, and you go to the doctor and the doctor tells you you got stage 3 cancer and you got a 50-50 chance of coming through it alive, that's a misfortune. It's a terrible misfortune, but it's just a misfortune because it's built into the nature of our species, Any of us could be assigned such a verdict on any particular day. Anybody could get such a diagnosis. But if you experience such a misfortune and you get such a diagnosis and you can't get health care because you love the wrong person, or you lost your job, or you're not working, or you're too poor, that's not a misfortune. That's an injustice, because we can do something about that. And life is hard enough, Mr. Chairman, with all of the illness and accident and heartbreak, for government to be compounding the misfortunes of life with the injustice of denying people access to health care when they get sick. And in the richest country in the history of our species, at its richest moment, not to advance forward to adopt a Medicare for all system is to deny, I think, the common humanity of our fellow citizens. And I read an essay during that period by Susan Sontag, who said that everybody's born with two passports, and one passport is to the land of the healthy and the living, and the other is to the passport of the sick and the dying. And we all hope that we're just going to use one of our passports in life, but in truth, all of us are going to use both of those passports. And to me, it is an elementary question of democratic solidarity and equality whether we are willing to acknowledge that all of us are going to use those passports and we should make everybody's trip as easy as possible. So I'm a co-sponsor of this legislation. I'm not going to hide that fact. I'm not just a neutral, objective questioner here. But I am fascinated about how we're going to get through this process and bring everybody aboard and come up with a system that makes sense to all Americans. Now, I want to ask a question that came up before. I think Mr. Barkin raised it, about how we ended up tying in our society healthcare to people's employment. I read something, and I don't know whether it's true, but I read something which suggested that it goes back to World War II when there were wage and price controls, and employers, in order to attract new talent, had to give them something better than higher wages, and they offered them health insurance. And that began quite accidentally, quite arbitrarily, the connection of employment and healthcare. And I just wonder if anybody could illuminate that for me. Perhaps, Mr. Baker, you could.
Yeah, I mean, that is in fact the history, and of course it's spread, to a wider range of employers, so that the vast majority of people below Medicare age are getting their insurance through their employer. And this has come up previously. I could speak now as a former employer, because I was a co-director at Center for Economic and Policy Research for 17 years. We hated having to deal with our health care insurance, just for obvious reasons. We're busy. We're trying to do lots of other things.
And most small businesses hate it because they're not in the healthcare business, right?
That's exactly
they're
right.
Running
and
a movie
on top
theater,
of that,
or they're running a think tank or a farm.
And we're trying to keep our workers happy, obviously, our employees happy, and they have different needs. And, we're trying to find frankly, I don't know and I don't want to know what's the best insurance plan for my individual workers. But we had to talk about one size fits all. We had to pick one plan that was going to be better for some people, worse for others. We didn't want to be in the business, and I can't imagine any employer
So a Medicare for All system will liberate small business in America from the obligation of trying to figure out what's the best health care plan for their workers and from paying for it. Is that right?
That's right. And I should also point out, we had an insurance broker, an additional cost. We had someone who would go through the plans with us. This is total waste.
You described in your testimony, Dr. Baker, how financing Medicare for All starts by looking at how we're spending money today and then making it more efficient. And in many ways, that description of how to finance it sounds remarkably similar to a study done by another witness here, Dr. Blauhaus, from the Mercatus Center. And in a piece for the American Enterprise Institute, he wrote the following, quote, Medicare for All supporters are correct to observe that Americans already pay for the vast majority of health spending that would occur under Medicare for All, and that most of the Medicare for All's costs are therefore not new to the national economy. Do you agree on that point?
Absolutely. I mean, clearly there'll be some increase in utilization, and that's partially the point. But I think that's limited for two reasons. One, that the people who most heavily utilize care, and this is something we have to keep in mind, basically 10% of people account for 70% of the cost. Most of those people already are not limited by cost, strictly speaking, because they're either on Medicaid or they've hit their out-of-pocket maximum. So these are the big, where we might expect big increase in cost. But the other point that's been made by several people here, you have a lot of people that incur high costs because they're not getting the care they should need at an earlier stage. So then they end up going to the emergency room with very expensive care when they could have had very simple care if they'd had access to a primary care physician.
The other industrialized countries on earth have arrived at national health care plans, the kind that has proven so elusive for us. I want to ask a couple questions about that. And the first, and perhaps Dr. Collins, I can start with you. What is the principal value they are seeking there? Is it justice for everybody so that everybody gets health care? Is it efficiency of the system? Or is it the public health in general, to advance public health? What are the values they're seeking to vindicate?
I would say certainly all three. I mean, I think that having universal coverage enables everybody to get health care that they need. It definitely promotes a more efficiently run healthcare system. People have access to care that makes them productive. We have a big problem when we have 30 million people uninsured, so it reduces their overall productivity as well. So I would say it's all three of those things.
Okay, and Dr. Brown, do you agree with that, that all of those values are achieved?
Oh, certainly. And I think you also have to look at, if you have a healthier workforce, you're going to have cost savings in your employment business, because the time that you lose for sick days and getting off and taking care of family and all of that would not be achieved, because you're then fully working and staying healthy. So yes.
Thanks, Dr. Navi. I've got a question for you, because I've received an increasing number of visits from doctors and nurses and people in the healthcare system who say that the current system we've got is not working for patients, and it is interfering with their ability to deliver quality health care to people for a whole host of reasons, including the ridiculous amount of time that they have to spend on bureaucracy and fighting with insurance companies whose financial model is to not pay for people's health care. The question I want to ask you is this. I think it was Ms. Turner who said we shouldn't just blow the whole system up. Of course, some of my colleagues across the aisle voted 70 times to blow up the Affordable Care Act. They wanted to take that system down. But I want to ask you a tough question about the transition from the Affordable Care Act to one that covers everybody and tries to lower costs in the system, squeezing out the money that we all pay for copays and deductibles and constantly escalating premiums. As I understand it, President Obama said, we want to reach across the aisle and we will go to the plan that was cooked up at the Heritage Foundation. Now that fact has been buried, but this was the Heritage Foundation plan, the Affordable Care Act, and it was the model for what Governor Romney did in Massachusetts, right? And so the idea was, let's take the Republican plan of the individual mandate, which they came to revile and denounce, and put that at the heart of the system. They considered it an expression of individual responsibility. Then what happened was it became politicized, and rather than that compromise working, they turned on it, they renamed it Obamacare. They voted dozens of times to try to destroy it and not replace it, but destroy it and leave nothing there, despite the fact that tens of millions more people got health care because of the Affordable Care Act. It was a giant step forward, and yet we know of what its limitations are. Now, is it going to be possible for us to move from the Affordable Care Act with its limitations to a Medicare for all system? Is that going to be too complicated for us to accomplish?
I don't think it's too complicated, and I also would say that we actually need to do it. I think just expanding the Affordable Care Act wouldn't cut it. And I gave 3 examples earlier of the 28-year-old female that had the urinary tract infection that tried to drink cranberry juice to solve it, and the gentleman that stopped taking his antiplatelet medication, and the lady with the depression medications. All these people, I don't know if I made this clear, they all had private insurance, and it just wasn't cutting it for them. They ended up having these problems despite having private insurance.
Well, sometimes people think Medicare for all is just for the 30 million people who have no health insurance. Mm-hmm. That, for me, probably would be enough. But it's actually for the 45 or 50 million Americans who have a weak insurance plan, where the premiums are always going up, the deductibles are going up, the copays are going up, and it doesn't work for them. So what we're looking for is a system that's going to serve all Americans. Now, it's been suggested by our distinguished colleague that, well, we don't want to interfere with the plans that are working. The plans that are always cited in that question are single-payer plans, like the VA or the military. So they say, don't mess with the people who have single-payer now because they love it, and then the point of the political opposition is to try to scare everybody into thinking, wow, if we have single payer for all Americans, if we patriotically bring everybody in, then it's going to interrupt the single payer provision that we've got now, right? Is it the case that we cannot afford a system that works for all Americans without taking away health care for people who are getting it from the VA or getting it from the military and so on?
I'm not an economist, but as an ER doctor, one of the first things you learn is that when things are getting crazy, you need to stay cool, calm, collected. Oftentimes, when everyone around you is yelling about all sorts of things, usually the problem's not that hard to deal with, and we could deal with it. So from a big step back perspective, I apply something that I call the look test to this. Just look at what's out there and what makes sense. So if someone's coming here and arguing that heavier than air flight is not possible, but I just point to an airplane, I say, but look, I see an airplane, so I hear what you're saying, but that can't be true. So the corollary to that is that when everyone starts yelling and screaming that doctors are going to get paid so much less and these systems can't function, the hospital is going to have to close, I would just point to other countries that are doing similar things, and I would say, I hear you, but it seems to be working just fine.
And do any of the economists want to weigh in on this point? In order to have a Medicare for all system, do we have to?
I'm going to lend you 2 minutes of my time.
Oh, forgive me. I didn't
Congressman.
realize it was over. Okay, let me just, I thought it said 2. Okay,
Congressman, may I make a comment?
Mr. Chair, I'll yield back. I'm sure the answer.
Did I get my 2 minutes back?
Congressman,
Yeah.
may I make a comment?
Sure.
Congressman Raskin, 10 years ago, just before you got sick, when I was in law school, you came to speak to a student group. I was so inspired and amazed by the vision you laid out, and I decided that you were the kind of lawyer and public servant I wanted to become. And your comments today once again inspire me and give me hope for the future. Thank you.
Thank you, Mr. Burke.
Thank you very much. Before I yield to Dr. Burgess, I want to ask unanimous consent to insert in the record an article that appeared in the Washington Post back in June of 2018 entitled House GOP Plan Would Cut Medicare and Medicaid to Balanced Budget. And I do that not to break the spirit of camaraderie here, but simply to point out that, you know, when you complain about the lack of adequate reimbursement of Medicaid, and that providers don't want to oftentimes take Medicaid, and then you support a budget that cuts Medicaid, that it's a little bit kind of not consistent. I don't know, but anyway, I ask that be put in the record. I also want to acknowledge that during the hearing, Congressman Adam Schiff came in, and now we have Congresswoman Ilhan Omar is here. We are happy to have you. I'm now happy to yield to Dr. Burgess.
Thank you, Mr. Chairman. I take it under advisement that you said you're happy to yield to me. So it's interesting. I used to be a student of medical irony. I am a physician as well. Worked in ERs when I was putting myself through residency at Parkland Hospital. We didn't have CAT scans back in those days, so you got operated on for appendicitis. So it was probably a lot cheaper and more direct. However, I used to be a student of medical irony. Now I've kind of branched out, and policy irony is part of my realm as well. And it's just, I find it ironic that we are here today criticizing employer-sponsored insurance, that it's so bad, and yet the Affordable Care Act that we debated in this room many, many years ago had an employer mandate built into the Affordable Care Act. Employer insurance is so good, we want to require everyone to have it. So just a point of historical context, and it's not my goal to relitigate the Affordable Care Act and how we got here. There are good books written on it. I think one of our witnesses has written a book. One of your committee members has written a book. So I encourage you all to check out Amazon. I'm sure they're still available. But I do have to say that, you know, as the Affordable Care Act, President Obama was elected. He was elected on a healthcare, he said on a healthcare mandate. And I reached out to the transition team when I said, look, I didn't give up a 25-year medical career to come up here and sit on the sidelines while you all do this. Talk to me. There may be some places where we can work together. And they thanked me very much for my participation. That's the last I ever heard of them. Same with then Chairman Waxman, who was the new chairman of my committee, the Energy and Commerce Committee. And same discussion with Chairman Waxman. I didn't quit my day job to come up here and watch somebody else do healthcare reform. Talk to me. There are perhaps places where we could work together. And again, I never got a response. So again, my purpose was not to relitigate the Affordable Care Act, but it's come up several times today. And yeah, there were some missed opportunities. And I say that having been part, and just for people who are watching at home, this, I don't want to say this committee's not normal, but normally healthcare policy would come through one of the committees of jurisdiction, what are called authorizing committees. Mr. Cole is an appropriator, so he pays for everything we authorize very graciously. But one of the authorizing committees would have had this type of hearing and probably done it over several iterations. But this hearing in the Rules Committee is somewhat unusual. I mean, I haven't been on the Rules Committee more than 8 years, but it's unusual in my experience. We had 2 primary hearings when Republicans were in the majority, but they were on things that were outside of the normal realm of the authorizing committee. So it's just, I want you to know, it's a little unusual to have this here, but it also indicates.
Gentlemen,
that
there's a new sheriff in town. That's why we're doing the hearing.
What's that?
There's a new sheriff in town. That's why we're doing the hearing.
And exactly the point. This issue is so important to the Speaker of the House. This is the Speaker's committee. This committee is not, this committee is 9-4. Mr. McGovern is never going to lose a vote in this committee. If he does, he'll probably have to leave town. So this is the Speaker's committee. So the ratio was set up by a Texan, Sam Rayburn, who everything up here is named after Mr. Rayburn. Got a room downstairs, we've got a building over there. I've got a freeway at home named for Mr. Rayburn. Mr. Rayburn set up the ratio of the Rules Committee in 1961 to facilitate enacting the agenda of a young activist, President John F. Kennedy. And the ratio has stood ever since. But it is unusual to have this hearing in the Rules Committee, but I make that point because this is the Speaker's committee. The Speaker has elevated this. This is what the Speaker wants us to be talking about today, this week, this month, and so we shall. I do have a number of specific questions, and I apologize for forgetting. It's just hard because I devoted my time and experience to one of the authorizing committees that deals with healthcare, NIH. Our committee, the Energy and Commerce Committee, produced cures for the 21st century. I mean, we can argue about how we're going to pay for things, but if we ain't got the things to pay for, it's a crazy argument. And Dr. Brown, thank you so much for being here. Thanks for your service to the National Medical Association. I will tell you, when we were doing cures and it had gone through all of the machinations that we could go through in the committee, and the House had passed it, the Senate dragged their feet, and then an election happened, and they decided they better get busy and pass cures because things weren't getting any better for them after the 2016 election. So they did. They passed a version of cures. We quickly got a conference committee together, worked out the differences, and Mr. Rush, Bobby Rush, on our Energy and Commerce Committee came up to me and said, "Doc, we forgot sickle cell." And, well, we didn't really forget sickle cell. We were trying not to be disease-specific. It was about funding for research in the broad perspective. But I got what he was saying because several months before, we'd had a hearing in the Energy and Commerce Committee in the summer of 2016, and we had a witness from the Sickle Cell Disease Association, and she made the statement that it had been 40 years since a new sickle cell treatment had been approved by the FDA. 40 years. That meant the stuff that I was using at Parkland Hospital in the 1970s, that was state of the art. I could probably go back to work tomorrow because it hadn't changed. That was an astounding statement that day. So obviously we were at a point with the Cures bill that nothing could be changed. The Senate had agreed, the House had basically agreed, and we were going to go to the floor for a vote, and the president was going to sign it. I think it was the last bill signed by President Obama. It's a great bill and evidence of what the Energy and Commerce Committee is capable of doing if we take our time and do things correctly. I did make a commitment to Mr. Rush that I would work to get a new sickle cell authorization. It hadn't happened since 2004, and that was tacked on to one of the Bush tax cuts, so it wasn't a true sickle cell reauthorization. And the next month, when I was chairman of the Health Subcommittee, we passed a sickle cell authorization bill. And it took the Senate forever, it always does, but in October they passed their version. We approved their version over here on the House floor, and the president signed into law. The first major sickle cell authorization that had been passed in certainly over a decade, and with no new therapy. And then here's why this is important, because I normally don't watch 60 Minutes. I don't think I watched it the night it was broadcast, but someone said you should go to YouTube and look at this 60 Minutes broadcast on sickle cell. And if I'm not violating copyright laws, I encourage people to do that. It was a fantastic discussion of what someone is doing at the NIH with fixing the genetic defect that causes sickle cell. I mean, that's unheard of. It's a 2-base error, and it seems like something, it's just a spelling error. It seems like spell check should have caught that, but it didn't. And this doctor has worked out a system where they are actually able to put that corrected DNA into a patient's cells. And I got to tell you, I'm an Episcopalian, so I don't emote. But when I saw that picture of the blood film on 60 Minutes, that young woman who they were treating, and these were all normal red blood cells, I mean, I broke down and cried. That is incredible that that child could have that blood film picture. And doctor, you know from your time in the emergency room, sickle cell patient, I mean, they go into a crisis and it's tough, but not a lot you can do. And people worry about prescribing opiates now. We should be judicious, but at the same time, these are people who need pain relief, and the old treatments of hydration and Thorazine, I suspect, is still one of the things that you do. But this was a great step forward. And again, I bring that because the authorizing committee did that. Another bill that we did, I hated the sustainable growth rate formula. When you talk about Medicare for all, oh my God, there was one point where the Congress said, you know what, we're just gonna cut your medical reimbursement for doctors, not for hospitals, not for insurance companies, not for pharma, just for doctors, 20-some% every year. Oh my God. And it never goes away. It was written in a way that even if Congress came back in and added some money, which we would do every year in December, called the Doc Fix, if we did that, it still added on to what the eventual cost at the Congressional Budget Office would score as if you're going to repeal this is what's going to cost to the vagaries of something called the update adjustment factor. And I'm not an economist. I don't understand what that is, but it was bad. I know that. 13 years it took me to repeal the sustainable growth rate formula, and I did. And I did it in a bipartisan fashion. We had a 51-0 vote in the Energy and Commerce Committee. We had 393 votes on the floor of the House. We had 92 votes on the floor of the Senate. So that was a great example of bipartisan cooperation to correct a major problem that we had with delivery of our health care. But you can't stop there. And this is one of the things I learned, that when you finish a big bill like that and hand it off to the agency, with all due respect for anyone who might have worked at the agency at one time in their life, when you hand it off to the agency, things can happen to it. And you've got to keep your eye on it. As members of the authorizing committee, we've had multiple oversight hearings on the implementation of what's called the Medicare Access and Chip Reauthorization Act. So this was a major Medicare improvement that was agreed to in a bipartisan fashion. But, I mean, there's not a day, not a week that goes by that someone does not call my office with some concern about something that they're going to either not be able to do or be required to do because of something the agency said, rulemaking that the agency makes. So I encourage people when they read this bill, this Medicare for all bill, and it is a real bill and is a real consideration. This is the Speaker's Committee. We're considering this bill in the Speaker's Committee. I worry about it because of the number of times it says in that bill, the Secretary shall, we're talking about the Secretary of Health and Human Services. With all due respect to anyone who might have been a Secretary of Health and Human Services at one time, that's kind of a difficult way for health policy to evolve, because then it goes out of the realm of the People's House to the agency. And what was the statement that Mr. Raskin made? Ridiculous amount of time spent on bureaucracy. If you think that's going away, if the fine folks over at the Hubert H. Humphrey building are in charge of everything, if you think that ridiculous amount of time spent on bureaucracy is going away, it ain't. It will still be there in some form or fashion, and it quite possibly could be worse. So I appreciate your indulgence. I just had a lot I wanted to get off my chest. Ms. Turner, let me ask you, because this comes up all the time, in the issue of administrative cost in HHS, in CMS. I mean, administrative costs, that's a little bit of it's a little misleading, because if I want to go out and start an insurance company, never do it, but if I did and I was going to take care of a lot of people, I would have to go out and borrow a lot of money. There would be a cost of capital that I would incur. CMS does not have to account for the cost of capital, do they?
No, Dr. Burgess. Actually, Merrill Matthews with the Institute for Policy Innovation has did a study with an economic consulting firm some time ago, looking at the comparison of Medicare administrative costs with private insurance. And he said most of these comparisons are really apples to oranges. And when you conclude everything, including not only cost of capital, but the federal government's ability to collect premiums and resources, and the difference in the population of Medicare versus those that are younger, that it comes out pretty even. But I think the key point is that somebody's going to have to determine what benefits are allowed or not, who's going to be an authorized provider, how those providers are going to get paid, how the paperwork is going to get collected.
And we turn all of that over to the secretary with this Medicare for All
Well,
bill.
somebody's still going to have to do it. And
Correct.
so I think that all of the processes of providing services that the taxpayers are going to be paying for and are part of this program are going to have to be documented. That's not going to go away.
Let me just take what time I have remaining, and I need to enter into the record. As you consent to enter the record, we're limited, only have 2 witnesses on the Republican side, so we're not able to have a patient. I wanted to bring this article that was printed this morning, cbc.ca. A mother in Nova Scotia living with cancer is challenging Premier Stephen McNeil to meet with her after a years-long battle with the province's healthcare system. In an emotional video, she said she went undiagnosed for 2 years because she couldn't access a family doctor. By the time she was diagnosed, her cancer had progressed to stage 3. This is the face of healthcare in Nova Scotia. I cannot receive help for trauma that I experienced because of the failed system until sometime in July. That's for the mental health that she thinks she requires. Doctors in Nova Scotia replied. Tim Holland, president of Doctors for Nova Scotia, says this is the first time he's heard this kind of story. He said this experience has all the elements of the problems that Nova Scotians are facing with their healthcare system: lack of a family physician, lack of access to emergency care, and knowing full well that those emergency departments aren't equipped to be diagnosing cancer, are stretched thin themselves. And I would like to insert that for the record.
Dr. Burgess, can I just say that I think we mustn't ignore what we see in other countries. In Canada, if you can't access a primary care physician, you can't get to see an oncologist. And the Fraser Institute, a Canadian think tank, actually spends a great deal of time tracking what is the average wait time. The average wait time is about 5 months for specialty care. We see in the UK, we see ambulances that are driving around London for hours waiting for the emergency room to be able to let a patient in. When they get in, they're often warehoused in hallways. People die. There's an example in my testimony, people dying in a hospital emergency room hallway waiting to get care. So we have to look at the experiences of other countries. That's how they ration care. They ration through waiting lines and the lack of access to new medicines. The United States, we have access to almost more than 95% of all new medicines. In France, half of them. So that sickle cell treatment may be available theoretically, but are you going to get it if the state has to pay for it?
I need to yield back. I know I have more time later.
Well, I'll use my time, but Dr. Navi had a...
I just did want to bring something up. And first of all, I do want to say, Dr. Burgess, I'm always impressed the way medicine was practiced back then, and I always am thankful for the luxuries that our generation has in dealing with this. So I did want to say that. But I did want to comment on something you said about kind of going through the normal protocols and taking our time and making sure we do it right. I do think that's critically important. If we're going to do something of this scale, we have to make sure we do it right. But on the flip side, I'm part of the reason I'm here because my patients are suffering and they're dying. So I want to advocate. We just need, I think, a little bit more of a sense of urgency. We have to go through the right channels. We have to do things right, and we have to take our time. But we have to do this with a sense of urgency that people are dying as we're waiting and as we're doing this, and we need to have that fire to keep moving, whatever the solution is. And I do think that's critically important. At the end of the day, a lot of people here have mentioned that this is the United States. We're the richest country in the world, but we're also the boldest, most entrepreneurial country in the world. If we decide we want to do something, we can do it. And I'm a little bit worried that there's a lot of finding problems with the solution rather than finding solutions to the problem, as my dad would say. And I think we need to invest more to try to start with the starting position that we can get this done and we need to get this done because people are dying and people are suffering, and then go through all the right channels, as you said, and do it the correct way.
And Dr. Collins, I want to yield to you, but I just also would like some clarification here. I mean, we've heard that kids, seniors, workers, everybody would lose their coverage under Medicare for All. I mean, is that right? And will all of us be left without health care under Medicare for All? And how would that coverage be better than today?
I mean, the way the bills are structured, that everybody would move from the current coverage they have, for the most part, and into a new system of plans with more comprehensive benefits in many cases. So it's not true that people would lose their insurance coverage.
And did you have a?
I did want to just address the wait times in other countries and the rationing of care. I mean, clearly we are rationing care. Insurers are rationing care right now. We are rationing care by leaving so many people uninsured. So it's all a matter of how you use that term. But also in other countries, we actually have wait times that are very consistent. In our surveys of international systems, we show that wait times, we find that wait times for specialists are about the same as they are in the United States. In countries that have had wait time issues, like the UK, they have addressed those. So it is not. It doesn't mean that a single payer system there is going to be a single payer system here. There are ways to address wait times, and certainly other countries have done that.
Yeah, and I just want to say something about the Rules Committee. Since it was brought up that it's unusual that we're having a hearing in the Rules Committee, it's not so unusual. Actually, this is the oldest committee in the Congress, and we do big things. I'm proud of the fact that we moved the Affordable Care Act forward, and we insured 20 million people who didn't have health insurance. And I think it shouldn't be unusual that we do hearings. You know, when we did the Affordable Care Act, the House held 79 bipartisan hearings and markups. We had, over 239 amendments. 121 amendments were accepted. I mean, this was an enormous undertaking. Is it perfect? No. And you contrast that to, the way my Republican friends handled the repeal bill. It basically bypassed the hearing process entirely. We just came right to the, right to the floor. So there is a contrast here. I don't think hearings should be viewed as unusual or undesirable. This is an opportunity for everybody to be able to say what's on their mind, pro and con, and that is not a bad thing. Yeah, Dr. Navi?
Yeah, I just wanted to say one more thing about rationing. You mentioned that we are already rationing with the uninsured, but we're also already rationing with the insured. When 41% of Americans felt like they needed to go to the ER in the past 12 months, but then didn't, and considering only 12% of Americans are unemployed, that's still about a third of Americans that have insurance that feel they need to go to the ER but don't. That's rationing by any other name. That's self-imposed rationing, and that's part of the crisis.
And Dr. Brown, quickly?
MR. Chairman, may I make a comment?
Absolutely.
Anecdotes aside, we know that single-player systems in other countries have better outcomes than we do.
Dr. Brown?
I want to thank Dr. Burgess for the support of the sickle cell bill and how that has come about. And yes, we have one new drug that was just recently approved for the disease. And speaking to Mr. Raskin's comment, I want to say that even though I have a niece who unfortunately died from colon cancer, she was at the age of 48, so she could not get the screening test because her insurance did not cover it. She waited too late and she had advanced stage disease and died. So again, having Medicare for all or universal health coverage would allow those individuals to get the kind of screening test that does not follow those guidelines, because at any age, if you're having symptoms, you need to be treated.
Thank you. We appreciate that. Ms. Scanlon?
Thank you, Chairman McGovern, for the opportunity to participate in this hearing to help us explore how we continue to try to make good on a commitment to accessible and affordable universal health care. I'm grateful for the expertise and effort that my colleagues, especially Congresswoman Jayapal and my fellow Freshwoman colleague, Congresswoman Shalala, have put into introducing and analyzing this legislation. I have no question that health care is a human right and that no family should have to go bankrupt or worry about putting food on the table due to medical costs or have to create a GoFundMe page. I understand that we have to find a way to address what my colleague, Mr. Raskin, called the injustice of being unable to afford medical care when hit with the misfortune of medical trauma. You know, I've already supported measures that would try to lower prescription drug costs, allow Americans over 50 to buy into a public option, but I'm trying to parse the best way forward from here to protect the Affordable Care Act and move to whatever our next step is. There are constituents in my district who believe that Medicare for All is the best path forward, and there are others who are concerned about how it's going to work. And those concerns are multifaceted. They're rooted in fear of rising costs, changes to their existing employer or union-based insurance, and for many, the impact on their jobs. So it's my hope that I can get some information from this panel to help get answers to these important questions that I can take back to my district as we have this critical conversation about what a just transition to Medicare for All would look like and how we achieve that elusive universal coverage. So Dr. Collins and Baker, when we're talking about best ways to get to universal coverage, including Medicare for All, one of the things we talk about a lot is the financial burdens of the current health system on individuals. So whatever we do, how do we address the cost of rising premiums, prescription drugs, copays, deductibles? Can you talk about the impact a Medicare for All system would have on those premiums, copays, and deductibles for individuals? Dr. Baker first.
Well, of course, if you did go the full route of Medicare for All, basically those all go away. I mean, this is basically what we're doing is taking money that we're paying out of our pocket, our employers paying for us, that will go in taxes. I mean, it's a tax increase if people think that's bad, whatever. But I mean, it's money that we're paying now, and instead it'll be paid by the government for these services. So it's, you know, it relieves that problem. There's no doubt about it. I mean, the question is, you know, how to do that in a way that's least disruptive, how to do that in a way that's as efficient as possible. But there is no doubt about it. It takes away those costs that are now borne by individuals.
Can I follow up on that? Is there any analysis of how an individual's tax burden would compare to their savings?
Well, a lot will depend on how you actually structure the tax. My friend Bob Poland, I think it was referenced earlier, at the University of Massachusetts, did an analysis, and they have a payment plan. It's, I think, a reasonable one, but I mean, it really would depend on how you decide to pay it. And also, again, you know, I'd emphasize this point earlier, getting costs down. Now, we do know we get administrative costs down. We could argue how much, but I think there's no doubt about it. We're getting rid of an insurance industry. We also get rid of the administrative expenses that hospitals, doctors' offices, other providers have. That's a clear savings. The other question is, what about the other inputs? How much will we save on drugs? I mean, I argue we should save a lot on drugs because I think we pay, I mean, basically I think it's absurd. Drugs are cheap. We make them expensive. That seems stupid to me. Same with medical equipment. And I think our doctors' pay should be more in line with doctors elsewhere in the world. But those are all things that are up for debate. How much do you depress those costs? But again, you know, point of reference, we look at other countries, they pay about half as much per person on average. There's some range there. There's no reason we should be paying so much more than other countries. So can we get as low as the average? Will it take us 5 years, 10 years? Those are all, you know, that's very, very much up for grabs. But it should mean that a typical person will pay much less in taxes than what they're paying now for their health care.
Ms. Collins, Dr. Collins?
I would just say, add to that, you know, there are, in my testimony, there are about 10 other bills that provide sort of smaller steps towards universal, ultimately towards universal coverage. And there have been lots of different reform approaches that have been modeled by the Urban Institute and RAND, and approaches that the Commonwealth Fund has modeled. So there are lots of ways to improve people's cost sharing, to lower premiums, even in employer-based plans, or lots of policies for moving us more slowly. Obviously, there are trade-offs. The Affordable Care Act, the lesson of the Affordable Care Act has been that we haven't seen any congressional change, any legislation to improve the Affordable Care Act since it was passed. So there are definitely trade-offs. But I'd also say for people with employer-based coverage, there are lots of hidden costs in employer-based coverage. People make wage concessions so that they can have employer coverage. People pay a lot, contribute a lot in premiums, even with the wage concessions, and they're seeing increasingly higher deductibles. So a movement towards Medicare for All obviously would replace those costs, because it does away with the employer-based, would do away with the employer-based system, and taxes would rise in order to finance that. But for many people, depending on how you would structure the taxes, many people would probably see a net cost of health insurance go down, depending on their income. So the incidence of taxation would matter quite a bit. But I think the controversy in Vermont really did come down to legislatures not being able to explain this change of financing from premiums to taxes to their constituents.
If I could also just add quickly on Vermont, I think everyone of us agree that at least a goal, of Medicare for All is putting downward pressure on input prices like drugs, like medical equipment, which certainly the U.S. as a consumer can clearly do. Vermont, with 600,000, 700,000 people, probably doesn't have the same sort of bargaining power.
In speaking with experts in my home state of Pennsylvania, they've talked about long-term care as being one of the big drivers in cost and an issue that we really need to struggle with, particularly with all of the aging boomers coming into the system. How does Medicare for All deal with that?
Well, the plan, the JPOL plan does cover long-term care, and that is a major problem in the current system, both because it's not covered in general, but also you do have this coverage under Medicaid, which creates this absurdity where you have many people that could get by fine with home health care that's not covered, but they could have nursing home care that is covered. It's obviously a less desirable situation for that person and their family if they could get by with having some minimal amount of home health care rather than going into a nursing facility. But on top of that, of course, it's much more expensive. So it's, what we want to do is provide people with the care they need, not have them getting care that they may not need, but that's affordable because of the way we've structured the payment system.
You had something?
And I think too, just there's been talk about people losing their Medicare, but under the bills, the Medicare for All bills, Medicare benefits would actually improve substantially, including with the addition of long-term care and home health services.
So that would be another area where there could be substantial savings as a result of transitioning to this system.
Absolutely. You get all sorts, we've had references to this earlier. You have all sorts of perversions in our current system because some things are covered. Most importantly, emergency rooms. So people can't see a primary care physician, run to the emergency room. So that's not good health care, and it's an incredible waste of resources. The people in the emergency room should be dealing with emergency situations, not someone who can't see a primary care physician.
In terms of a just transition for those whose livelihoods are dependent upon the current system, can you speak at all to how that would occur?
It really depends on how you write into what you write into the law. So can you have something where you have special employment benefits for people in the insurance industry to be the most obvious people who would lose out? I think that's a reasonable thing. It's come up with climate change as well. So what are we going to do for people in the fossil fuel industry if we move aggressively to promote solar and wind energy? So I think that's a reasonable thing for members of Congress to look at. It's not an inherent part. I know the JPOL bill has, support for that. But again, how you structure that, it really depends on what Congress were to decide. And obviously, it's a consideration that we don't want to see workers lose their jobs and suddenly be unemployed. Is this situation worse than in other industries? Because, better or worse, workers are always losing their job. I don't mean to be cryptic about that. I take that very, very seriously. But I'm just saying we have to think carefully, how does that fit in with our other benefits?
Can you also...
Representative,
Yes.
may I please weigh in on the cost issue?
Please.
It is very important to emphasize the following point: these cost savings are only possible through a genuine Medicare for All system. Other proposals to increase health insurance coverage, such as those that would make Medicare compete with private insurance, would not facilitate administrative and billing savings.
Okay. I actually was just going to speak to that subject, and what you saw as the pluses and minuses of the proposals that we moved to a public option that would force the private insurance companies to compete.
Yeah, I actually am sympathetic to that as an interim measure. I'd like to see us get to Medicare for All, but I laid out, what would you do in a transition? I said part of the story first is, we have kind of glaring inadequacies of the current Medicare program. Most obviously, there's no out-of-pocket cap, which is something I'm embarrassed to say how long I was in Washington doing policy work before I realized that, because it's kind of like, why is there not an out-of-pocket cap? Also, the fact that prescription drugs we have a separate drug benefit, that makes no sense. You don't have separate drug benefits in the private sector. Why did we think that made sense? So having those together, and also, of course, Representative Woodall made reference to the fact that many people get Medicare Advantage. Well, part of the story is we're subsidizing that. So we pay about 15%, or I think it's 13% more for a person on Medicare Advantage than the person with the same health care condition would we pay for them in the traditional plan. Those are serious problems with the traditional plan. But in terms of the savings, if you envision a situation where we actually fix the Medicare program, so we probably have, instead of 2/3 of people on traditional Medicare, probably 80 or 90%, I mean, I'm guessing here, but clearly a higher percentage. And then on top of that, we let people buy into it. I think we're talking about a massive program at that point, and I think there would be administrative savings for the simple reason that what I suspect is you'd have a lot of providers that say we don't want non-Medicare people. This is a huge blind block. Why do we want to pay with United Health and, sorry to single those out, but the point is, why do we want to play with them when we have this huge block, we know what they're doing, it's standardized, we don't have to play games. So I think there would be large administrative savings, which is not to say I don't want to see us go all the way towards Medicare for all, but I'm just saying there would be savings with the intermediate step.
I think there's some very critical design issues too in a Medicare for all, and where you set the provider rate. The bills propose at Medicare rates, but clearly some of the analyses that have been done have looked at rates that are somewhat higher. But it's a key design issue for a public plan, and going with a public plan option based on Medicare, maybe rolling it out in certain parts of the country where there are very few insurance companies, would give us an opportunity to see how that would work, where you would set the price, and what might work the best. So that would be an advantage of starting with a public plan based on Medicare or Medicaid.
And that also relates back to the chairman's concern that if we keep slashing Medicare and Medicaid funding, then it becomes more difficult to get people on the provider side to buy in.
That's right. Yeah.
Okay, thank you. I yield back.
Thank you very much. Ms. Lesko.
Thank you, Mr. Chairman. I think it's important to note that all of us, no matter what side of the aisle we are on, want to improve health care.
Generally to you, just one second. If it's okay, I think what I'm being told is that everybody needs a little bit of a break. If it's okay with you, can we take a break for votes and then come back? Unless you can't come back, then we'll go right to you.
Can I come back? I can come back.
Okay, so we're going to take a little bit of a break. Right. So we're going to take a little bit of a break. And when votes are over with, we'll come back. We have a few more people to ask questions, and then closing remarks, and then we will bring this to a conclusion. So I thank the witnesses for their patience, but I think you're entitled to a break now. Yeah, thank you.
doesn't take that one off. I guess.
That's how dated I am, not even a black.
And before I yield to Ms. Lesko, I just want to ask unanimous consent to insert into the record a statement from Congresswoman Norma Torres, who's on this committee, who wanted to be here today, but she was on a fact-finding mission to South America, and she's encountered some unforeseen problems leaving the country, so she can't be here, but I'm hoping that means that...
nothing to do with it.
Right, that's what I want to say. I ask unanimous consent to put this in, but as Ms. Torres, I know, is a strong advocate for universal health care. So at this point, I'm at where we left off. I will yield again to Ms. Lesko.
Well, thank you, Mr. Chair, and I hope Rep. Torres comes back soon. That's what, hopefully she's not being held against her will or something. Okay, you know, I just wanted to say we've had a long discussion here, and I think members on both sides of the aisle, I mean, I can speak for myself and my friends on the Republican side, we want to solve the health care problem. We do believe that there's problems in the health care right now and that improvements can be made, but I think we should do this in a bipartisan fashion because I think really big issues like this actually need to be done in a bipartisan fashion. So when I was in the state legislature, in the state Senate, I actually worked on legislation to address surprise medical bills, which had been brought up before. And I got everybody together in a room and we kind of hashed it out. It was controversial, but we got it done. So I think that if we did work in a bipartisan fashion, we actually could get things done, even though we disagree on certain issues. I do really believe it can be worked out. However, this bill is not a bipartisan. This is a very partisan bill. And I'm sure that you know that most, if not all, Republicans in the House are probably going to vote against it if it gets up for a vote. And certainly the Senate is not going to hear it. So, you know, I don't know why we're doing this, but, you know, we are. So here we are. So as we've discussed in the several hours here, several reputable studies have put that the extra price tag to the government of a one-size-fits-all healthcare system is north of $30 trillion with a T over 10 years. And as has been said before, some states have already tried to implement government-controlled health care, but the price tag is too high. In Vermont, as was stated, they said no because it said that the payroll taxes were going to increase by 11.5% and income taxes by 9%. And that was enough for even the Bernie Sanders constituents to say, no, thank you, to this government-controlled health care. Given this history and that the federal government is already running massive deficits and the Medicare program is already reaching insolvency, I think that it's unclear that this new bill is going to solve any of our problems, and it is questionable how it is even going to be paid for. I'd like to spend some time now talking about one of the most successful innovations in Medicare since its inception, the Medicare Advantage Plan programs. This bill would take that all away, as we've talked about before. All Medicare Advantage plans would be gone. And so Medicare Advantage enrollment has almost tripled from about 7 million people in 1999 to over 20.4 million people that want Medicare Advantage in 2018. The 2019 annual report of the Medicare trustees released last week indicates that 37% of Medicare beneficiaries are currently in a Medicare Advantage plan, and that this percentage is expected to rise to 40% over the next 10 years. Also, according to the Kaiser Family Foundation, 88% of Medicare Advantage enrollees have plans which include prescription drug coverage, and about half of these beneficiaries pay no premium at all, which is the case of my mother. My mother's on a Medicare Advantage plan. She loves it. She doesn't pay anything extra for drugs, and I can tell you that if we took this away from her, she would not be happy, and if we forced her into another plan, she would be confused because it's difficult, as you all know, to navigate this whole healthcare system. So I guess I wanted to point out, I got some numbers of how many people in our members here that are here present today have their constituents that are on Medicare Advantage and that would lose it under this bill. So the first one, the one that has the most people under Medicare Advantage is actually Representative Morelli. You have 98,360 of your constituents, or 66.4% of all the Medicare population has Medicare Advantage in your district. And Ms. Shalala, you have 81,043 of your constituents that have Medicare Advantage, which makes up 60.3% of all the people on Medicare. I come in third, 75,887 of my constituents are currently on Medicare Advantage, which is 44% of all of the people on Medicare in my district, and I can go on, but my point is Medicare for All would take away all of this from everyone. And so my question is to Ms. Turner, what do you think about that? Do you think seniors are going to be happy that their Medicare Advantage plans are taken away?
The Medicare Advantage allows seniors to voluntarily, as you said, to enroll in these plans that provide better coordinated care, integrated care, so that they can have one plan with their physician coverage, their hospital coverage, their drug coverage, vision and dental. They often provide additional benefits. So yes, I think seniors are gravitated to these plans because they give them more resources to deal with an ever more complex healthcare system, and they highly value it. And now about 20 million seniors overall are on Medicare Advantage, and as you say, the number grows all the time because it provides these coordinated, integrated benefits.
Thank you. And my next question really has to do with how the bureaucracy would work under this program. So I'd like to take a few minutes to walk through what I understand the process a hospital would need to go through to fix a leaking roof under this bill. So let's start off with a simple example and what happens under the current system. The roof is leaking. The hospital administrator or maintenance division calls somebody out to inspect it. Maybe they get a couple of bids, decide on a contractor, and the leak gets fixed. Pretty simple. But what happens, as I've been told under this Medicare for All bill, well, first, since the hospital has a provider agreement, it needs to get funds from the government's capital expenditure budget to fix its roof. To get those funds, they have to submit an application to the regional director. Once they submit the application, they have to wait until the regional administrator decides to review the application. How long will that take? What happens to the roof in the meantime? But that's not the end of the process. After it goes through the regional director, the Secretary of Health and Human Services has to review the application and decide whether to approve the application and how much money should be provided. Now, I'm sure that the Secretary of the Health and Human Services has many more important things to do than go through applications for funding of a leaking roof. So how long does that take? Who knows? This bill doesn't set any limits on either of these two review processes. So a hospital could be sitting for months in line, waiting for their application to be reviewed. We all know how painful it can be going to DMV, Department of Motor Vehicles, sitting in that line, waiting for your number to be called. Imagine having to go to a federal Department of Motor Vehicle for every little thing you need. Need a new x-ray machine, new application and wait. Need to buy the software upgrade for your electric health record system, new application and wait. And every single Medicare for All provider across the country is going to be forced through this one system. Everyone will be doing a lot of waiting. We need less bureaucracy in the system, not more. So that is a problem I see. Also, Ms. Turner, you have spoken about wait times in your testimony in other countries who have government-run health care. Is there anything in this bill to protect the American people from astronomical wait times?
There's not, and I do believe that that the promises being made are, that it evokes for me that your health insurance premiums are going to go down by $2,500 a year for a typical family, that everybody can keep their doctor, everybody can keep their plan. It's easy to say these things, but when you wind up with a system that's promising free access to the system without any checks, it is impossible to imagine the current system being able to meet that demand without having ever lengthening queues, and that is, of course, what we see in other countries and why the Fraser Institute keeps track of how long those waiting times are, and why in the UK, people can be waiting for a year for surgery. In Canada, the hospital may run out, the region may run out of money, and if you had a surgery canceled in late November, sorry, the hospital's not doing any more surgeries this year, get back in line.
Yeah, and so speaking of wait times, you know, it wasn't that long ago that Phoenix VA Medical Center was in the news, in the spotlight, because of really long wait times for our veterans at the hospital. And some of the claims were that veterans died while they were waiting. And so one of the solutions that has been worked on and was supported by our late Senator John McCain was that there be more freedom of choice for the veterans outside of the government-run health care plan so that they could go see a private doctor if the wait time was too long. Now, to me, Ms. Turner, does this seem like the opposite approach, like we're going to more government-run health care instead of allowing patient choice?
And this plan is more comprehensive in bringing everybody and virtually all systems under the federal government's control. Even the UK, you can buy private insurance. In Canada, you can come to the U.S. The Mayo Clinic in Rochester has a lot of patients that are Canadians coming to this United States. So the fact that people would have a difficult time finding a private option in this country, I think would concern a lot of people.
Well, thank you. It certainly concerns me. Dr. Blake,
Congresswoman, may I make a comment about Medicare Advantage?
can I ask Dr. Blahaus a question first, and then if I still have time, certainly. Dr. Blahaus, will this bill provide free health care for illegal immigrants?
Well, the bill I analyzed indicates that the benefits would be provided for every resident of the United States, and it's left to the Secretary of HHS to basically promulgate regulations that define who a resident is. There's nothing in the legislation that excludes the undocumented immigrants from receiving benefits. So my working assumption was that they would be eligible for benefits, yes.
Thank you. And as members, as you already know, I come from a district where the number one concern is border security and illegal immigration. I know we all come from different districts, and so I can tell you that my constituents, and I would guess the majority of citizens in the United States, would not feel happy that they are going to be forced to pay for illegals that aren't citizens free health care. And so with that, I am done with my questions, and sir, you had a comment.
Medicare for All would deliver all of the benefits that are currently provided for with Medicare Advantage. Seniors wouldn't lose the joys of paying for Medicare Advantage, they would receive better coverage for no cost.
Thank you, and thank you for your comment, but I can tell you firsthand experience. My mother is on Medicare Advantage. It took quite some time to figure out which program was the correct one for her, and now she likes the doctors that she has. She's happy with that. She doesn't like changes, and my understanding is that this bill would take away that program and require everyone, no matter what they are on, if they're on Medicare Advantage or not, they'd all have to take this government-run program, and I just find that unacceptable. It's not patient choice, it's government-run mandated health care. Thank you, and I yield back my time.
I know Dr. Navi was trying to be recognized. You still have 44 seconds, so why don't we yield to
I'll be
him?
real quick. So I guess one thing it's worth pointing out is that regarding undocumented immigrants, we're already providing care for them for free in the most expensive way possible. They're coming to the ER because of that 1986 law signed by Ronald Reagan, and they're getting care, and no one can stop them, and it's the most expensive place to get it. Medicare for All would provide such that these patients who are already getting care would just get that care in a more fiscally responsible way at the primary care doctor's office.
Thank you, Mr. Chair. And sir, I thank you for your testimony, but most people in the United States are not going to voluntarily want to be paying for illegal immigrants free health care. And so there's a difference between people coming here illegally and showing up in the ER. And by the way, we have a huge crisis at the border, and I hope I'm going to introduce several pieces of legislation, and I hope that Republicans and Democrats will get on board and realize we have a crisis at the border, and we have to mitigate it. But I can tell you, I go to a lot of different meetings in my district and quite frankly throughout the state. And there's not going to be anybody happy about paying their taxes for free health care for illegal immigrants.
But it's not about ideology. We're already doing that. The only difference is we'd save money in doing the same thing that we're doing now.
Well, we can debate this. Obviously, we disagree, but I can tell you I've heard loud and clear from people consistently they do not want their taxes going to pay for free health care for illegal immigrants. Thank you.
Thank you. Let me just, I have a couple of unanimous consent requests. First, without objection, I'd like to insert into the record a letter from the Washington Community Action Network, Washington State's largest grassroots community organization with 44,000 members. I'd like to insert a letter from the Labor Campaign for Single-Payer Health Care with 15 national unions and eight state labor federations and a large number of local and regional organizations. I'd like to insert a letter from the Social Security Works, an organization which seeks to protect and improve the economic security of disadvantaged and at-risk populations. A letter from Dr. John Aldis, a doctor in West Virginia, and they all support Congresswoman Jayapal's Medicare for All legislation. Also, Rebecca Wood's daughter, Charlie, there's Charlie right there, was born prematurely before the age of 3. I mentioned this at the beginning of my testimony. She had suffered through more infections, surgery, physical therapists, and injections than most of us deal with in our lifetime. Her medical costs added up quickly, and much of that was paid for out of pocket. The financial devastation that forced her family to make tough choices regarding Charlie's treatment highlights the need for adequate long-term care in this country. So without objection, I would like to insert into the record this story submitted by Rebecca Wood, where she thanks Representative Jayapal for her work. In the story, she says, and I quote, "Long-term supports and services included in this bill are crucial to families like mine. The bill would provide mandatory coverage of community-based services that people with disabilities need and want. Additionally, ensures that services are equal across geographic areas, a problem that I've personally had to contend with. I want that in the record as well." And Dr. Blauhaus, I want to thank you. This is a personal thing for me, but when talking about the issue of immigrants, you referred to this group of people as undocumented immigrants. I much prefer that than having people refer to them as illegals. It's a personal thing with me. I don't think anybody in this world is illegal, but, you know, I just would just say to Ms. Lesko, when asked why are we doing this hearing, I mean, we're doing this hearing because many of us, not just Democrats, but Republicans as well, I think are concerned about the fact that we have 29 million people who do not have insurance, over 40 million people who are underinsured, who are afraid to get sick because they're afraid they're going to go bankrupt, and we need to do better. The system that we have in place is deeply flawed and is hugely expensive, and we all think we can do better. I think Medicare for All is the way to go. Others have different opinions, but that is why we're here. And, you know, I'd love to come up with a bipartisan solution here, but I will remind my colleague that, because I've been in the minority for 8 years, and every time there was a bill to repeal the Affordable Care Act, I don't recall ever being consulted or ever being asked to be part of any kind of discussion on how we should move forward. And before I yield, I know Mr. Barkin had an additional comment he wanted to make.
Congresswoman Lesko, you said you're not sure why we're doing this hearing, given that the Republican-controlled Senate won't pass Medicare for All. First of all, if you don't remember, I want to remind you that we last ran into each other in Arizona during your election. That time, when I asked you about Paul Ryan's plans to cut Social Security, you had no idea what I was talking about. Well, it seems you have chosen to not get your facts straight today, either. Why are we having this hearing? To keep people alive.
Thank you.
Thank you. Mr. Chairman, if I could respond.
Yeah.
Thank you. You know, the reason that I said that statement is because we're going through the Rules Committee, first of all. It's not, this bill is not being heard in a regular committee.
Well, we are.
And
we are a
also,
committee.
I would like, this is a, this is a big issue. And I do believe we need to have high-quality health care at a reasonable cost for patients. And I concede that we can definitely improve on our healthcare system. But something this big, what my point was, something this big and this major, I think both parties need to work on together. And we're not going to agree on everything. I already know this. I did pension reform in my state. I did surprise medical billing. I did contentious things, but we worked through it. And I know that, you know, Representative Cole has said that in the past year, he has worked on big issues in bipartisan fashion. And that's what I think we should do. Now, this, I mean, you must concede that you don't think that this is going to pass because you didn't ask for input from Republicans. And even though we're in the minority here, the Senate is still Republican, and you still have a Republican president. Yep. And so that was my comment, why I said that, because I would hope that we would work on something that is actually going to pass, and that's what I would like to do.
Well,
Thank you.
Thank you. And again, we're the Rules Committee. We're the oldest committee in the Congress. And we're one of the committees to which this bill was referred. And I hope all the other committees do hearings, unlike when my colleagues were in charge, where there were no hearings on any of these issues. We are doing hearings. And in terms of input, I don't know what we're doing. Everybody's offering suggestions, and we have witnesses who have all kinds of opinions, and we're having this discussion. This is what you're supposed to do. This is a deliberative process, right? And so I mean, I think this has been good. I think this discussion has been good. I don't agree with most of my colleagues on the other side of the aisle have said. I think it's been a good discussion. And I think it needs to continue beyond this committee, and we are going to do that. So having said that, I now yield to Mr. Morelli.
Thank you, Mr. Chairman. First of all, thanks for organizing this hearing today. I think we have an extraordinary panel of people testifying. I think this is the appropriate place to begin the conversation around health care. And I would congratulate Congresswoman Jayapal for introducing an ambitious piece of legislation. It's brought us together. This is an important conversation about a critical issue facing America's patients and what we must do to ensure that we have quality, affordable health care for all of our citizens. Tomorrow, May 1st, should be celebrating my daughter Lauren's 33rd birthday. But unfortunately, Lauren passed away nearly 2 years ago of triple-negative breast cancer. Doctor, thank you for all your good work on breast cancer. And while it's a personal tragedy for my family and myself, we are hardly unique. I don't think there's a member in this room, I don't think there's a member in this body that hasn't been personally touched by tragedy as it relates to health care. And there's no one who has not heard from countless citizens about the many ways in which their lives are touched by the illness or by the difficulties in our health care system. After making what I consider significant progress, we're backsliding now because of purposeful action taken by the White House. At the end of 2018, the percentage of U.S. adults without health insurance reached a 4-year high. More than 1 million people across the nation have lost coverage since 2016, and almost 14% of Americans are without health insurance today. Those are numbers we haven't seen since the enactment of the Affordable Care Act. And this is in part because of the actions of the President. Cut funding for the ACA, push Americans into junk short-term health plans, which we don't even allow in the state of New York, where I'm privileged to represent, deny essential services, shorten enrollment periods for families to sign up for coverage, create burden after burden to seek Medicaid coverage, and repeated attacks on women's health care and essential family planning services. Fact is, Donald Trump does not have a plan to address health care unless you consider dismantling the Affordable Care Act, stripping away protections for people with pre-existing conditions, leaving millions of hardworking Americans without health coverage, a plan, to say nothing of the nearly 70 million uninsured or underinsured people in this country. Unlike the president, the members of this House believe it's critical we address the health care crisis head-on. Whether it's this plan or others, we can begin taking steps toward meaningful health care reform that lowers costs, improves and strengthens the quality of care, improve patient experience, the so-called triple aim of health care, and ensures every person in our nation has coverage they can depend on. And I think the American public has been clear. They want essential health benefits, protections from annual and lifetime caps without discrimination based on pre-existing conditions. And I would say that the president and many of his colleagues on the other side of the aisle, including Senator McConnell, who has indicated that the Senate, despite the talk about partisanship here, isn't prepared to even address health care until after the 2020 elections, which I consider reprehensible at the very least. I think instead we welcome the opportunity to look to the future and begin the work of making our health care system, which has serious shortcomings and concerns, more affordable, more equitable, and simpler for people in my community across this country. So I think this hearing is entirely appropriate. Having said that, there are a number of concerns. I have a number of questions regarding the financing of this system, healthcare cost trend lines, cost containment measures, some of which have been talked about, provider reimbursement. So I'd like to start perhaps, and I would ask anyone to feel free to respond, but I note that, Dr. Collins, you've talked a little bit about this, but Dr. Baker as well. Currently, as I look at it, we spend, according to CMS, $3.5 trillion a year health care, all in. That's all payers, private insurance, public insurers, and my back of the envelope, which is not very good, but even if you assumed a 3.5% increase in the CPI in healthcare, which is pretty low, but let's just for argument's sake, we would be at about $4.75 trillion in 2026. Over the next 10 years, about a $41 trillion healthcare spend. Most of that, as I think you know, goes to healthcare spends in hospitals and physicians. So what I'm struggling to understand is, and right now Medicare payroll is about, I think, $289 million out of what is right now a $3.5 trillion spend. So as I think about it, I was trying to figure out how this works. We saw today in the New York Times a number of corporations in the United States are now paying zero taxes, some getting rebates. How we will struggle to make this work unless there's a pretty dramatic increase in payroll taxes. And I recognize, and I apologize for the long question, but I recognize that people are paying premiums now. Those premiums presumably would go to pay now instead of premiums, taxes, which will pay for this spend. So there's clearly a movement of those. But there are disparities as well. Some businesses pay for health insurance right now, coverage for their employees. Others do not. So this is not as though it's going to be a smooth transition. But if you could talk about how the financing would work in some detail, and if you have thoughts about income taxes, payroll taxes, other forms of taxes, or premiums to meet that spend.
I'll take a stab at that. First off, we've talked about this. There clearly are large administrative savings. Most immediately, we know that the private health insurance industry spends about 20%, in fact, probably about 25% of what it pays out in benefits in administrative cost, whereas whereas the Medicare system, traditional Medicare system, it's less than 2%. If we use Canada as a reference point, it's less than 3%. So that allows for very, very large savings. In addition,
yeah, I apologize, but let me just, as I looked at it, the private insurance, this will help perhaps guide your answer. Private insurance is about a third of the Medicaid or healthcare spend, so about 1.2 trillion right now. And if you estimate 18% savings, which I think what others have talked about, translates to about 214 billion. So I'll give you that. But I want to talk about the tax. So let's take that out of the mix. But you still have even if you could realize all 200 billion, you'd still be at a $3.3 trillion spend. So I'll give you that $200
Okay,
billion off
there's
the
also,
top.
I'm not trying to avoid your question, there's also administrative costs that are incurred by hospitals, by doctors' offices, other providers, which would largely go away. They don't go to zero, but again, comparing the US to Canada, and there's research on this, our providers pay much more, so that would be additional savings. I also, you know, and I talked about this in both my written testimony and my oral comments, we do have to reduce payments to providers. There's no, you know, we pay twice as much for our drugs, for our medical equipment, for our doctors. You know, how much do you get those down? You know, you could argue on that, but I do think we have to get those closer in line to the rest of the world. Now, how do you get the rest of the money? To my view, I think a payroll tax has to be a very big part of the picture, because basically healthcare premiums that are paid by employers are very similar to a payroll tax now. And as you point out, many employers don't pay that. Well, I think that's a problem, you know, so you know, just as we've had other mandates on employers, and in fact, we do have mandates on employers in the Affordable Care Act, then, you know, I think you would in effect have to do that with, you know, in effect, a payroll tax would be equivalent to a mandate. So I think that would be the biggest chunk. I'd also look, and again, obviously this could be done 1,000 different ways, towards other forms of progressive taxation where you would disproportionately have high-end earners, whether it be income tax, you know, Senator Warren running for president proposing a wealth tax. I think there's problems with that. I don't think you want me to get into that, but I think we can get more taxes from high-income people who have been the big winners in the economy over the last 4 decades. So
Okay, that's, I appreciate that. Anybody have anything that they'd like to add relative to how we pay for this?
I'll just jump in real quick and just make the point I made earlier about the significant cost growth that's occurring from provider prices in insurance and private insurance. So that's a key growth push in the healthcare system right now.
Yeah, and you answered that earlier, and I wanted to just understand a little better what you said. As I sort of think about it, and this is borne by the experience of talking to hospitals, physicians, other providers in my district and around New York, is that essentially the public payers, Medicare, Medicaid, CHIPS, and other programs are too low for providers, and essentially the commercial world or the private insurance, whether it's self-insureds or the commercials, essentially subsidize payments to allow providers to be successful. But you said something earlier that I thought was at odds with that, or, and I didn't really understand that.
Yes. So the literature on the cost shift, which is a cost shift from lower payments in Medicare program and Medicaid program, are made up by higher prices in private insurance. The literature really does not show that. A study that was done in Colorado on this issue found that the higher margins that providers were getting, the higher prices providers were getting in Colorado, were going towards more administrative costs, higher margins, buildings, other things like that. There wasn't evidence that there was a cost shift. The prices were not going to fund their lower rates on Medicare.
So
and there's an enormous
be,
amount of literature on showing that.
So would your argument be that we could pay at Medicaid or Medicare rates and not substantially affect the quality of providers, or that we would not impact their ability to provide service?
You know, I think that so a key thing about the healthcare market that is so different from every other market is that prices drive costs in this market. Costs in other markets drive prices, so prices are a fair reflection of the cost of production. In healthcare, and particularly in private insurance, we choose the prices we want to pay, we choose the cost level we want to be at. So we know there's a huge amount of evidence right now that the major growth in healthcare costs is occurring in what we pay providers and private insurance. If we want to get control of our healthcare costs, we have to start focusing on that issue. And what these bills have done is bring this issue up.
Some of you have looked at other health systems around the world. You know, in Rochester, it would not be unusual to pay a neurologist, a neurosurgeon, $750,000 or more, and we're not one of the higher costs compared to some other metro areas. What would be a comparison to what a surgeon of that kind would get compensated for in another place? Canada, Great Britain, anyone know?
Odds are it'd be closer to $250,000. They would get compensated considerably lower. Now, You know, I've had arguments with doctors about their compensation because they all think they get too little, but they don't pay for their health care, for their education for the most part in other countries. I mean, to my view, that's not closely offsetting, but they don't. That is a point to keep in mind.
Yeah. I want to talk just a little bit cost
May I
containment.
comment, Congressman?
Yes, sir.
I want to say, you're asking good questions. It is important to ensure we have a clear way to pay for such an ambitious policy proposal. But we are the richest country in the history of the world. We pay for far more expensive things, like wars of choice. We can afford to do this. We just need to decide to make it happen. It's a political challenge, not an economic one.
Well, I appreciate that very much, and I agree with you that this is ultimately about what people are willing to do, but there are challenges to doing this, and there will be disruptions in the marketplace, but if we didn't go into it with a clear-headed view of what this will mean, then I think we're doing a disservice to have this conversation without talking about that. I do want to talk, and I apologize, I only have just a couple minutes left. As it relates to cost containment, utilization issues, I was involved in a practice transformation grant that we got from the Affordable Care Act I chaired back in Rochester called the Rochester Health Innovation Collaborative, where we embedded essentially case managers that were nurse practitioners that worked on social determinants of care, really tried to drive down the cost curve particularly for older chronically injured or chronically ill individuals. We had some success. I'm not really sure where I see the pressure to do that in this system. This is, from my mind, unless you have a different view, this is essentially a fee for service. Not sure how utilization declines or how you get better coordinated care, because I don't see incentives to do that, but perhaps in the last moment or so, folks could comment, anyone on the panel.
Yes, thank you so much for the question. I think if you're looking at the plan and the comprehensiveness of the services that you're going to provide, it behooves the plan to have those coordinators that are part of it, that's going to go out, and whether it is community health workers, in cancer, of course, we call them navigators, that's going to make the patients understand how to utilize the system in a more appropriate way. So you're talking about a patient-provider partnership, and you're going to bring about better care. You're looking at whether you're providing them nutrition and food services, the exercise programs.
Well, and I don't mean to cut you off. I think that those are all great, and I agree with you. The goal here ought to be to try to reduce the health care spend, or at least bend the cost curve down. And you can do that with some of those things. I'm just not sure that I see in a fee-for-service system that this essentially moves to where the incentives are to do that. I'm not sure who provides that kind of coordination, because I don't see an incentive in this. I just see fee-for-service. I'm really afraid of that because I think it blows out potentially the long-term healthcare trend lines in terms of cost.
Well, I'm looking at it sort of in a prepaid way, so you have incentives built in the program. If you're basing it on the kinds of system that we have in TRICARE, or you're looking at, and again, that's a large integrated health system, or even some of the services that's provided under the VA. So you focus more on the preventive aspect of it. You want to keep, and TRICARE and all services want to keep our patients out of emergency rooms. And so you build in emergency care facilities, you then expand your hours, you get those people to practice prevention, and again, that's not utilizing the cost that's there, and then they can get an incentive for keeping people well and healthy.
Well, and I completely agree. If there's a system that allows us to do that, and I'm not sure this entirely sets up the incentives.
Global billing is Global billing is exactly how we bend the curve. No more fee for service.
Well, I agree. I'm just not sure that this proposal contains that, and if it does, what do you do in a metro region when you exceed your, I apologize, Mr. Chairman, I know I exceeded my time, but I appreciate your thoughts on it.
Did you want to finish? Yeah.
Medicare has been a leader in innovative payment practices for providers and accountable care organizations. I mean, there is no reason why those kinds of innovations could be brought into a bill like this.
But haven't those largely been done by some of the private insurers that create the programs around Medicare, because you use private insurance right now to do it. I'd love to talk to you maybe offline, Mr. Chairman. I apologize for taking.
And we yield to Mr. Cole because he has some unused time.
Thank you very much. I appreciate that, Mr. Chairman. I only have a couple minutes here, so I'm going to kind of move you along pretty rapidly. Forgive me for that. Committees of primary health care jurisdiction right now are literally moving legislation that would make fixes to the ACA. And some of that legislation literally could be here in the next few weeks in front of this committee. So my question is this, and if you can give me a yes or no, I would appreciate it. And I'll start with you, Ms. Turner. Do you support abandoning these committee efforts to reform the ACA in favor of Medicare for all?
You know, the Trump administration is trying to do a lot of things to give people more choices who felt shut out of the market. Some of them are things like short-term limited duration plans,
I got to
assisted
ask
health
for a
plans.
yes or no, or I'm not going to be able to get all the way through the panel.
So should the
Should they abandon those efforts and focus on Medicare for all, or should we keep moving with the efforts to fix the ACA?
I think we should try to do what we can to fix the ACA, both through administrative and legislative authority.
I agree.
I think that's a false choice. I think we could do both.
It's really not a false choice. There's only so much time up here, and there's only so much bandwidth to actually move something that become law. We've debated a lot of legislation this year that is not going to become law. We have a chance, I think, to make some fixes that we probably all agree on in a bipartisan sense. So should they continue to prioritize working on that?
If you need more bandwidth, I'm happy to help. A lot of citizens that will sign up for this.
I appreciate that, but I don't think that's quite within your power legislatively.
Correct. Universal health coverage is one way to fix it.
I think that there are a lot of good ideas on the table and many bills that would move the system towards universal coverage, and even small little fixes could help millions of people.
Mr. Parkin?
Both, please. Thanks very much.
Okay.
Yeah, if you can do fixes that move the situation forward, do them. But I just don't see this coming at the expense of a comprehensive solution.
Well, I'm out of time. Can I ask one quick question?
Absolutely.
Okay, you're very kind, Mr. Chairman. Mr. Blothouse, let me ask you this. Is Medicare going broke now?
The Medicare Hospital Insurance Trust Fund is projected to be insolvent in 2026. That's actually less than half of Medicare. The other half of Medicare, by definition, cannot go insolvent because it's statutorily constructed so that you always give it enough money, but it also has financial strains going forward. So both sides of Medicare are in trouble.
Let's fix what we've got first before we launch into a new system. I mean, I think there's a lot of risk involved in this when we have a system that millions of Americans depend on that's going broke right now under the current financing mechanism we have.
Before the Affordable Care Act is projected to go broke in 2019 this year.
It suggests to me that we should be working on that, not Medicare for all.
According to this, you wanted another 2 minutes for Mr. Woodall.
If you're offering, Mr. Chairman, I accept. Thank you. And if I could ask unanimous consent, Mr. Chairman, I've got a letter from the Partnership for Employer-Sponsored Coverage that I'd like to have entered
Without objection.
into the record. As you would imagine, they support employer-sponsored coverage. And Dr. Collins, I just wanted to clarify, I think in response to a question the chairman asked you about plans going away, your response was it is not true that anyone would lose their insurance coverage. I think we so often conflate insurance coverage and health care access. I think what is actually true is everyone would lose their insurance coverage because health insurance would no longer exist in America. Health care would exist in America. Am I misunderstanding the dynamic?
Well, this is a single payer insurance plan so people would have access to a set of benefits and that would give them access to health care. I guess maybe I'm not understanding your question.
Well, let me go to one of our actuaries. The reason the trust fund is going to be insolvent isn't that we're planning to stop providing care to people. It's that we've pre-funded it through payroll taxes. There is no insurance out there. We just have a pot of money, and we're using that pot of money to pay for every claim that comes through the door. We're no longer insuring against risk. We're indemnifying folks with first dollar coverage.
You're talking about under Medicare for all.
Under Medicare today.
Right. I mean, you're basically providing first dollar provision of the entirety of people's health care. So, right, in a sense, you're not insuring them against the risk of a large future health expense or an unforeseen event, you're basically providing payment for every service, routine and large.
And I wasn't trying to wordsmith. I'm just saying there's a different set of challenges to fix the insurance system than to fix I'm sick and I can't get access to care system. I've not heard Mr. Navi care two hoots about solving problems for insurers. He wants to solve problems for patients, and it's a different challenge. Tell me from a financing perspective, I appreciated Mr. Morelli's questions. We serve on the Budget Committee together. We're not paying for the promises we make today. We're not paying for the wars we're in. We're not paying for the health care promises we make. I've got $3 trillion in revenue, $4.5 trillion in expenditures. I'm happy to spend my children's money, but apparently it's not important enough to me. I do think it should be important enough to us. This is an issue that's important to all of us. What's the order of magnitude that your numbers suggest we'd have to increase our individual citizen contribution to pay for Medicare for all?
Well, again, this is on the national level. We're talking somewhere between $32, $38 trillion in additional funds provided to the federal government. On a per capita basis, that's about $10,000 per head. Now, to your other point, we have a very substantial financing shortfall in our current Medicare system, and we have not figured out how we're going to finance that yet. That is a much more manageable problem than trying to finance what is called Medicare for All. It's actually sort of a national single-payer system that differs from Medicare in many ways. But that is several orders of magnitude more difficult than financing current Medicare, which we have not yet figured out how we're going to do.
That shortfall is not a Republican or Democratic shortfall. That's just an American shortfall. When you're talking about your numbers, these aren't Republican or Democratic numbers. There are conservative groups who are computing those scores and liberal groups computing the same order of magnitude?
The estimates are remarkably consistent regardless of who makes them. I provided a table with my written testimony that shows if you adjust for the years being estimated and particular assumptions for administrative costs or drug costs or provider payments, you can basically get a lot of these different estimates to line up, and they're pretty much all in the same ballpark.
I'm afraid I'm out of time. I'd welcome my chairman's indulgence, but in the absence of that.
No, but we let you go on for 2 minutes.
I thought I'd abused it already.
Yeah. Let me before I yield to Ms. Shalala, let me just say one thing. First of all, two things. First of all, Dr. Baker is going to have to leave at 3:10, so I don't know if there's anybody who has an urgent question for Dr. Baker, because he's going to have to leave. That's a hard stop. So thank you. Let me just say one other thing. You know, the idea of, you know, should we fix the Affordable Care Act or should we do Medicare for all or something more comprehensive? You know, I believe we can do great things here if we want to, right? We can walk and we can chew gum at the same time. And so you can, you know, I mean, if we have a fix ready to go tomorrow that will help help more people, we should just do it. That doesn't mean you can't do this. I mean, we ought to be able to go on both tracks. I mean, that's kind of, you know, I mean, I always refuse to believe that we are incapable of doing great things. And you look at our history, we have done. I mean, Medicare is a great thing, right? Social Security is a great thing. So it doesn't, I mean, we don't have to be picking and choosing. We ought to be doing both. And just to my colleague, Mr. Woodall, I think I know what he's trying to do. He's trying to get a soundbite out here to say that people are going to lose their health insurance. You know, to add to the...
Mr. Chairman, I don't believe you're suggesting that my goal here is to get a soundbite on an issue as important as this one.
Well, I mean, you know, well, I hope I'm wrong, but I mean, it just seems to me that, you know, the difference between, you know, getting provided, well, anyway, I shouldn't go down there. This is a mistake, so I won't do that. I'm just simply saying that I think what is motivating us here is the fact that the system we have right now is deeply flawed, and that we have 29 million Americans without insurance, over 40 million Americans underinsured. People are afraid to get sick. They're afraid to take their doctor's advice. There is something terribly wrong, and we need to fix it. And I know this is politically a hazardous topic to go down the road on, but we have to do it. And I believe that this is a political condition, what we're faced with right now, because we can fix this, and we have the resources to fix it. We have everything we need to fix it. It's whether we have the political will to fix it, and we'll see whether we do or not. I hope we do, and that's why I think we can do small fixes, and we can do a larger piece here. But anyway, let me yield to Ms. Shalala.
Thank you, Mr. Chairman. I actually think this has been a very smart hearing with very smart people and very good questions. So I want to thank all of my colleagues. The truth is if any of us had a chance to sit down and establish a healthcare system from scratch, none of us would have designed the system that we have. It's a system in which we've cobbled together over the last half century or so a number of programs to fill gaps. Some people may call them incremental, but I don't consider Medicare and Medicaid or the Children's Health Insurance Plan or the passage of Medicare Part D in the mid-2000s or the passage of the Affordable Care Act small steps. We Americans are not afraid of giant steps, and certainly Congress has demonstrated over and over again that they have the backbone to take on big problems, put their arms around it, and try to find a solution. In fact, that Affordable Care Act actually extended the Medicare, the HI fund by 8 years once we established it, because it offset a lot of costs that would have otherwise been there. I want to see more changes in the healthcare system. I want to get to the place where Adie's family does not have to pay $9,000 a month to allow him to live at home with his wife and child, and where patients are not walking out of Dr. Nafi's emergency room with treatable conditions. We need that kind of healthcare system. I'm for universal care. We have spent a lifetime filling in the blanks where the private sector couldn't fill in the blanks. Government has stepped up for working folks, for the poor, for senior citizens, time and time again. But now what we've got is a system in which we thought the employer-based system was going to be the core of healthcare forever in this country. We adopted it after World War II, the unions bought into it, but it's deteriorating. And anyone that has talked to employers or has looked at the statistics sees a deterioration of the employer-based system. I know that. I've been an employer. I've sat on corporate boards. CEOs are struggling with trying to predict their healthcare costs for the future. And what have they done? Most of us have shifted more costs to our employees, increased the deductibles. In fact, high deductibles have become the norm here in this country as we've tried to contain healthcare costs with very crude instruments. Throughout all of that, Medicare in many places, in many ways, has been a star because it's been better at reforming costs, at trying different kinds of reforms, but more importantly, from my point of view, at containing costs. But I'm perfectly willing to debate the cost issue and how we're going to pay for it. But we're here because the employee system is deteriorating in front of our eyes as our companies have changed and as we've moved to a gig economy, as we've gotten smaller and smaller companies, as they've lost their leverage, and because we want better outcomes, because we pay twice as much as anyone else in the world for our health care. I'm far more interested in focusing on outcomes and how we get to outcomes and how we get an integrated system. But I'm for universal care. I think Medicare for All is one way of getting there. And looking at the VA and its integrated care system, at TRICARE, at the military health care system, we got lots of experience. And I'm not afraid of transferring our system if that's what we decide to do, because we've got platforms. We've got lots of experience in taking large-scale problems and integrating them. And we've got lots of platforms. Medicare happens to be one of the platforms that we could do it. I could build the system. I don't think I could do it in 2 years, but certainly our experience in the public system of taking advantage of platforms and extending it to more and more people is certainly possible. Dr. Collins, I'd really like to start with you, though. I have some questions. Private insurers have been less effective at controlling costs than Medicare itself. In fact, private sector costs have gone up faster. You've talked about that a little bit, but you haven't explained the reasons for it. Is it because they're a smaller part of the market than Medicare is? Could you talk us through the reasons why the private sector, before we laud the private sector, let's talk a little about the deterioration as well as the failure of the private sector to be able to control costs themselves.
Great question. One of the main reasons that we're seeing the price increases that we're seeing across the country in private insurance is the fact that prices are set through private negotiations between providers, hospitals, and insurers. And so providers, particularly in concentrated markets, have a lot of leverage to increase prices.
This is the complaints that hospitals have they don't have enough docs to negotiate with, right?
Or
they don't have options.
Right, so they don't have enough. So insurers want a hospital in their networks because it makes their networks more valuable. So then that cost then gets shifted to the employers. So the employers have a higher premium than they might otherwise have, and they share those costs. They try to lower those costs, those premium costs, by increasing deductibles for employees. Employees are already making wage concessions, but they're having to have benefits with higher deductibles that actually give them less coverage. So that's really kind of a simple way of looking at how prices are determined and how that kind of filters through the system and hurts employees, particularly employees at the mid-range of the income distribution.
Dr. Blauhaus, do you have anything to add to that in terms of why the private sector has more trouble negotiating
I really
cost containment?
I'll be brutally honest, perhaps not that informative, but when I was doing the research for my paper, I found this area bewildering. I think Dr. Collins has a clearer view of the literature than I do, but obviously, I became informed in the course of the research of the paper about the discrepancies in payment rates between what Medicare pays and what the private sector pays, and I ran into a lot of conflicting explanations as to what was going on, why it was going on, and what would be the consequences of making various changes. I ultimately concluded that it would be a fool's errand on my part to venture too far into there and try to explain what was going on.
Mm-hmm.
So instead, I simply just flagged the issue. I noted where the payment rates are for private insurance relative to reported hospital costs, where Medicare's are. I flagged the issue, identified it, and noted some of the conflicting interpretations out there, but I fell well short of being able to explain it.
Do you, any of you, do you know very much about, I sat on the corporate boards, and one of the things that was apparent to me, particularly on healthcare boards, is that they're following the Medicare decisions on payment. That it's not the private sector setting up their own group to decide how much to pay. They're actually watching Medicare very carefully, and in many ways, Medicare is driving that cost. Is that your experience as well?
I'll just jump in really quickly, but I think it goes to Congressman Morelli's question about Medicare and how it could lead in innovation and payment, bundled payment, all kinds of different ways of lowering healthcare costs. So it has been a leader. The Medicaid program has been a leader in lowering healthcare costs. There's not a lot of fat in the Medicaid program or the Medicare program. In fact, what's really driving costs in both those programs is enrollment rather than prices in the commercial.
Do you know a way in which, without an integrated system, we can get better outcomes? Is there any experience in this country in getting better outcomes without an integrated system? It seems to me that the VA has better outcomes. TRICARE has struggled with outcomes, but have done a pretty good job, as has the military healthcare system.
But both of those are sort of integrated systems, so I don't think there's one that is not an integrated system. And I do want to add the comment in terms of the Medicare costs, particularly for Mr. Cole, when you set, and I'll just use the drive-by mastectomies that they had for a while, where patients had to stay in the hospital for a short time, get this procedure and go, so that you could lower the costs for those hospitals. The outcomes have been very different. They send patients home when they have congestive heart failure and some of those issues, and then the plans are penalized because it's within a certain time period, those patients are coming back to the hospital. It's really not a cost savings under that program. You have to, again, practice better health care if you're going to lower those costs, and that is an integrated system.
Yeah, there's no question that Medicare Advantage has provided some integration depending on the plan. And certainly in Florida, in my district, where over 60% are in Medicare Advantage plans, they feel like it, but we're paying more for it. We're walking in, we're paying at least 13% more for Medicare Advantage to get some integration, but it's still pretty fragmented when it comes to referrals for specialists. And that's, it seems to me, where the system breaks down, because Medicare Advantage, often the HMOs come together, but they're mostly providing primary care, and then they're contracting for the specialty care and contracting with as low cost as they possibly can for the specialty care. But I haven't seen the outcomes research on Medicare Advantage. Have any of you seen that outcomes research on Medicare Advantage? As far as I know, the research has not, even though we're paying more and people may be happier because they're going to one place, I would argue that Medicare Advantage is as close to Medicare as we're going to see, Medicare for all as we're going to see, but we don't know very much about the outcomes yet. And I assume that that is your experience as well. And finally, let me give Mr. Barkin a chance to talk a little about, again, about this fragmented healthcare system. How many interactions have you had to have with your private health insurance system in a month? Can you give us a feel for some of that?
Maybe 5 or 10.
You must be the best friend of your insurance company. These are all appeals, I assume, for them to cover more quickly?
I cost too much.
Mr. Barkin, of all of the people I've met on this earth, you are the last person I would use that for. Thank you.
Congresswoman, I want to say how important your voice is in this debate. As Chairman McGovern said, this is a question of political will. Many Democrats are going to follow your lead on this. So I just want to plead with you to summon all the courage you can and help lead our country to a more rational, just, and humane system.
Mr. Barkin, I'll try. I'll try. Thank you very much. I yield back my time.
Thank you very much. And we yield back to Mr. Cole. So are you divvying it up?
It's on to me. Thank you, Mr. Chairman. 1 second, please. You know, as I was, Mr. Chairman, as I was thinking about this, I thought of the different, like fire, police, teacher unions and associations that negotiate their health plans, and sometimes it takes them years to get what they want, and they often trade better health plans in lieu of higher wages or salaries and other things. And so, Ms. Turner, would this bill take away the current health care plans negotiated by, let's say, the teachers' unions?
Yes, it would. And I think one of the issues that would be on the table is, what about the compensation that they have foregone in order to get those benefits? I think that's going to be something that could be very, very disruptive, and that's something that would be a particular concern because they make considerable sacrifices in their take-home pay in order to get these generous health benefits.
Thank you, Ms. Turner. And members, I'm just actually a little surprised that some of my colleagues would you know, understanding that these different unions, fire, police, teachers, negotiate a lot, and I know they do because they came to me when I was in the state legislature. and take away that and replace it with a one-size-fits-all government-run plan. Thank you. And I yield back.
And if I could just acknowledge Congressman Chuy Garcia from Illinois, who is here, and we want to thank him for coming by. You'll thank Mr. Burgess, I think.
Thank you, Mr. Chairman. Director Whitehouse, let's talk just a little bit about global budgeting and what it means. So if you have a budget and you have more expenditures than your budget, what happens?
Well, then you're going to have to cut something. You have to cut the excess or restrict what you're paying.
So can you envision a system where that would perhaps result in the rationing of care?
Well, yes, and if I might elaborate a little bit.
Please.
There's been some discussion here about the effects of Medicare for All upon the demand for services. The economic literature is actually very, very clear and unanimous on this point. People do use or demand more health services when their insurance covers more. There was a very famous RAND insurance study several decades ago that demonstrated that when there's no cost sharing, people utilize more services. There was a more recent study by Cabral and Mahoney about what happens when Medicare beneficiaries carry Medigap insurance that has first dollar coverage. Costs of the benefits that they claim goes up by about 22%. So these are very real, very well documented effects. So we would expect to see a very significant increase above and beyond currently projected health services under Medicare for All. So I'm sorry, but just to quickly wrap up, when at the same time we're going to have various constraints upon supply because of the provider payment reductions, we don't know how those things will be balanced. The Urban Institute found there would be some insufficiency of supply to meet demand. I didn't have the ability to model that, but clearly something would have to give.
Something would have to give. I agree. And I'm going to assume that the Medicare supplementals have to go away under this bill that we're discussing today. I mean, because they'd be duplicative, and that would, by law, they would be unavailable to people. It was not clear what the punishment would be for violating the law. I get that. So, Ms. Turner, let me just ask you on the innovation side, new products, new drugs, new treatments, new devices come to market. I got to tell you, I mean, I deal a lot with people who are affected by coverage determinations by CMS. So what happens to a patient? Do they have to just wait till the next budget cycle if there is one of these new CAR-T therapies or new sickle cell therapy? They just have to wait till the next budget?
Well, that's what we see in Europe. We see that that access to the most innovative and oftentimes the most effective medicines are absolutely restricted. As I said earlier, we have access to about 96% of new medicines over the last 11 years in the United States. In France, they only have access to about half. In Singapore, only 18%. So they do provide chemotherapy, for example, but it is not likely to be the newest and best chemotherapy drugs. And then the innovation is crippled because, and we see in Europe that they used to have a robust pharmaceutical, medical development, medical device industry has shrunk because of payment policies in Europe. We are now the medicine chest for the world. Most new drugs come from the United States because we continue to pay for them. We pay for them for the globe, for the planet. People object to that. But those new medicines are available because of the incentives that the companies have to continue to produce those new medicines. And without that, I think we would find that we have nothing but old drugs and leaky hospitals.
Right, and of course, Cures the 21st Century Energy and Commerce product really moved the needle on that, and the Congress should be proud of that work. So, Ms. Turner, if current Medicare and hospital provider rates are mandatory rates set for all health services, that's going to have an impact on patient access, correct?
Actually, the CMS actuary said that when this was being considered earlier, it would cause many hospitals to either cut back dramatically on services, on operations, on services offered, and some would have to close. Physicians' offices many of them would go start operating in the red. So yes, they would have, this is not us. This is the CMS actuary looking at the impact. They simply couldn't keep their doors open.
True story, personal experience. If you're losing money on every patient, you can't make it up in volume. I learned that in the 1980s. So, Dr. Blauhaus, you've made some assumptions regarding provider cuts, is that correct?
Yes, well, I've examined what was in the text of the bill, yes.
So, someone asked a question about provider rates in other countries. Here's an op-ed from the New York Post, and I'm going to ask unanimous consent to put it in the record.
Without objection.
Enrique Padron. In Cuba, doctors make the equivalent of 25 cents an hour, teachers 21 cents an hour, and pharmacists 8 cents an hour, just for your reading pleasure. So, Ms. Turner, in the first quarter of last year alone, Britain's National Health Service canceled 25,000 surgeries. Is this a problem for a one-size-fits-all system?
It's a problem when you have a strict global budget and hospitals make decisions about canceling or delaying surgeries, and people are impacted. And once again, they get access to fewer of the new treatments. If you are in the private system, you do have access to more of the new treatments, better surgeons. If you're in the public system, you may not even know it, but you will have fewer options.
And I do have to bring up the issue of, we talked about this offline a little bit, of patient autonomy. I've got a paper, Mr. Chairman, I'd like to ask unanimous consent to put in the record.
Without
from the
objection.
Journal of Bioethical Inquiry, when doctors and parents don't agree, the story of Charlie Gard, the very sad story from the National Health Service, where the determination was made by the hospital not to acquiesce to the parents' request to bring that child to the United States, where they thought they had a treatment for his mitochondrial disorder, and I'd ask that to be made part of the record. So the 25,000 surgeries, is that isolated in government-run systems, or does that seem to be pervasive in government-run systems?
Well, there's no one government-run system, obviously, and some do better than others in being able to reduce wait times.
That's a great point. Wait, I've got to interrupt you there.
Yeah.
The director, at no thought for my personal safety, I attended the Commonwealth Fund's healthcare weekend. Thank you, Commonwealth Fund, for putting that on. I was the only Republican there. The director of the National Health Service was there. And he did point out to me that there is no single European health service. There's England, there's France, there's Germany. Canada, I believe, is structured provincially, the provinces run. So this thing that we're building, and with no cost-benefit analysis, with no double-blind controlled randomized study, no toxicity study, this thing that we're building no one has ever seen a system that is this big. Our Medicaid system currently is larger than the National Health Service, I believe. That is correct. But this Medicare for All bill that we have under consideration in the Speaker's Committee, the Speaker's desire to have this bill heard today, that is going to be gargantuan. Is that a fair statement?
A fair statement, and I do think you have to worry about centralized decisions over access to care. In the UK, just recently, a commission that helps determine benefits that are available decided that cataract surgery was not a high priority. And so cataract surgery was significantly limited. If you have cataracts and you can't see, that should not be an optional business. But when you have centralized government bureaucracies deciding what services are available, I just don't think that's something that Americans are going to tolerate.
So as a practical matter, and I don't understand from my reading of the bill, and I've read through it a couple of times, and it is a frightening bill to read for me, but if you can't get your cataract surgery, and there's an ophthalmologist down the street says, I'm doing these in my kitchen, what's to prevent that from happening? And what's to prevent a cottage industry of healthcare that then develops a black market of healthcare, if you will?
Or offshore, or Indian reservations. Native American reservations, I think, wind up being enclaves where you could actually get private care.
So, and the cataracts are an interesting case study because during the Bush administration, the variable lens that could be replaced during cataract surgery and do away with bifocals, Medicare said, hey, wait a minute, we don't pay for refractive services, so you only get a one-size lens. So Medicare patients were then was a pretty uncomfortable position for the Bush administration. We're going to deny the best treatment available to Medicare patients. And so they had to actually make a single, and I remember when Dr. McClellan did it, and I was jubilant. I thought, oh man, here's a balanced billing example that we can use. Patients were allowed to bring their own money to the transaction to get the state-of-the-art lens so they could read their Sunday paper without their readers. I mean, it was, I thought, going to herald a new era of insight in the Medicare system, but I was wrong. So, but I did repeal the SGR. Thank you very much for welcome. Thank you, Chairman. I'll yield back.
Okay, I want to, some other people I want to say, so I'll use remaining time. Let me just say one thing, a couple of things before I yield to Dr. Navi. I think who else wanted to, Dr. Collins, Dr. Brown too. I know, Dr. Burgess, you said you read the bill many times, and then you referred to the global budget, but the bill says, from the reading that I read, that there'll be a quarterly review of the global budget, so we can choose to make sure that there are enough funds if there's any problems. So it's not, I mean, that's actually written into the bill. And, you know, I know, I mean, people like to speak in alarmist terms. We talked about the Affordable Care Act. We talked about, my friends were talking about death panels. Well, that wasn't true. Wasn't true then, and it's not true now.
But, Mr. Chairman, we don't have a budget for this year. Where are we going to get this budget?
Yeah, thank you. And then you also raised the issue of the UK and Canada and said that they can't get the latest, greatest services. I'm not saying that we should be like the UK or Canada. I'd like to think we can do even better. But let me ask Dr. Collins just on this point. I mean, does that mean that the UK and Canada have worse outcomes than we do?
No, that's a really good point, and I was actually going to raise that. I mean, why is it then, if you paint such a gloomy picture was painted of the UK, where in fact their outcomes and those in other industrialized countries with universal health systems are actually better than ours with less money spent. I also think, Congressman Burgess, that at the conference, the director of the National Health Service did say that they were covering CAR T therapy, because they made a determination that it was highly effective as a curative, therapy, and so they made a decision to cover it. So there's a different metric that's applied, I think, than we often do.
I do relate to him that at MD Anderson Hospital in Houston, they've actually come up with a therapy that is as effective but much less expensive and can be administered as an outpatient without having to spend time in the ICU.
Okay, thank you, Dr.
I'd be happy to provide a paper for you.
Dr. Navi.
Dr. Burgess, I did just want to respectfully point out that if we're going to be talking about a hypothetical future where there might be rationing, we need to make sure we don't forget that we have rationing right here today. And it's not for the most expensive and the newest drugs, or not only for the most expensive and newest drugs, but patients that can't get antibiotics or antiplatelet medications. We have that rationing right here today. And in regards to we'd be the first country doing something like this, that's kind of what America's good at, to do things that no one else has done before.
Dr. Brown.
Thank you. And Mr. Burgess, just wanting to add to the point that we're really not talking about one size fits all, because we're talking about a universal coverage, but we've moved into precision medicine where we're trying to give the therapy that is specific for those individuals. And when we take in the social determinants that are very important for those individuals, we know the kind of care. And so it's equity that we're talking about, not equality.
And I know Ms. Lesko left, but someone just showed me a report that appeared in the Hill magazine because she was curious about whether other committees would be doing hearings, and it says in that report that the Ways and Means Committee will do a hearing on this very bill, so she doesn't have to worry that we'll be the only one. I now yield to Mr. Desaigner.
Thank you, Mr. Chairman. You're almost done. If you're down this end of the podium, the panel, I should say, you're almost done. But I want to thank you all for your patience, your ability to articulate your thoughts and your professional experience. And I obviously want to thank Mr. Barkin for your tenacity and your being here and your good demeanor in spite of difficult personal odds. So thank you all for being here. I'm a little bit flummoxed, not unlike the hearing yesterday, with all due respect to my colleagues. The United States is #1 in cost as a percentage of GDP and as a cost per capita, almost twice other developed countries per capita for cost of health care, but our outcomes are the opposite of what you would expect. 28th in life in mortality, I think close to 30th in infant mortality. So for me, it just strikes me, not unlike the conversation yesterday about the energy economy and the environment, is that we're arguing about status quo versus a world that's already changing, and how are we going to adjust to that? I'm a co-author of the bill. I appreciate the author. And I think this is a discussion we have to have. As a former small business person, I remember owning restaurants, and fortunately where I live in the Bay Area, Kaiser in the East Bay is very dominant. It started in the East Bay, so the closed system in Kaiser is over half the population of the 2 counties where I live. That's about 3.5 million people, and they've been able in that closed system to provide a pretty good quality of care versus cost. But when I started in the restaurant business 30 years ago, I could pay easily for Kaiser and pay a portion, and then after someone worked for me for 6 months in full. But then towards the end, I had employees coming to me in tears, one manager in particular, where she couldn't pay the copay. So I came out of pocket as an employer, which goes to the statistics about, which Ms. Shalala talked about a little bit, is about the number of employers, I should say, paying 100% or any portion. And I don't know what the numbers are for small businesses, but I would imagine it's pretty staggering with small businesses and the cost of staying in business just not being able to pay at all. My memory from reading is in 2000 or 2001, almost 30% of employers paid 100% of their health care costs. 4 years later, it had dropped by 10%. It's kept going down. So this model, to me, clearly doesn't work. So it's a question of what we're going to do about it. Like Mr. Raskin, I'm a survivor of cancer. 4 years ago, I was diagnosed with stage 4 chronic lymphocytic leukemia. I took a pill 35 minutes ago that keeps me alive that costs $400. Senator Durbin said to me recently, because he knows of my health channels, he says, how's your health? I said, fine, Dick. I have a pill in my pocket that I take every day, and it keeps me alive. And he goes, how much does it cost? I said, $400. He said, that's outrageous. I said, not to me. It keeps me alive. My oncologist said 15 years ago, Mark, somebody would come in with the same diagnosis, and we would sprinkle some water on your forehead and say, good luck. Now the life expectancy is 85%. If you can get through the first 5 years, and I'm almost there. And a lot of this, as I've become familiar with it and gone out to NIH, actually was developed with taxpayer dollars. A doctor who worked for the Army for years and is now at Ohio State, that Dr. Moynihan was nice enough to put me, was the key person. And most of his research was taxpayer funded. Much of the deployment, I went over to NIH and met with these young people making $60,000, $65,000 a year that went to Hopkins and Stanford and Harvard, and they're working at NIH because that's what they want to do. So one of the things is, to me, is apples and oranges, counting this right. And I'm sorry that one of the panelists had to leave because this was directed at him, but I want to direct it at Dr. Navi because I'll lead into this, is what are the real costs to the average consumer and then macroly. So if we know those numbers about individual costs and outcomes and the GDP, it's a huge disadvantage to us because if we weren't at 18% and if we were like the Japanese at 12% with better outcomes, all that money could be going to more productive uses. Not that healthcare and staying, keeping people alive, coming from me, isn't important, but we could be prioritizing. So the reason why I've been able to afford this, and there's an interesting story in the Wall Street Journal that I'd ask everyone to read about people who are wealthy with my condition and having a challenge paying for what they're paying for on private care, health insurance. I was lucky enough to get elected to be a county supervisor. I chose to take my health care through what was the first county public option in the United States when the Contra Costa Health Plan was approved, the HMO. And they paid, I'm here alive today because of that. If not, if I had stayed a restaurant owner, I would have made a lot more money. But now when I look back in hindsight, if I was paying for Kaiser, Blue Cross, Blue Shield, I wouldn't have nearly the service versus what the out-of-pocket costs would be. So Dr. Navi, I'm going to have an example from my experience as an elected official. In California, we delegate public health and delivery of services to the urban counties. Contra Costa, where I governed, was. Our biggest challenge, whether it's Los Angeles or all the urban counties, is the cost of the clinics and hospitals who do most of the indigent care. So one of the things we did when we rebuilt our county hospital, I was a swing vote, and LA at the time, their general fund contributions with 5 hospitals and with an increasing indigent care population was up to 23, 24%. Ours was going in the same direction. So we've tried in California to help the counties and say, you've got to cap your costs, be more efficient. My point is, when we get down to 10%, that extra 15% we spend on libraries, the sheriff's department, economic development. So that's sort of the color of money. In your experience as a point of sale person in different emergency rooms, you see people coming in the door, but their costs are all absorbed differently, but the consequences for who pays and subsidizes those costs are also different. Could you speak to that on a personal level, and then I'd ask Ms. Collins to also talk to that?
Sure. I think that if you go to different hospitals, people will be paying differently. And the interesting thing about New York is that we have a lot of hospitals that are right next door to each other that accept different types of insurance and different types of payments. So there's 2 hospitals that I work at that are right next door to each other. If someone comes in and they have insurance, they'll be taken care of. And if they don't, they often get referred next door to the public hospital where they will end up receiving care, and then that hospital does not get reimbursed for it. And then that contributes to the challenges of that hospital not having enough money, and it creates this cycle. I think one of the good things about Medicare for All is that in those hospitals that primarily serve the indigent population, they'll be able to make more money because they'll be reimbursed higher than Medicaid payments, and no one effectively will be uninsured. Every patient will be a paying patient.
Before we leave you, this is another, so the behavioral health costs. In Los Angeles, we see where they've been pushed out of the hospital. I know in my county, we always looked at, I was on joint conference committee, we'd look at indigent care in the psych ward, and we were stabilizing them and pushing them out, but they would go into the emergency room first. But I think the statistic on people who commit suicide, 60% of them go to see a primary care physician within 60 days. So that's another aspect I don't think we're talking about, is we understand the neuroscience and the amazing research we're having on helping on behavioral health, but then the acuity of people who are going through the current system for medical conditions and then accruing greater liabilities, both real and financial on that side. And you saw that, I assume, in your experience.
Yes, I do. And the people that end up in the ER that can't be reimbursed, we end up all paying for that. I'm not sure if that answers your question.
Yeah, it does. Ms. Collins?
Yeah, I just think on the benefits, the way we're designing benefits and the way employers are being forced to grapple with their higher costs are giving patients incentives or people incentives that it goes against their own health interests. So people are making decisions based on their deductibles about whether or not to fill a prescription, whether or not to keep their, to skip doses of the prescriptions because they're afraid of the cost. And it just really does run counter to how we'd like people to think about their health care and getting better.
And I don't know if others have had this experience, but I know the Rotary clubs in my area take me out to their clinics where they have pro bono physicians and others who come, and especially in the disadvantaged communities, most of them who come to those Rotary clinics once a month, they won't go to the county hospital. They won't go because they're afraid of the cost, and they're afraid. And some of it, I'm sure, is part of white smock disease. Dr. Burgess would remember that. I have that. My blood pressure is usually off. I don't know why I don't trust doctors, doctor, but I do now because they've kept me alive. But the Rotary care stuff is really fascinating because people will go to their Rotary clinics, and it's the same doctor, but the environment's different. I guess I'm really appreciative. I didn't fully anticipate this hearing. I think it was good and constructive and largely positive. I hope that we go on from here, and I think the genesis of this in the bill, I remember it was Madison who said, not that this is going to happen, he said just because a member of Congress doesn't think their bill will happen immediately shouldn't inhibit them from introducing it. And I think this is, at the very least, restarted an important conversation in this country. So with that, Mr. Barkin, do you have anything to add to whatever's left of my 15 minutes? Or is Mr. McGovern going to take it all?
No. Yeah, you have your...
Just as long as it's not Ed.
Thank you so much to members of this committee for having me. This has not been an easy trip to make, and it's a big risk for me. But I came here today because this is one of the most pressing crises facing our society. Every day, I feel the weight of the moment. Every moment feels urgent, and I feel acutely my time running out. I hope that sense of urgency is pressed on everyone here, as we think about how to build a more fair and just society for all. We are at a crossroads, as a nation. We can either become a society where care is rationed to those only with immense means to pay the most exorbitant, exploitative health care bills imaginable. Or, we can transform our society, alleviate families of the enormous financial burdens that come with a for-profit health care system, and live with more dignity and joy. I sit before you today hopeful, because I believe we will make the right choice. I believe the number of people demanding justice across the country will only grow, and I believe that we will win. Thank you again for having me.
It was all our pleasure. Thank you for being here.
So I think everybody has asked their questions. So at this point, I will yield to Mr. Cole for his closing remarks, and then I'll make closing remarks, and then we will let you all go home. Thank you.
Well, I want to begin, Mr. Chairman, by thanking you. I want to thank you for the manner in which you've conducted the hearing. Everybody, you've been exceptionally generous with the time and kept us focused and very civil. So you can be very proud of your performance here, and we're all very proud of you. And I want to thank all of our witnesses as well. Each of you have brought insight, knowledge, professionalism. You've all contributed to helping us grapple with what's, a challenge at the societal level. And obviously, we heard a great deal today about the majority's highest priority in Congress, which is, in my view, putting everyone in a one-size-fits-all government-run health plan that will double everybody's taxes, eliminate choice, and put Medicare at risk. It'll take plans away from 173 million Americans and give them something they may or may not want and something they may or may not be willing to pay for. As we heard from Dr. Blayhouse, Medicare for All would cost a staggering amount, more than $32 trillion over 10 years. It's worth thinking about that. The current federal budget annually is about $4.5 trillion. This would make it immediately $7.7 trillion. The legislation has not proposed any way to pay for that. But Dr. Blayhouse told us that even if you doubled everybody's taxes, doubled the corporate tax rate, still wouldn't cover these costs. And as my friend Mr. Woodall pointed out, we're not paying for all the health care we're getting now. We're putting an awful lot of it on the national credit card. Dr. Baker offered up several ways to pay for this in his testimony, but many of those involve what euphemistically are called input costs, or what everybody in the healthcare industry would call more than a 40% cut in their compensation. I can't imagine that an entire industry would accept that level of reduction. And I would also note that such cuts would put everybody's health care at risk. Indeed, Ms. Turner testified that many hospitals would simply close if they had to take 40% pay cuts, as envisioned in this bill. If such cuts become law, the Medicare for All truly would become nothing more than a program that provided minimal care in exchange for astronomically high taxes and much longer wait times. Most disturbingly to me, I think today's hearing made clear that the Medicare for All would put the current Medicare system at risk. We force doctors and hospitals to take lower payments. We run the risk of pushing them out of the industry entirely, thus making it impossible for current Medicare beneficiaries who've paid into this program for a lifetime to receive health care. In my home district, rural hospitals rely on higher reimbursement rates from private insurance to offset the lower reimbursement rates from Medicare patients. If these hospitals were to only be reimbursed at Medicare rates, most of them, quite frankly, would close. If nothing else, today's hearing shows that the committees of jurisdiction need to consider this bill as well, and I'm proud that you have both called on that, Mr. Chairman, and announced that at least one of those are going to take it up. I particularly hope my friend Mr. Burgess gets another crack at this, and the Energy and Commerce Subcommittee, and certainly our committee, and the Ways and Means Committee, and the Education Committee and Labor Committee as well. All of them, frankly, have significantly more jurisdiction in this area than we have here. And to be uncharacteristically humble for our committee and ourselves, they probably have more expertise than we have here, because they have both the staff and they. I'll let you argue that with Mr. Neal and his counterparts. So you guys can work, and Mr. Pallone, because frankly they do. I mean, they just focus on these things. I guess what? I probably know more on Indian health and some of these things because I focus more on it. We don't have hearings up here. This is an unusual moment for us and a good one. I'm not complaining about that, but I'm glad you're going to have the opportunity for these issues to be discussed in front of committees of jurisdiction. Though I think the Democratic Medicare for All proposal is an extreme one. I'd remind the majority that Republicans are, as Ms. Lesko said, committed to working together to improve the system we currently have and to build on and improve what works and ensure that every American gets the quality of care that they deserve. And while it's always fashionable to want to do a once and for all total comprehensive bill, we went through that with the ACA. And with all due respects to my friends, I heard phrases like, keep the doctor, if you like the doctor you have, you can keep him. You like the plan you have, you can keep it. And, finally, your insurance payments are going to decline by $2,500. None of those things happen. So count me as skeptical that a new one-size-fits-all system will achieve the objectives that its advocates hope, have laid out with such hope, such optimism and such hope. And, again, it's worth discussing for sure. I would hope in the meantime, though, we do what everybody here agreed we ought to do, in addition to looking at this, which I have no objection to, that we actually focus on smaller steps that we know can become law, that we know can actually happen. And I look forward to working with my good friends on the other side of the aisle, certainly with you, Mr. Chairman, to make sure that we can do something that matters in the weeks and months ahead and makes a big difference. And so with that, Mr. Chairman, again, thank you for the hearing. Thank you for the manner in which it's been conducted. I yield back my time.
Well, thank you. And let me also thank my ranking member, Mr. Cole, for his participation in this hearing and for his courtesies and for his questions, quite frankly. And I want to thank my Republican colleagues as well. I don't agree with you on a lot of what you said, but I appreciate that this was this hearing, which is on a serious topic, was treated in a very serious manner. And I was recounting to some of you that some members of the press and some colleagues who have been watching this on C-SPAN are kind of surprised that this has been such a civilized and in-depth hearing, and some of those people are on the committees of jurisdiction. And so I will tell Mr. Neal that, who's the chair of the Ways and Means Committee, the second oldest committee in the Congress, we're the oldest, that he should follow our example. And I want to thank the staff on the majority and the minority side as well for all their work in this. And I want to thank Congresswoman Jayapal's staff and Congresswoman Dingell's staff and Senator Sanders' staff and others who have been very helpful in working with us on what this hearing should look like. I want to thank the panelists. You've been here since 10 o'clock this morning and nonstop with a short break. And I think everybody here was excellent. And we may have some differences of opinion, but I think everybody did an excellent job. So I want to thank, again, all of our witnesses for their time today. So as this hearing comes to a close, let's remember why we're all here. We're here because 29 million Americans are still without health coverage. 44 million people are underinsured, and many more are paying ridiculous out-of-pocket costs for health care that just isn't there when they need it the most. There's no health care system like what we have in America. And I don't mean that necessarily positively. People are forced to go without care. Those with coverage have to wonder whether their insurance provider will play games with their coverage when they need it most. And all of us up here know exactly what I'm talking about because that's the kind of casework we do each and every day. What we have shown today, I believe, is that Medicare for all is possible. that we can build on the principles of the Affordable Care Act to make even bolder reforms, reforms that would give doctors like Dr. Brown and Dr. Navi the ability to treat patients and give them the best care every time without letting costs dictate medical decisions, that we can treat patients like Adi Barkan with the dignity that they deserve without forcing them to battle with insurance companies. If you walk away with nothing else today, know that we have the ability to do that. Medicare for all is possible. It is reasonable. It can move forward, and I think it should. I'm proud to support this bill and to work with Congresswoman Jayapal and Dingell and many others who have been championing it. And by the way, that includes not just its supporters here in Congress, but many advocates, the doctors, the nurses, the patient advocates, consumers, and more all across the country who have worked tirelessly to make this historic day a reality. It's been a long time coming, and it's the result of all the letters and the calls and the emails and advocating that has been going on for a very, very long time. I believe in people power. I mean, I got to be honest with you. I don't think we'd be talking about any of this if our constituents weren't raising their voices. I'm proud to stand with you and fight alongside of you for Medicare for all. And this is just the first phase of the conversation, and I look forward to continuing this dialogue with all of you. And again, I just wanted to say to Adi, I love this picture. And I look at your wife, Rachel, and your son, Carl, and I can't help but believe how proud they all are of you. And I've been watching your dad, who's sitting behind you, and I can see how proud he is of your courage and your commitment to being here. This is a big deal. And your presence here is making a huge difference. I just want you to know that, we can do great things. I mean, we really can. But it means we have to stand up to the naysayers who tell us, no, you got to think small. We need to think we need to think bigger than tweets, right? We need to think in terms of, how we impact the lives of millions of people in this country who are struggling every day, wondering whether or not they're going to go bankrupt because they're sick or their kids are sick. It just shouldn't be. As everybody has said on all sides, I mean, we can do better. We have to do better. And so I, again, want to thank everybody for being here today. This is the first step. It's a big step, but we're on our way. So thank you, and the Rules Committee is adjourned.
What